Good morning, distinguished delegates. I would kindly ask you to take your places. I hope you are all well today. We will now resume the work of Committee A. Distinguished delegates, before we start our discussion this morning, I have an important announcement to make concerning our program of work today. This morning, we've met with the President of the Health Assembly and the Chair of Committee B in view of the number of agenda items still to be opened by our committee. It was decided to transfer agenda item 15, namely review of an update on matters considered by the Executive Board under Promote Health, from our committee to Committee B. So, please I would like to repeat it again. It was decided to transfer agenda item 15, review of an update on matters considered by the Executive Board under Promote Health, from Committee A to Committee B. The sub-item concerned 15.1, strengthening reputation in health systems, 15.2, well-being and health promotion, 15.3, the health of indigenous people, 15.4, maternal, infant, and young child nutrition, and 15.5, draft strategy on the economic of health for all. If you have any questions, you may ask now. I think no questions. I believe it is clear.
There is a question from
Okay. We have one state member asking the floor. Malt. We have some technical issue. If IT people would come here and help us. Okay. Malta, the floor is yours.
Hi, just to confirm the timing for these agenda items, if we have any indication.
Right now, Committee B is working on item number 20. Just after when they finish the item number 20, they will start either in this morning session or afternoon session. We will update you as soon as we get more information from the Committee B. Okay, let's resume. Distinguished delegates, before we start our discussion this morning, I would like us to adopt the draft of the third report of Committee A I therefore give the floor to our rapporteur, Mr. Basimwa, who will read the report in question. Mr. Basimwa, you have the floor.
Thank you, Chair. Committee A held its 6th, 7th, 8th meetings on 21st May 2026, chaired by Dr. Timur Sultan Gaziev of Kazakhstan, Mr. Fernando Israel Espinoza Olvera of Mexico. It was decided to recommend to the 79th World Health Assembly the adoption of the attached 3 resolutions and 2 decisions relating to the following agenda items. Provide health. 12. Review of and update on matters considered by the Executive Board. 12.3. Communicable diseases. NTB strategy. 1 decision. 12.1. Follow up to the political declaration of the high-level meeting of the General Assembly on prevention and control of non-communicable diseases. 1 resolution entitled Steatotic Liver Disease, a missing piece in the global non-communicable disease response. 1 decision entitled Follow up to the political declaration of the 4th high-level meeting of the General Assembly on the prevention and control of non-communicable diseases and the promotion of mental health and well-being. 1 resolution entitled Global Action to Advance Health Equity for People with Hemophilia and Other Bleeding Disorders. Protect Health. 14. Review of and update on matters considered by the Executive Board. 14.5. Public health implications of the unprovoked attacks by the Islamic Republic of Iran on civilians and essential civilian infrastructure in Bahrain, Kuwait, Oman, Qatar, Saudi Arabia, the United Arab Emirates, and Jordan. 1 resolution entitled Public Health Implications of the Unprovoked Attacks by the Islamic Republic of Iran on civilians and essential civilian infrastructure in Gulf Cooperation Council countries and Jordan. Thank you, Chair.
Thank you, Mr. Basimwa. I understand the committee is willing to adopt this report as read out. Are there any objections? I see none. The report is adopted. We will now reopen the agenda sub-item 12.4, Universal Health Coverage. Under Provide Health, this sub-item contains 3 bullet points as follows. Draft Global Strategy for Integrated Emergency, Critical and Operative Care, 2026-2035. Increasing availability, ethical access and oversight of transplantation of human cells, tissues and organs, and rare diseases, a global health priority for equity and inclusion. The relevant document is A79/5. When we suspended our discussion yesterday evening, several delegates requested the floor. Would those delegates still wishing to speak, please press the microphone button now. The microphone will open automatically when I call your delegation to take the floor. There is no need to touch the microphone button again, as this will remove you from the speakers list. The first, I give the floor to Togo, followed by Ukraine.
Thank you, Chair. Togo has the honor to make the statement. on behalf of 47 member states of the Africa region. The Africa region congratulates the Secretariat for drafting the draft global strategy for integrated emergency critical and operative care 2026-2035. It is a universal strategic approach that makes it possible to plan and coordinate services, including readaptation and palliative care interventions, in order to respond to the needs throughout their life. The African region of WHO welcomes the WHO certification of the first medical emergency team in Senegal regarding the availability of transplantation of human cells and tissues. We welcome the progress made by the Secretariat in drafting the global strategy on the donation and transportation, and in particular the setting up of the expert committee and the drafting of the strategy. Regarding rare diseases, we commend the Secretariat for the preparatory work, in particular the surveying of the number of institutions and the drafting of technical reports. Despite these measures, there are a number of challenges that could serve as a stumbling block to the implementation of the expected results. These include a low level of organ donation, adaptation of legislative frameworks, and governance, funding, and staff regulations in countries. There are several gaps in terms of data that limit the drafting and monitoring of policies based on evidence. In view of the above challenges, the Africa region invites the Secretariat to advocate for the swift taking into account of resources and various modalities for the gradual and adapted interpretation of in the global strategy, integrating obstetric and surgical care in primary health care by strengthening health services, intensify and appeal for robust legislative frameworks to prevent trafficking of organs and protect donors and those who and beneficiaries, to promote regional and sub-regional cooperation, sharing of knowledge, and cross-border transfer if need be. Drafting action plan for strategy of integrated care by member states in order to facilitate its ownership and implementation. The Africa region takes note of the report.
Please, honorable delegates, be aware of time limit. I now give the floor to Ukraine, followed by United Arab Emirates.
Thank you, Mr. Chair. Ukraine thanks the Secretariat for the reports and supports universal health coverage as the foundation of resilient health systems. Regarding the draft global strategy for integrated emergency, critical and operative care, Ukraine's experience during Russia's ongoing aggression shows that critical care must function as continuum, from pre-hospital response to surgery and rehabilitation. We support strengthening workforce capacity, referral systems, and digital tools, especially in conflict-affected settings. On transplantation, Ukraine believes that addressing unethical practices require tackling the global shortage of organ tissues and cells. Alongside stronger oversight, we need practical measures to expand donor programs and improve equitable access. Regarding rare diseases, Ukraine stresses that equity must become a practical reality. Many countries still face limited access to diagnostics and treatment due to weak procurement capacity and extremely high prices for orphan medicines. We support stronger international cooperation and practical access mechanisms. Finally, Ukraine fully supports strengthening primary health care, including the integration of mental health rehabilitation and digital solutions, as well as task-sharing approaches to address workforce shortages. I thank you.
I thank Ukraine and invite United Arab Emirates, followed by Egypt.
Thank you, Mr. Chair. Emirates welcomes the Global Strategy for Integrated Emergency, Critical and Operative Care 2026-2035 as a vital step toward strengthening the universal health coverage and health security. Building on our national experience and expanding emergency capacity, workforce planning, and service readiness, the United Arab Emirates supports global efforts to advance governance, sustainable financing, and integrated service delivery. We call for operational guidance to support member states in implementation. The UAE also recognizes the importance of ethical, equitable organ transplantation systems with strong regulatory frameworks and international cooperation. Our national program, Hayat, reflects this commitment. Finally, the UAE recognizes rare diseases as a health equity priority, supporting early detection, genomic medicine, and equitable access to diagnostics and therapies. The UAE remains committed to collaboration, innovation, and leaving no person behind. Thank you.
I thank United Arab Emirates. The floor is now given to Egypt, followed by Bahamas.
Mr. Chair, Egypt takes the floor under this agenda item to reaffirm its unwavering commitment to universal health coverage, a cornerstone of sustainable development and social justice. Universal health coverage is not only a health objective, it's a commitment to ensuring that every individual can access quality healthcare services without financial hardship. Guided by this principle, Egypt continues to advance its universal health insurance system by expanding comprehensive, equitable healthcare services across all governorates, and by strengthening primary health care as the foundation of resilient health systems. Mr. Chair, Egypt is honored to have led, alongside a broad coalition of member states, the presentation of 4 resolutions under this agenda item, and extends sincere appreciation to all co-sponsoring countries for their constructive engagement and support. On stroke prevention and management, Egypt stresses the urgency of integrated national responses to strengthen prevention, early detection, acute care, rehabilitation, and long-term support, particularly in low and middle-income countries, where the burden count continues to rise. In teleradiology, Egypt believes that digital health solutions can help bridge critical workforce gaps and improve access to specialized care, particularly in underserved settings, by enhancing capacity building and South-South cooperation. On pharmacovigilance, Egypt underscores the importance of strengthening national systems for medication safety monitoring as an essential pillar of patient safety, resilient health systems, and public trust. And finally, on precision medicine, Egypt emphasizes that scientific innovation, including genomics and AI-driven diagnostics, must remain accessible and affordable to all, so that it becomes a tool for equity rather than a source of widening disparities. Egypt calls on all member states to support the adoption and effective implementation of these resolutions to accelerate progress towards equitable and resilient universal health coverage for all. I thank you, Mr. Chair.
Thank you, Egypt. I now give the floor to Bahamas, followed by Fiji.
Thank you, Chair. The Bahamas supports the position of the WHO on the importance of universal health coverage, including the promotion of equity and inclusion in addressing rare diseases, emergency critical and operative care, and increasing availability, ethical access, and oversight of transplantation of human cells, tissues, and organs, all undergirded by precision medicine as a critical component. We recognize the importance of improving early and advanced diagnosis, access to treatment, strengthening international collaboration, research and data systems, specialist services, and continuity of care to ensure rare diseases are appropriately integrated into health systems. Advancing equity for persons living with rare diseases requires strong national commitment and continued international collaboration, technical cooperation, and knowledge sharing among member states. The Bahamas remains committed to advancing integrated, resilient, and people-centered ECO systems and supports continued global cooperation to accelerate progress towards UHC and improved health outcomes by 2035. We continue to prioritize integrated, resilient ECO systems as evidenced by recent national investments, including the opening of the renovated emergency department at the major tertiary institution and expanded diagnostic services at the primary care level level in the Family Islands in northern Bahamas, where a new facility is under development. With regard to human tissue, cell, and organ transplantation, the Bahamas has established a renal transplant program, and a transplant ethics committee supporting policy and legislation are underway. We remain committed to ensuring that all procedures are in adherence with national laws and international ethical guidelines. We call upon WHO and international partners to continue supporting SIDS through technical cooperation and skills transfer. Thank you.
Thank you, Bahamas. The floor is now given to Fiji, followed by Japan.
Chair, Fiji reaffirms its unwavering commitment to universal health coverage, ensuring that every Fijian, particularly the poor, vulnerable, and those in remote maritime communities, has access to quality, affordable, and people-centered health services. We remain steadfast in protecting our population from financial hardship by maintaining out-of-pocket health expenditure below 20% of total health spending. For Fiji, healthcare must never become a privilege reserved for those who can afford it. In alignment with Executive Board recommendations, Fiji is accelerating the modernization of our health system through digital transformation and innovation. We are integrating precision medicine and genomics into our national universal health coverage agenda while rapidly expanding teleradiology services across the country. Digital X-ray system, which embedded artificial intelligence, are now being deployed nationwide to improve diagnostic speed, accuracy, and equitable access to healthcare. Further, our Medicine Regulatory Authority has launched a Fiji mobile application, strengthening real-time pharmacovigilance and reinforcing patient safety through smarter digital reporting system. Chair, Fiji also welcomed the renewed global focus on stroke care. Particularly, stroke remains a major contributor to our national NCD burden. Fiji has progressively strengthened stroke services through establishment of our mobile stroke inpatient in 2014, the hospital in-house initiative in 2019, and the rollout of free stroke. Chair, Fiji remains resolute in building a resilient, equitable, and future-ready health system that leaves no citizen behind. Thank you.
Thank you, Fiji. The floor is now given to Japan, followed by Zambia.
Thank you, Chair. Japan welcomes the report and appreciates the comprehensive approach articulated in the draft Global Strategy for Integrated Emergency Critical and Operative Care 2026-35, as well as the report on transplantation and rare diseases. These three areas are essential domains that must be integrated to advance universal health coverage to ensure equitable access to safe, effective, quality, and affordable care for all. Emergency, critical, and operative care form one of the central components of resilient health systems. They guarantee continuity of essential services not only in normal settings, but also during emergencies. In the fields of rare diseases and transplantation, equity cannot be achieved by market forces alone. Public sector leadership in collaboration with private sectors through adequate financing, regulation, and governance is important to ensure timely diagnosis, safe transplantation pathways, and inclusive access to life-saving interventions. To deliver on these ambitions, we reaffirm that achieving UHC is fundamental. Japan has a long championed UHC based on the principle of the human security. In this regard, to support developing countries in strengthening health financing and policy implementation, Japan is supporting the UHC Knowledge Hub launched by WHO, the World Bank, and recently hosted the UHC High-Level Forum in December last year with the participation of high-level representatives from many countries and relevant organizations. Japan will continue to work closely with the international community to build more resilient, more equitable, and more sustainable health system, thereby leaving no one behind under UHC. Thank you.
I thank the delegate from Japan. I now give the floor to Zambia, followed by Egypt, who will be giving the group statement.
Honorable Chair, thank you. Zambia reaffirms its commitment to universal health coverage, recognizing emergency, critical, and operative care as a continuum of essential services fundamental to resilient health systems and effective response to public health emergencies. Our recent experiences, including the 2023-2025 cholera outbreak, the ongoing mpox response, and climate-related flooding have demonstrated that strong, integrated emergency care systems are indispensable for saving lives and maintaining continuation of essential services. In response, Zambia has strengthened case management, established treatment centers, and scaled up clinical capacity to manage surges in demand. Financing universal health coverage remains a key constraint. While the National Health Insurance Scheme is a major step forward, it is still evolving, with gaps in coverage and sustainability. In particular, ensuring equitable and sustainable financing for vulnerable population, including the elderly and those in the informal sector. Zambia is addressing these challenges by strengthening primary healthcare systems, integrating emergency preparedness into health service delivery, and embedding emergency care within universal health coverage packages. We call for sustained WHO and global support to strengthen integrated emergency critical and operative care systems, including investment in workforce, infrastructure, and data systems for decision-making. I thank you.
Thank you, Zambia. I now give the floor to Egypt, followed by Netherlands.
Distinguished Chair, honorable delegates, Egypt has the honor to deliver this statement on behalf of the 41 member states that co-sponsored the landmark resolution on rare diseases. 1 year ago, this assembly took a historic step by adopting the first ever resolution on rare diseases. We moved beyond policy, we committed to the visibility, dignity, and equity of millions living with rare conditions worldwide. We welcome the Secretariat's progress report. We commend the initial work on global standards, disease burden analysis, and the mapping of regional centers of excellence. However, we must be clear-eyed. For most patients, particularly in low and middle-income countries, the reality remains one of delayed diagnosis, limited treatment, and persistent inequity. Commitment is no longer sufficient. We must move to implementation. We emphasize the urgency of developing the WHO Global Action Plan on Rare Diseases for the 21st WHA. This framework must be practical and inclusive, anchored in universal health coverage, transformative, focused on early diagnosis, equitable access to medicine, and robust data surveillance, collaborative, strengthening cross-border cooperation, and sustainable financing. We must move away from fragmented approaches. Rare diseases must be fully integrated into a resilient health system. As co-sponsoring member states, we reaffirm our unwavering commitment to support the Secretariat in shaping this action plan. Let us ensure that promise made 1 year ago translates into tangible progress for every patient, in every region, without exception. Advancing this agenda is a profound test of our collective commitment to the right to health for all. Thank you.
Thank you, Egypt. I now give the floor to Netherlands, followed by Qatar.
Honorable Chair, distinguished delegates, my name is Anne Geitenbeek, and I stand before you as youth advocate, young woman, and soon-to-be medical doctor. I want to introduce you to a patient I met during my clinical internships. She was a 16-year-old pregnant girl with no partner, no stable income, and no secure housing. She asked us to terminate her pregnancy. Since I was young, I've dreamed of becoming a mother. She showed me how that dream is shaped by privilege, shaped by the autonomy I have over my body, shaped by the access I have to reproductive health care and abortion, and shaped to the resources to care for a child. Across the world, discrimination and neocolonial legacies drive inequalities, disproportionately affecting women and girls, restricting their sexual and reproductive health and rights. I call for action on behalf of the 164 million women with unmet family planning needs and the 25 million women who undergo unsafe abortion each year. I want to amplify the voices that are overlooked, silent, or denied respect. Voices that I'm missing on this stage. I urge all nations to first integrate SRHR into healthcare systems to guarantee informed choice, bodily autonomy, and access to abortion. And second, to build equitable systems with community-led solutions that ensure SRHR. The girl should have had a right to choose. She did not. and so do millions like her. Since I met her, I have a new dream. A world where everyone, regardless of race, nationality, socioeconomic status, gender, or identity, has full access to SRHR. This dream can and must become reality. Thank you.
I thank the delegate from Netherlands, and now give the floor the delegate from Qatar, followed by Nepal.
السيد الرئيس Mr. Chair, distinguished delegates, Director General, peace be upon you. We appreciate the efforts of WHO in improving the availability of human cells in organs transplantation and ensuring ethical access and under oversight. We also appreciate efforts to issue the global strategy on transplantation and donation in order to empower every member state by 2035 to meet the needs of patients in this field, to save lives and improve the quality of life under WHA Decision 77-4 of 2024. We commend the report of DG and EB 158/12 on the progress made in implementing WHA Resolution 77-4 of 2024 and WHA Decision 63/22 of 2010. We also appreciate that the report included the targets of the global strategy on organ transplantation, especially paragraph 9A to F, the main pillars for any effective and integrated program on donation and transplantation, and this ensures meeting the needs effectively. To conclude, we understand the circumstances and the reasons that drive the EB to take a decision 158/5 of 2026, that is to say, to defer considering the global strategy. And we hope that we will receive a detailed report expressing the progress made through the EB session 160s before submitting this to the WHA in 2027. Thank you for your kind attention.
Thank you, Qatar. The floor is now given to Nepal, followed by Ireland.
Respected Chair, ladies and gentlemen, good morning. Nepal emphasizes that achieving universal health coverage by 2030 requires coordinated strengthening across all components of health system. Nepal has made progress through expansion of emergency units, training of health professionals and first responders, adaptation of WHO-supported emergency care tools, and strengthen disaster preparedness. However, further efforts are needed to build a more integrated and resilient emergency critical and operative continuum of care in this. In this regard, Nepal welcomes the draft Global Strategy for Integrated Emergency Critical and Operative Care 2026-35. Given the rising demand for these services, amid shortage of skilled workforce and limited resources, especially in low and middle income countries, Nepal has established important legal and institutional foundation for organ transplantation and has institutionalized services. However, access remains limited. Government system for the human cell and tissue are still evolving. Nepal notes progress by some member states in this arena, while many continue to face regulatory and capacity gaps. Establishing global benchmark for ethical access, safety and oversight, along with strengthened international cooperation, is impressive. Regarding rare disease, Nepal does not have a standard policy, but related priorities are addressed through the border health system framework. Although rare diseases are a small population, equity and inclusion remain critical. Thank you.
Thank you, Nepal. The floor is now given to Ireland, followed by Iraq.
Thank you, Chair. Ireland aligns itself with the statement delivered by Cyprus on behalf of the European Union and its 27 member states. We reaffirm our strong commitment to universal health coverage as a cornerstone of equitable, resilient and sustainable health systems. We remain firmly committed to advancing universal health coverage and securing better access to safe, affordable and quality health services and commodities for those who need it most, including women and children and communities affected by conflict and humanitarian disaster. Chair, the resolution on rare diseases, a global health priority for equity and inclusion, adopted last year, recognises rare diseases as a major global health challenge. It urged Member States to integrate them into national health plans, improve diagnosis and treatment access and promote social inclusion. A key outcome is for the WHO to develop a comprehensive 10-year global action plan by 2028 with measurable targets and accountability framework. As many rare diseases often affect small patient populations, international cooperation is crucial for sharing knowledge, expertise and resources. Ireland believes that collaboration on the global level is imperative to drive innovation, enable early diagnosis and improve management, treatments and outcomes for persons living with a rare disease. In conclusion, Chair, achieving universal health coverage is fundamental to the right to health, building on resilient health systems and strong primary health care. Equity must remain at its centre, and this includes sexual and reproductive health and rights, and ensuring that all health systems are inclusive, resilient and responsive to the needs of all people at all times. Thank you.
Thank you, Ireland. Now the floor is given to Iraq, followed by Sri Lanka.
Honourable Chair, Iraq would like to express its full support for the resolutions EB 158.R2 on precision medicine, EB 158.R3 on strengthening equitable access to diagnostic imaging, EB 158.R4 on reducing the burden of stroke, and EB 158.R5 on advancing smart, efficient pharmacovigilance, and would kindly like to request to be added as a co-sponsor to the aforementioned 4 resolutions. Thank you.
Dear Iraq, could you please push the button again if you haven't your statement? Okay. Now the floor is given to Sri Lanka, followed by Slovenia.
Thank you, Chair. Rare diseases are often chronic, progressive, and life-threatening conditions that require long-term, specialized, and multidisciplinary care. Nearly 80% of rare diseases are of genetic origin, with many presenting in early childhood. Despite Sri Lanka's notable achievements in improving population health through a strong public health system and sustained commitment to equity, services of rare diseases remain underdeveloped and fragmented. Patients with rare diseases in Sri Lanka frequently experience significant delays in diagnosis due to limited awareness and inadequate access to specialized diagnostic facilities, including genetic and biochemical testing. Many individuals are managed without the definitive diagnosis, resulting in suboptimal care and missed opportunities for early intervention. Access to appropriate treatment and long-term care is another major challenge, as essential medicines, including orphan drugs, are often unavailable or unaffordable, placing a substantial financial burden on affected individuals and their families. Furthermore, the absence of structured referral pathways and multidisciplinary care models contributes to inefficiencies and inequities in service delivery. Rehabilitation, psychosocial support, and community-based services remain limited, leading to reduced quality of life, social exclusion for patients and caregivers. The lack of reliable data and surveillance system in some diseases addressing rare diseases is essential, and priority has been recognized in the National Health Strategic Master Plan 2026-2035, which strengthened emphasis, equity, inclusion, and people-centered health systems. In response, Sri Lanka has initiated to advanced diagnostic test relevant medicines, recognizing genetic specialty as a separate field, and necessary rehabilitation care further constrains effective planning and resource allocation. Sri Lanka currently does not have a national registry of rare diseases limiting the ability to understand the true magnitude and distribution of these conditions. Thank you.
I thank Sri Lanka. The floor is now given to Slovenia, followed by Tanzania.
Honorable Chair, distinguished delegates, Slovenia aligns itself with the EU statement. Slovenia reaffirms its commitment to universal health coverage, which remains one of the most critical goals in global health, yet its absence in many parts of the world continues to leave millions vulnerable. Without comprehensive coverage, individuals are often forced to choose between life-saving medical care and financial stability. Financial protection is the cornerstone of UHC. It ensures that the cost of healthcare does not push households into poverty. To achieve this, a robust primary healthcare system is essential, acting as the first point of contact and the foundation of a resilient health system. However, primary healthcare can only function effectively with sufficient health staffing and unhindered access to services free from geographic or socioeconomic barriers. Slovenia would like to commend WHO European Office for the support in developing the first national human resource development plan. Slovenia welcomes the draft global strategy for integrated emergency, critical and operative care 2026 to 2035 that provides a vital framework for enhancing UHC by addressing the full continuum of care. By prioritizing integrated emergency and surgical care alongside primary health initiative, we can make significant strides toward a world where quality health care is a universal right, not a privilege. Thank you.
Thank you, Slovenia. I now give the floor to Tanzania, followed by Colombia.
Honorable Chair, United Republic of Tanzania aligns with the statement delivered by Togo on behalf of African countries. Tanzania reaffirms its strong commitment to universal health coverage as a pathway to equitable access to quality health services without financial hardship. Achieving UHC requires resilient, people-centered, and integrated health systems to ensure safe, effective, and affordable care for all. We strongly support the resolution on advancing smart and efficient pharmacovigilance as an essential component of a strong, sustainable, and responsive health systems. Pharmacovigilance plays a critical role in achieving UHC by strengthening patient safety, improving the quality and effectiveness of medicines and vaccines, building public confidence, and enabling timely detection and response to adverse events. Tanzania supports the resolution on stroke and recognizes its growing burden, particularly in low and middle-income countries. We also support strengthening integrated emergency, critical, and operative care as a key pillar of resilient health systems and universal health coverage. We further support equitable and ethical access to transplantation of human cells, tissues, and organs, while emphasizing the need for technical support, capacity building, and sustainable financing for developing countries to expand access safely and effectively. Tanzania reaffirms its commitment to working with member states and partners to build resilient and inclusive health systems that advance universal health coverage and leave no one behind. I thank you, Chair.
Thank you, Tanzania. I now give the floor to Colombia, followed by Guatemala.
Buenos días.
Good morning, and thank you, Chair. Universal health coverage needs us to work beyond expanding services and to continue to strengthen the capacity of our systems to respond and provide an effective, timely, and equitable response to the needs of persons throughout their life cycle. We are grateful for the draft global strategy for integrated emergency, critical, and operative care, and we fully endorse it because it will help us to transition towards more resilient and integrated health systems. At a national level, Colombia has been engage in ongoing strengthening of its hospital network. We are expanding capacities and improving the availability of essential services. This has helped us to strengthen more coordinated responses, although there are still challenges with respect to territory coverage and timely access. We also wish to highlight the situation of rare orphan diseases, recognizing the importance of continuing work on diagnostics in a timely manner, integrated attention pathways, and responses that help us to deal with the various needs of persons and families. We believe it is important that we continue to strengthen those tools that will help us measure not only coverage, but also ensure that there is effective, timely, and quality access to health services, especially in areas where there are major deficiencies. We reiterate the importance of further strengthening sustainable financing mechanisms, building human talent, and ensuring that we have interoperable data systems that will help us effectively implement these initiatives and strengthen more solid, integrated, and people-centered health systems. Thank you.
Thank you, Colombia. And now give the floor to Guatemala, followed by Malaysia.
Gracias, señor.
Thank you, Chair. Guatemala has been promoting strengthening of UHC and primary health care through the gradual transformation of our care model, which is geared towards expanding access to basic services and reducing gaps. Among the main progress, we would highlight the implementation of the integrated care model, and we also are stepping up our reorganization of coverage, and we're also incorporating new health workforce roles and enhancing digitalization tools to improve follow-up of patients and managing medicines. Nevertheless, there are still structural challenges related to infrastructure, financing, and equitable access to services. The main gaps include long-standing limitations in the services network, cultural and linguistic barriers as well, and there's low public investment in health and the impact of out-of-pocket spending on people and families. We must strengthen the UHC model and focus on social protection, dealing with the social determinants of health, and recognizing the cultural and intercultural diversity as essential elements to ensure that there's equitable access to health services. Thank you.
Thank you, Guatemala. And now give the floor to Malaysia, followed by Pakistan, who will be giving the group statement.
Thank you, Chair. Malaysia acknowledges the importance of the draft global strategy for integrated emergency, critical and operative care 2026-2035 and expresses its support for efforts to strengthen health systems through improved access to essential emergency, critical and operative care services. Malaysia also open for collaborative initiatives that promote capacity building, knowledge sharing and sustainable development, while continuing to strengthen capacity and enhance service delivery and preparedness in line with national priorities across the healthcare system. We wish to highlight several priority areas where targeted support to most urgently needed. First, technical guidance for national action plans is essential to support structured, implementable, and context-specific frameworks. Second, strengthening health information system, including rare diseases registries and ICD-11 implementation, is critical to address gaps in data, surveillance, and policy planning. Third, improving access to diagnosis and treatment remains a major challenge. Strengthening the integration of rare diseases within existing universal healthcare frameworks, particularly in improving access to diagnostics, specialized care, and sustainable financing for high-cost treatments. Fourth, Malaysia supports the development of centers of excellence and regional collaboration, particularly within ASEAN, to enable knowledge sharing and optimize specialized care. Fifth, Malaysia emphasizes that research, clinical care, and public health efforts must work together in in an integrated and
Thank you, Malaysia. Unfortunately, time is up. Now I give the floor to Pakistan, followed by Uruguay.
Thank you, Mr. Chair. Your Excellencies, the member states of the Eastern Mediterranean region recognize the importance of strengthening health systems through these 4 complementary resolutions. Progress on precision medicine will enable more targeted and equitable care. Expanding access to diagnostic imaging through teleradiology is essential to reduce disparities in service delivery. Addressing the growing burden of stroke requires strengthened prevention, acute care, rehabilitation, and systems readiness. Advancing smart pharmacovigilance systems will ensure safer, more resilient, and responsive health care. Together, these resolutions reinforce a shared commitment to innovation, equity, and people-centered care across the health continuum. We call on all countries to fully support these resolutions to advance universal health coverage worldwide. The region continues to actively contribute to shaping the global strategy on integrated emergency, critical, and operative care. A comprehensive survey and regional consultation with health ministers created a shared understanding of the gaps, priorities, and opportunities. Consolidated regional inputs have contributed to refining both the global strategy and the forthcoming action plan. Organ donation and transplantation across the region remains complex and highly heterogeneous, reflecting wide variations in socioeconomic conditions, health systems, capacities, legal and regulatory frameworks, and cultural context. The global strategy should recognize the link between non-communicable diseases and organ failure and address specific challenges in emergency and humanitarian settings. Strengthening regional and cross-border collaboration, improving data systems and transplant registries, and enhancing regulatory and professional capacities are all essential to prevent organ trafficking and reinforce ethical oversight. The region supports deferring consideration of the global strategy to 80th Health Assembly and encourage continued technical support to ensure meaningful progress on this agenda. I welcome the continued attention to rare diseases following the adoption of resolution at the 78th World Health Assembly. We strongly support the resolution and urge the Secretariat and Member States to expedite development of a global action plan. Collectively, we reaffirm our commitment to these important advancements. Thank you.
Thank you, Pakistan. I now give the floor to Uruguay, followed by Cambodia.
Thank you, Chair. Uruguay supports the strategies of the WHO to ensure universal health care. In 2007, we created an integrated health system which took 7.7% of our GDP and covered 15.5% of out-of-pocket expenditure, and we sought to ensure equity and sustainability for a set of timely delivery of medicines and care to reach homes and families through laws enacted in the last 15 years. Our health system protects the sexual and reproductive rights of women, and we provide universal access to abortions, and we ensure the human rights of gender identity, and we protect our transgender candidates and protect them also against stigmatization. We share the concern of the EB on ECO care and the lack of resources for them, especially in conflict-affected areas. We align with the Council's report on the implementation, the reports. We seek to detect early any endocrine and deformities. Rare diseases also can be dealt with free of cost for potential candidates, and we also subsidize medicines for certain diseases, including muscular atrophy inter alia. Thank you.
Thank you, Uruguay. And I'll give the floor to Cambodia, followed by Barbados.
Honorable Chair, ladies and gentlemen, emergency, critical, and operative care are vital to reducing preventable deaths and disability in Cambodia, particularly from trauma, obstetric emergencies, and other time-sensitive conditions. Cambodia has strong commitments through the National Policy and Strategic Plan for Surgery, Obstetric, and Anesthesia 2026-2035, closely aligned with the draft Global ECOC strategy. Our approach integrates emergency and operative care into the broader health system, connecting primary care, referral system, and post-operative follow-up. This strengthens access to essential life-saving procedures, improve quality and safety, develop and fairly deploy the health workforce, and reduce out-of-pocket costs for families. Cambodia policy emphasizes continued investment in integrated emergency, critical, and operative care as the cornerstone UHC and resilient health system. In this regard, Cambodia fully supports the adoption of the draft global strategy for integrated emergency, critical, and operative care as the key component of the universal health coverage. I thank you, Chair.
Thank you, Cambodia. The floor is now given to Barbados, followed by Indonesia.
Thank you so much. Barbados reaffirms its strong commitment to universal health coverage grounded in primary health care approaches that ensure equitable access to quality services for all. We have made meaningful progress through investment in community-based care, modernization of our polyclinics, implementation of our National Strategic Plan for Non-Communicable Diseases. We continue to prioritize prevention through fiscal measures, including taxation on sweetened beverages, and strengthening our digital health systems and surveillance. However, small island developing states like Barbados continue to face significant challenges, limited fiscal space, persistent health force work shortages, and a high dependence on imported medicines and technology constraints our ability to expand and sustain services. At the same time, climate change poses an ongoing threat to resilience of our healthcare system. In this context, Barbados welcomes the development of the Global Strategy for Integration, Emergency, and Critical Operative Care for small states. Integrating these services into universal health care is essential to ensuring timely access to life-saving care. We emphasize the importance of scaling up digital health solutions, including telemedicine and teleradiology, to address the constraints of small island developing states. Continued collaboration on non-communicable disease prevention and climate change resilience is also critical. Chair, achieving universal health coverage requires sustained commitment and partnership and innovation. Barbados stands ready to work with the WHO and member states to ensure that no one is left behind. Thank you so much.
Thank you, Barbados. And now I invite Indonesia, followed by Brazil.
Thank you, Chair. Where you live should not determine whether you live. That is the premise of universal health coverage, ensuring that every person can access quality health services when and where they need them without financial hardships. Indonesia reaffirms its commitment to advancing universal health coverage. Achieving UHC by 2030 will require not only ambition, but also proactive, targeted, and grounded in strong and sustained political leadership. As part of this effort, Indonesia has integrated emergency, critical, and operative care into our national health transformation agenda and national health insurance system. At the same time, we recognize that resilient health systems depend on a strong and protected health workforce. Indonesia is therefore strengthening the governance of internationally deployed health workers through standardized competencies, stronger legal and physical protection, and mechanisms that support brand circulation. We are also advancing efforts for rare diseases through expanded newborn screening, genomic sequencing under the Biomedical and Genomic Science Initiative, National Referral Hospital, and the development of a national rare disease registry to support earlier diagnosis and evidence-based policymaking. Indonesia welcomes the resolution and believes that advanced health services and innovative technologies must remain accessible, affordable, ethical, and inclusive. Thank you, Chair.
Thank you, Indonesia. And now invite Brazil, followed by Palestine.
Mr. Chair, our discussions today on universal health coverage reaffirm our shared commitment to health for all. The Executive Board's recommendations reflect a comprehensive vision integrating diverse yet interconnected priorities for resilient health systems. In Brazil, expanding universal health coverage reflects a renewed commitment to strengthen primarily health care as the foundation of equitable service delivery. We must accelerate the responsible use of digital health technologies to enhance diagnostics, streamline pharmacovigilance, and bridge persistent gaps. The incorporation of new treatments and health technologies must also remain firmly grounded in scientific evidence and aligned with the guidance of national and international health authorities, ensuring safety, efficacy, and equitable access for all. Health sovereignty requires robust domestic capacity to manufacture essential medicines, vaccines, and diagnostics, reducing external dependencies and safeguarding national resilience against future crises. Equally vital is sustaining high vaccination coverage, a powerful tool for population-level disease prevention, alongside targeted strategies to reduce the global burden stroke and strengthen integrated emergency, critical, and operative care networks. Addressing rare diseases further underscores the imperative of leaving no one behind, requiring early diagnosis, equitable treatment pathways, and reinforced international cooperation. Collectively, these initiatives position UHC as the cornerstone of global health security. To fully realize this vision, member states must invest in adaptable, people-centered systems that prioritize community needs, while advancing scientific innovation, continuous workforce training, and sustainable public financing mechanisms. Thank you, Chair.
Thank you, Brazil. And now give the floor to Palestine, followed by Malta.
Thank you, Mr. Chairperson. Palestine thanks the Secretariat for the UHC report calling for the promotion of a comprehensive UHC and a strong health system for all without any exception. And this reminds us of the Astana Declaration on the importance of health as a means of making peace. A strong commitment to achieving and translating words into actions, especially during and after the war and the actual horrific man-made humanitarian crisis in the occupied Palestinian territory, including East Jerusalem. We are facing several challenges and barriers implementing our UHC national plan in Palestine, including East Jerusalem. Gaza Strip enclave is completely out of any positive improvement. And Area C and East Jerusalem of the occupied West Bank Palestinian families in the Jordan Valley daily attacked by the Israeli colonial occupation army, blocking access to the Palestinian mobile clinics. This situation is worse with the ongoing extreme violence of the illegal Israeli settlers gangs, attacking all civilians, not only the Palestinian medical personnel, but also the humanitarian partners and staff, and all European and international peace activists in the occupied West Bank. The situation in Palestine is very dire. I thank you.
Thank you, Palestine. And now give the floor to Malta, followed by Cuba.
Malta aligns itself with the statement Cyprus has delivered on behalf of the European Union member states, with cerebrovascular disease being a leading cause of disability and mortality, and very cognizant of the fact that 4 out of 5 strokes are preventable. Malta considers the prevention, timely acute care, rehabilitation, and long-term care of stroke patients to be high on the national agenda. As we continue to work hard to improve stroke outcomes, recognizing the importance of prevention and rapid intervention, we strongly support the draft resolution on reducing the burden of stroke and would like to be included as co-sponsors of this important resolution. Thank you, Chair.
I thank Malta. And now give the floor to Cuba, followed by Mexico.
Chair, in Cuba, we ensure that emergency, critical, and operative care is integrated at the 3 levels of healthcare. And the fact that it is free, accessible, feasible, and there's equity in our national single health system sets us apart. And it's part of our state policy. We recognize the crucial role played by this coordination in providing a comprehensive response to a wide range of health emergencies, from acute to conditions requiring surgery. At the primary health level, we have 122 specialized services, and these are also at the community level as well, so there's equity and access to specialized health care. In our polyclinics, we have minor surgical procedures provided, which provide PHC care for patients with diseases requiring surgery. In our emergency response plans and in disasters, we have surgical units and emergency specialists to provide care for victims in remote areas. We also have a broad network of acute care services, and there are 159 intensive care units in hospitals where we have intensive care teams that provide planning, monitoring, follow-up, and recovery for surgical patients. We also have emergency plans in contingency measures which respond to the organizational charts, and we will continue our joint work with the WHO and PAHO for training and qualification of emergency health teams as a key way of ensuring that we can upgrade our emergency response in Cuba and support other countries and peoples in the world. Thank you.
Thank you, Cuba. And I'll give the floor to Mexico, followed by Chile.
Gracias, presidente.
Thank you, Chair. Mexico recognizes that universal health coverage is a fundamental human right, and we cannot limit it only to the formal access to services through subscription and payment. Universal coverage should mean that there is effective, timely, and continued access to quality services for everyone, especially those who are historically excluded from national security systems. Social security systems, rather. In this connection, we reaffirm that access to health should not be contingent on people's employment status, income, or any other social condition. With respect to the needs of our people in Mexico and the historic fragmentation of our public health system, our government, under the leadership of our President Claudia Sheinbaum, has been promoting implementation of universal health coverage. Universal health service, rather, which is geared towards ensuring free, progressive, human rights-based care. We are seeking through this strategy to coordinate existing public institutions such as IMSS, ISTE, and IMSS Wellbeing under a common operative framework that will enable us to provide effective UHC by optimizing our infrastructure and capacities that already exist across the territory. We underscore that UHC must incorporate a comprehensive approach that covers not only treatment but also combined prevention, timely diagnostics, protection of human rights, and comprehensive care that is people-centered. Thank you.
Thank you, Mexico. I now give the floor to Chile, followed by Republic of Korea.
Gracias, señor presidente.
Thank you, Chair. We're grateful for the presentation of the reports under this item from the WHO. We welcome the global strategy for integrated emergency, critical, and operative care. Integrating these services into our health systems is key towards reducing avoidable deaths. In our country, we have moved towards protection mechanisms to deal with emergencies, and we have reduced the financial barriers in our public network, and we're planning network surgeries and so on. We also believe it's important that we continue to strengthen the first contact, triage, and in the pre-hospital network. We also wish to highlight the rare diseases agenda as a co-sponsor of this resolution. This agenda is a milestone towards more inclusive health systems and our capacities to respond to people and families facing diagnostic delays. In 2025, we enacted our law on rare or orphan diseases, and we incorporated principles such as the participation of civil society, cooperation, and data protection. We also have a national list, and we're gradually implementing our national registry, and we set up a technical committee with technical, academic, clinical, and citizen participation. To provide UHC, we must strengthen the financing, the quality of healthcare, and the information systems. Sir, we believe that we must protect the financing available for our health systems, and we reaffirm our commitment to every effort in this regard. Thank you.
Thank you, Chile. I would like to remind delegations to only occupy the seat corresponding to their country and to not remove any nameplates or cards. Thank you. I now give the floor to Republic of Korea, followed by Panama.
Thank you, Chair. First, the Republic of Korea strongly supports the global strategy on emergency, critical and operative care, or ECO, which is a key component of universal health coverage. We are currently focusing on the integrated management of patient transportation and referrals. We are also strengthening our 24/7 specialized care systems to ensure continuity of care from the field to the final treatment. To expand such national systems, we suggest establishing a global ECO learning network to support multi-country research. Next, the ROK fully upholds the vision and strategic goals for organ donation and transplantation. We have expanded brain death donation through a comprehensive public system that supports the entire process from initial consultation to final transplantation. We also announced our first comprehensive plan for organ donation and transplantation to honor donors. Furthermore, we plan to introduce donation after circulatory death to further expand these life-saving procedures. In line with these efforts, we ask the Secretariat to finalize the expert community and request practical implementation tools and regulatory guidance for emerging technologies that are suitable for each country's legal system. Lastly, the Republic of Korea highly values the resolution on rare disease. Since 2017, we have actively implemented comprehensive 5-year action plans. Recently, we launched a national registry program for accurate data collection. We also announced new measures to strengthen intergovernmental support and advance state responsibility. To translate these national efforts.
Thank you, Republic of Korea. You're out of time. I now give the floor to Panama, followed by Chad.
Gracias.
Thank you, Chair. Panama is grateful for the presentation of the consolidated report, and we reaffirm our strong commitment to transitioning to UHC to ensure that there's equitable access to quality health services without any financial difficulties. We recognize the progress made in adoption resolutions geared towards strengthening more resilient health systems, including precision medicine and imagery and diagnostics, cardiovascular interventions, and co-surveillance. This reflects a modern, equity-based vision to deliver health results. We also welcome the draft global strategy for integrated emergency, critical, and operative care. And we wish to highlight the need to integrate this into PHC and health systems, especially considering the persistent gaps in access, infrastructure, and human resources. We must deliver safe and timely health services. This is essential to health equity. We also welcome efforts to increase availability of ethical access and the supervision of cell transplants and tissue and organs. And we have to strengthen the governance, transparency, and regulatory frameworks to ensure that there is just and equitable equitable access to these services. With respect to rare diseases, this is a global priority in terms of equity and inclusion, and it is key that we improve early diagnostics, access to treatment, and the integration of these systems into our broader health systems through international cooperation and strengthening of our data systems. We therefore reiterate that moving towards universal health coverage requires sustainable financing and innovation and effective international cooperation. Reaffirm our commitment to work alongside the WHO and other member states to ensure that no one is left behind and they have access to quality integrated health services. Thank you.
Thank you, Panama. And now we invite Chad, followed by Maldives.
Monsieur le Président,
Chair, guests, distinguished delegates, Chad endorses the statement made by Togo on behalf of the WHO Africa region. We thank the Secretariat for the excellent report submitted. We reassert our commitment to the principles of equity, inclusion, and universal access to vital health care and UHC. We support the draft global strategy for integrated emergency, critical, and operative care 2026-2035 for countries facing humanitarian security and health crises, in particular in the Lake Chad Basin, affected by terrorist attacks by Boko Haram. Strengthening capacity in terms of care in case of emergency is crucial in order to reduce preventable mortality and strengthen resilience of health systems. However, this is faced by funding challenges over the long term because of lack of qualified health staff in a context marked by persistent crises as well as migration and displaced persons. We support the initiative aimed at strengthening availability and transportation of human cells, tissues, and organs in respect for principles of equity and ethics. Taking into account the constraints we face, my country prioritizes a gradual approach in line with the WHO standards and the Istanbul Declaration. In this context, Chad has started implementing a transparent system that includes rigorous measures and vigilance and surveillance. We welcome the recognition of our country
Thank you, Chad. And now invite Maldives, followed by Ghana.
Thank you, Chair. The Maldives reaffirms its commitment to universal health coverage as a cornerstone of equitable and resilient health systems. As a small island developing state with a geographically dispersed population, ensuring timely access to quality health services without financial hardship remains both a priority and a challenge. We welcome the outcomes of the 158th Executive Board. For the Maldives, innovations such as precision medicine and digital health, including teleradiology, are highly relevant. These solutions help bridge geographical barriers, strengthen diagnostics across islands, and reduce dependence on overseas referrals. We support the draft global strategy for integrated emergency, critical, and operative care. In our context, timely emergency response, effective inter-island referrals, and reliable transport and digital connectivity are critical. Investment in health workforce capacity and resilient service delivery systems is key. We are particularly concerned about the growing burden of non-communicable diseases, including stroke. Strengthening prevention, early detection, rehabilitation, and pharmacovigilance systems is essential to improve outcomes and ensuring patient safety. Achieving UHC in small island settings requires sustained investment, strong primary health care, and global solidarity. The Maldives remains committed to working with WHO and partners to deliver practical, country-level solutions that leave no one behind. Thank you.
Thank you, Maldives. And I'll give the floor to Ghana, followed by Kenya.
Thank you, Chair. Ghana aligns with Togo's statement on agenda, item 12.4,
and appreciates the Executive Board's focus on advancing universal health coverage through enhanced service delivery, equity, and systems integration. We support the 2026 to 2035 Global Strategy for Integrated Emergency and Operative Care, recognizing that timely access is crucial to reducing preventable deaths, especially in low and middle-income countries. Integrating these services within primary health care is vital for improving outcomes and system resilience. We emphasize the need for adequate financing, workforce protection, infrastructure development, and digital tools for effective implementation. Ghana welcomes the report on the ethical access to transplantation of human cells, tissues, and organs, advocating for strong governance and oversight to address inequities and unethical practices. We support the ongoing development of a global strategy through inclusive consultations that prioritize equity and ethics. Additionally, Ghana recognizes rare diseases as a global health priority, urging a global action plan that enhances research, improves diagnosis, and integrates rare diseases into health coverage frameworks to ensure no one is left behind. In all areas, Ghana emphasizes that universal health coverage must be people-centered, equitable, and sustainable, strengthening integration, governance, and financing tailored to national context is essential for translating policy commitment into health gains. Ghana affirms its commitment to universal health coverage and looks forward to ongoing WHO support for building resilient health systems. I thank you, Chairman.
Thank you, Ghana. I now give the floor to Kenya, followed by Senegal.
Okay. Merci beaucoup, Monsieur le Président.
Thank you very much, Chair, delegates.
De la République de Guinée.
Mr. Chair,
Nous saluons le leader
We welcome the leadership of WHO.
universel aux soins.
Excuse me, the Kenya, the floor is yours.
yeah, thank you, Mr. Chair. On resolution on Agenda 12.4, Kenya aligns itself with the statement delivered by Togo on behalf of African states of the WHO region. We thank WHO for its leadership in developing the progressive resolutions and decisions under this agenda item and supports its adoption by the World Health Assembly. We support the launch of the Global Health Strategy for Integrated Emergency, Critical and Operative Care 2026-2035 as a key step towards addressing persistent gaps in emergency and critical care delivery. Kenya affirms that emergency, critical and operative care are essential to achieving universal health coverage and calls upon WHO to support country-level adaptation and implementation of the strategy. Guided by the Digital Health Act 2023 and the Digital Health Strategy 2023-27, we are advancing interoperable digital health solutions to promote equitable access to quality health services, including diagnostics. We support teleradiology as an important tool for improving access to diagnostics, particularly in underserved areas. Kenya further reaffirms its commitment to equitable access to safe, effective, quality, and affordable health products and technologies. We recognize the importance of strong pharmacovigilance systems in safeguarding patient safety and strengthening health system resilience and call for enhanced global collaboration, capacity building, and technology transfer to address existing inequities. In closing, Kenya endorses the global agenda on stroke prevention, care, and rehabilitation and welcome WHO's initiative to develop a global action plan on rare disease as an important step towards advancing and inclusion in UHC. Kenya stands ready to support this agenda, including through consideration as a regional center of excellence for rare diseases. I thank you.
Thank you, Kenya. Dear delegates, I would like to kindly remind you that the microphone will open automatically when I call your delegation to take the floor. There is no need to touch the microphone button again, as this will remove you from the speakers list. I now give the floor to Guinea, followed by Senegal.
Thank you, Monsieur le Président.
Thank you, Chair, delegates. It is an honor to take the floor on behalf of the Republic of Guinea. We welcome the leadership of WHO for equity and universal health care access. We reassert our commitment to UHC, which is part and parcel of our Constitution and at the heart of our National Health Development Plan through to 2034. To implement this vision, we are undertaking reforms. We are adopting a plan, and we have an autonomous agency on the UHC, which will be set up very soon. We have targeted the most vulnerable groups of the population. However, funding is still our major challenge. Despite free-of-charge services related to delivery, vaccination, and neonatal cares, household costs still account for 55.2% of overall care. To reverse these tendencies, we are mobilized through two major areas: increase of national efforts through our state budget to strengthen social protection, which is inclusive, and promote an inclusive vision. We have a program that will make it possible to improve taxation and ensure autonomous health services. We ask for the strengthening of assistance and technical cooperation in order for us to deal with the reality we're facing. Thank you.
Thank you, Guinea. I now give the floor to Senegal, followed by Somalia.
Thank you, Chair. Distinguished delegates, Senegal endorses this statement on the draft global strategy for integrated emergency, critical, and operative care 2026-2035 made by Togo. We welcome the drafting of the global strategy for emergency, critical, and operative care that marks a major step forward towards a series of consistent patient-centered care. This care is a fundamental pillar of the health system. It's vital in order to respond to traumas, obstetrical emergencies, acute complications of NCDs and communicable diseases, and health crises. Significant progress has been made in the last few years. The country has strengthened its supply of care at various levels through the development of operating rooms, life-supporting resuscitation and resuscitation units. Significant efforts have also been made to structure hospital emergency services, setting up special units and referral units for trauma and medical and emergencies. Training human staff in surgery and anesthesia has been strengthened to ensure safety and security of care. Despite this progress, there are still challenges in terms of access. It's limited, in particular, in rural areas and remote areas where infrastructure and vital equipment and human resources are insufficient. Funding of this care is also a challenge and leads to household costs that are catastrophic. We reaffirm our commitment to UHC. More funding must be ensured for these areas. Senegal takes note of the report and supports the adoption of the decision EB 1584. Thank you.
Thank you, Senegal. I now invite Somalia, followed by Timor-Leste.
Thank you, Chair. Excellencies, Chair, distinguished colleagues, good morning. Somalia aligned itself with the statement delivered by Pakistan on behalf of the Emiro region and thanks the Director General for the comprehensive report. Somalia welcomes the emphasis on the universal health coverage, immunization, digital health, and sustainable financing foundations for resilient health systems. For low and middle-income countries, such as Somalia, strengthening PHC remains the most effective pathway to universal health coverage. In recent years, Somalia has expanded immunization coverage. Somalia expanded the UHC coverage, strengthened DHI2 reporting systems, introduced vaccines, and significantly reduced zero-dose children through integrated and community-based approaches. However, challenges remain: the climate shocks, workforce limitation, and declining external financing. Somalia particularly welcomes the focus on immunization, Agenda 30, and also prioritization of zero-dose. We also support the integration of immunization, nutrition, mental health, rehabilitation, and NCDs into the primary health care and overall universal health coverage. We further emphasize the importance of sustainable, predictable financing to advance universal health coverage, workforce support, into country-led approaches anchored in one plan, one budget, and one reporting system to reduce the fragmentation. Finally, Somalia reaffirms its commitment to working closely with WHO member states partners to advance UHC and equitable access to service delivery so that we leave no one behind. I thank you, Chair.
Thank you, Somalia. I now give the floor to Timor-Leste, followed by Morocco.
Thank you, Chair. Mr. President, distinguished delegate. Timor-Leste welcome the discussion on universal health coverage and the draft global strategy for integrated emergency critical and operative care 2026-2035. As a small island developing state with geographical and resource constraints, Timor-Leste recognizes that strengthening emergency and critical care is essential to achieving equitable health care and a resilient health system. Through the Serviço Nacional de Ambulância e Emergência Médica (SNAM), Timor-Leste has strengthening health emergency prevention, preparedness, and response capacities between 2024 and 2026. Health emergency operation centers have been established in several municipalities and a hospital in Timor-Leste, improving coordination and decentralized emergency response with the objective of expanding coverage nationwide. Timor-Leste has also reinforced pre-hospital emergency care through the operation of ambulance and continued investment in emergency transport and workforce training. At the same time, we are modernizing epidemiological surveillance through integrated digital system to strengthening early warning and rapid response capacities. Timor-Leste believes that integrated and people-centered approach is essential to ensure that no one is left behind during emergency and disaster. Despite progress, challenge remain the infrastructure, specialist workforce capacity, sustainable finance and access to services in remote areas. We therefore support stronger international cooperation and sustained investment to reinforce emergency preparedness, resilient health system, and universal health coverage. Timor-Leste reaffirms its commitment to advance integrated emergency care and equitable health care for all. Thank you, Chair.
Thank you. I will now give the floor to Morocco, followed by Lesotho.
Monsieur le Président,
President, ladies and gentlemen, delegates, Morocco endorses the statement made by Pakistan. On behalf of EMRO, we express our appreciation for the Director General's consolidated report, and in particular on UHC. UHC aims to ensure access to high-quality care without financial difficulties and even less catastrophic expenses. This access can only be effective through inclusive financial and supply of care that takes into account various needs. With this in mind, Morocco has started a broad project to overhaul its health system. It's based on the universal application of medical coverage, strengthening funding, modernization of infrastructure, and reforming governance. With this in mind, also, we fully support the adoption of decisions and resolutions recommended by the board. We support the global strategy for integrated emergency critical operative care and support the proposal to strengthen ethical framework regarding transplantation and donation of tissues, as well as the preparation of a global action plan on rare diseases. Throughout the health system, we assert our commitment to work together with the WHO and all the partners in order to ensure that this leads to concrete progress. We highlight the importance of strengthening international cooperation to guarantee equitable access to technological innovation and continue the catalyst role of WHO to ensure convergence of high-quality standards. Thank you.
Thank you. Now I will give the floor to Lesotho, followed by Burkina Faso.
Thank you, Chair. The Kingdom of Lesotho reaffirms its strong commitment to strengthening integrated emergency, critical and operative care as a cornerstone of universal health coverage, health security and resilient health systems. In alignment with the WHO Global Strategy for Integrated Emergency, Critical and Operative Care, Lesotho continues to implement reforms aimed at ensuring timely, equitable and quality emergency and critical care services. Lesotho has developed the National Emergency Medical Services and Referral Policy, together with implementation guidelines, standard operating procedures, and operational tools to strengthen emergency response and referral systems across all levels of care. In addition, the country has developed a national critical care strategy and guidelines to improve the quality and coordination of critical care services within health facilities. To strengthen pre-hospital emergency response, Lesotho has established 2 emergency medical services ambulance-based stations dedicated to medical emergencies, currently awaiting pilot implementation. A national ambulance dispatch center under the Public Health Emergency Operations Center framework is being established to coordinate emergency communication, ambulance deployment, and referral linkages nationwide. Furthermore, Lesotho has introduced a national toll-free emergency number and procured both basic and advanced life support ambulances adapted to the country's mountainous terrain to improve access to emergency care in hard-to-reach communities. These efforts demonstrate Lesotho's commitment to building integrated, people-centered, and resilient emergency and critical systems.
Time is up. Thank you, Lesotho. I now give the floor to Burkina Faso, followed by Ecuador.
Thank you, Chair. Burkina Faso endorses the statement made by Togo on behalf of the African region. We thank the Secretariat for the excellent documents. We fully support the draft global strategy for integrated emergency, critical, and operative care for 2026-2035. Our country faces a strong pressure on health systems, in particular in terms of trauma care, critical care, and emergencies. Several reforms have been launched, in particular free of charge services for children under the age of 5 and pregnant women, drafting protocol for emergency care, deployment of emergency units and mobile clinics, and strengthening hospital infrastructure, as well as extending dialysis and specialized surgery capacity. Burkina Faso welcomes the progress in strengthening transplantation of human cells, tissue, and organs in respect for ethical principles. We plan to adopt a law, and we have set up a special ethics committee that has made it possible to carry out the first kidney transplantations. This is a major step progress for our health sovereignty and for reducing costly health evacuations. We welcome the recognition of rare diseases as a global public health priority. This is crucial in order to promote equity, inclusion, and social justice, in particular for people living with sickle cell anemia, albinism, autism, and other complex disorders. Burkina calls for international solidarity, South-South partnership, and transfer of technology. Thank you.
Thank you, Burkina Faso. I now give the floor to Ecuador, followed by Micronesia.
Mr. Chairman, distinguished delegates, Ecuador thanks the Secretariat for its presentation of the report. UHC is a fundamental principle to ensure the right to health and to reduce deep inequalities that are still affecting millions of people, especially in context of social vulnerability, poverty, and rurality. We continue to strengthen the PHC as the bedrock of our national health system. We give priority to promoting, preventing, and providing integrated care throughout the life cycle. We recognize that quality primary health care is the most effective way to get service to communities and to reduce barriers to access and improve health outcomes. In this connection, we have been promoting initiatives to scale up the workforce, expand vaccine coverage, improve access to essential medicines, and take forward community and intercultural health strategies with special attention to rural populations, peoples and indigenous nationalities, women, girls, and so on. We also recognize that the current challenges, including non-communicable diseases, mental health, malnutrition, and effects of climate change, require more resilient, sustainable, and prepared health systems. It is our view that we must strengthen sustainable financing and ensure that it doesn't condition people's access because of their ethnic origin or where they live or their financial purchasing power. Thank you.
Thank you, Ecuador. I now give the floor to Micronesia, followed by Vanuatu.
Mr. Chairman, the Federated States of Micronesia reaffirms its strong support for universal health coverage and welcomes ongoing efforts to strengthen equitable, resilient, and responsive health systems globally. For small island nations like Micronesia, universal health coverage is both an aspiration and a necessity. Delivering equitable health care across distant remote island communities presents major logistical, financial, and workforce challenges. Therefore, Micronesia strongly supports WHO's emphasis on integrated health systems, strengthening health workforce, improving referral systems, and expanding digital health and telehealth solutions. These investments are essential for communities where access to specialized healthcare, inter-island transport, telecommunication, and overseas referral services is very limited. We also welcome the focus on integrated emergency, critical, and operative care within universal health coverage. Micronesia is highly vulnerable to natural disasters, climate-related emergencies, and supply disruptions, making resilient health systems critically important. Micronesia further emphasizes that universal health coverage cannot be achieved without sustainable financing and long-term investment in primary healthcare systems and community-based services. Equity must remain at the center of global health efforts. Small island nations face disproportionately high costs to deliver even basic health services, and this reality must continue to be recognized in global financing and technical support mechanisms. Micronesia thanks WHO and our development partners for their continued collaboration and support, and we remain committed to advancing accessible, equity, and people-centered healthcare for all. Thank you, Chair.
Thank you, Micronesia. And now we invite Vanuatu, followed by Ethiopia.
Thank you, Chair. I want to acknowledge that strong primary health care and equitable access to quality health services are the foundation of universal health coverage. Vanuatu has recently developed a new national primary health care framework, reaffirming our commitment to people-centered, integrated, and community-based services, particularly for remote and underserved communities. In this context, Vanuatu strongly supports resolutions and decisions in this agenda item, which together advance equitable and people-centered progress towards universal health coverage. We recognize the potential of innovation and digital health to improve prevention, diagnosis, and treatment. However, for small island developing states, implementation must remain ethical, affordable, and phased, supported by strong governance, workforce capacity building, and protection of data sovereignty. Vanuatu strongly supports teleradiology to address diagnostic and workforce gaps in remote areas while strengthening referral pathways and digital health systems. We also support the resolution on stroke with its emphasis on prevention, rehabilitation, and primary health care to reduce premature mortality and disability. These resolutions reflect Vanuatu's priorities of strengthening primary health care, advancing equity, responsible leveraging digital health. Vanuatu reaffirms its commitment to working with WHO and partners to translate these global commitments into meaningful country-level impact in advancing universal health coverage. I thank you.
Thank you, Vanuatu. And now give the floor to Ethiopia, followed by Haiti.
Thank you, Mr. Chair. Ethiopia thanks the DG for the consolidated report and aligns with the African Regional Statement. Ethiopia has built one of the most extensive community-based primary healthcare platforms anchored by the Health Extension Program. Approximately 81% of those who seek care now receive it at the primary level, and the community-based health insurance scheme has been progressively expanded to cover more than 92% of districts in Ethiopia. These foundations are real, and so are the gaps. Out-of-pocket expenditure remains high, the service coverage index needs to climb further, the rural-urban gradient persists, and a series of overlapping shocks continue to test the resilience of the system. Ethiopia welcomes the draft global strategy on integrated emergency, critical, and operative care and supports its adoption. Moving forward, country ownership and leadership, scale-up of proven interventions, and catalytic financing are critical for measurable impact. We encourage member states to sustain investment in integrated emergency, critical and operative care services, and WHO to support the adaptation and implementation of the global ECO strategy and the upcoming global action plan. Ethiopia supports the draft resolution on smart pharmacovigilance that is timely and relevant. Ethiopia has been working on a comprehensive pharmacovigilance framework, including regulatory guidelines, adverse event reporting systems, active surveillance, and post-marketing monitoring. Ethiopia also welcomes the draft resolution on precision medicine. We are developing the precision medicine base with an integrated pathogen genomics and bioinformatics facility, national bioinformatics training program, and a recently launched Biomedical Research Institute. In alignment with these commitments, Ethiopia stands ready to deepen partnership and collaboration for attaining universal health coverage, leaving no one behind. Ethiopia takes note of the report and supports the adoption of the draft resolutions under this agenda item. I thank you.
Thank you, Ethiopia. I now invite Haiti, followed by Congo.
Monsieur le Président. Chairman, Haiti is grateful to the Secretariat, and we reaffirm our commitment to universal health coverage as the foundation of the right to health. For Haiti, UHC is a vital necessity. Under the leadership of our Minister of Health and Sports, efforts have been undertaken to strengthen primary health care and to integrate services and to scale up our workforce and maintain essential services in countries facing difficult conditions. However, we should not hide what is really happening. Access to healthcare is severely hampered by protracted insecurity, population displacement, and disruptions in the operations of many health facilities, the economic recession, as well as financial barriers that are besetting the most vulnerable of our Haitians. So building UHC needs more than just principles. We need solidarity, flexibility, and support in tangible forms. Haiti remains committed. However, countries facing multiple vulnerabilities cannot alone take up the challenges they face. We therefore call on the WHO and its partners to step up their support to countries experiencing situations that make them fragile, not only to respond to emergencies, but to build more resilient, integrated, and people-centered health systems. Universal health coverage should not be a privilege that is reserved only to countries that are stable. It should be a promise that is delivered for each and everyone by everyone. Thank you.
Thank you, Haiti. I now give the floor to Congo, followed by Mali.
The Republic of Congo welcomes constant efforts of the international community in support of universal health coverage, a vital pillar of the 2030 Sustainable Development Agenda. We support the WHO resolution on UHC. During the last few years, significant progress has been made. In particular, the launch in 2025 of the Universal Health Insurance Scheme. In 135 health facilities, we are committed to developing a national strategy for health financing, quality and equity in health care with emphasis placed on prevention. Health system has been strengthened by establishing 2 general hospitals, strengthening primary health care, and investing in human resources, and developing specialized technical platforms and improving care in vulnerable areas. Several reforms and investments are underway in order to give a new boost to primary health care services, in particular a new segmentation of the country in health districts from 50 to 72 in order to improve local services and setting up health sectors and strengthening community participation. The use of data in health districts to measure progress, taking into account health determinants of health in the approach to primary health care and taking into account all diseases in primary health care, including NTDs. Since 2020, with the support of WHO, we're committed to upscaling primary health care. Efforts to revitalize health districts have made it possible to double the service user rate and improve first prenatal contacts, which went from 16% to 43%, as well as there was a reduction in delays linked to disruption of stocks between 2020 and 2024. However, there are a few challenges remaining, in particular lasting funding of health, availability of qualified human resources. Thank you.
Thank you, Congo. I now give the floor to Mali, followed by Comoros.
Merci, Monsieur le Président.
Thank you, Chair. Mali fully endorses the statement of Togo on behalf of the WHO Africa region. UHC is not an ideal. It is an imperative of social justice and a fundamental pillar of national sovereignty. No citizen, no family should have to choose between getting food or getting health care. The efforts have been made in our country. We have built several hospitals and offered emergency services. In the face of the challenges we face, we are fully reforming our health infrastructure by deploying universal health coverage, strengthening primary health centers. We are addressing the health of the most vulnerable populations. We ensure that each community health center is the first stronghold against diseases. We today seek to ensure innovation, digitalization of health information system, and deployment of telemedicine to reach rural areas and ensure the provision of vital medications. We call for equitable access to medical technology. It is vital in order to deal with inequality of access in terms of care. Resilience of our health systems cannot be dissociated from our capacity to decide for ourselves. Along with our states partners of the Sahel region, we need to pool medication and care to guarantee equitable access. We call on WHO to support this initiative, financing UHC. It's not providing assistance, it's investing in stability and safety and health of our nations. Thank you.
Thank you, Mali. I invite Comoros, followed by Bangladesh.
Monsieur le Président.
President, in the African region, inequitable access to emergency care, as well as critical and operative care, remains a major challenge because of insufficient human resources, limited infrastructure, and fragile reference systems and geographic constraints, in particular in the rural and island context. Effective integration of urgency, critical and operative care into UHC is therefore vital to reduce preventable mortality and strengthen resilience of the health system. The Union of Comoros illustrates this regional commitment through structural investment, particularly recently completed building of a university hospital center in order for it to also open a special unit at the University of Comoros. These measures seek to support national capacity, train health staff, and improve access to specialized high-quality care. Member states of the African region highlight the importance of WHO support in drafting and implementing the global plan of action, highlighting the development of human resources, strengthening infrastructure, effective referral units, and adapted tools. We reaffirm our commitment to integrate this care in moving towards universal health coverage with international support based on equity and equality. Thank you.
Thank you, Comoros. I now invite Bangladesh, followed by Gabon.
Thank you, Mr. Chair. Bangladesh thanks the Secretariat for the reports. Bangladesh remains firmly committed to achieving universal health coverage through equitable, people-centered and resilient health systems. Bangladesh, since its independence, has achieved remarkable success in expanding primary health care, strengthening immunization and improving maternal and child health services. As part of its universal health coverage program, the present government of Bangladesh has undertaken initiatives for introducing nationwide electronic health cards and to reduce high out-of-pocket medical expenses and improve access to public health care. Bangladesh supports the draft global strategy for integrated emergency, critical and operative care. Timely access to emergency, surgical and critical care services is essential for saving lives and strengthening preparedness for disasters, pandemics and humanitarian emergencies. Bangladesh, over the years, has established numerous trauma centers as well as intensive care units and coronary care unit facilities to strengthen emergency services. The government is further committed to expanding emergency care capacity, enhancing referral and ambulance services, including newborn intensive care units, and implementing standard hospital emergency management guidelines. Bangladesh emphasizes the importance of resilient referral systems, trained health workers, trauma care capacity, and equitable rural access. On rare diseases, Bangladesh welcomes greater global attention to equity and inclusion and reaffirms its commitment to working collectively towards improving the lives of people living with rare diseases. Bangladesh recognizes that rare diseases remain a significant yet under-recognized challenge, particularly in low and middle-income countries where limitations in diagnostic capacity, surveillance systems, and specialized care continue to hinder timely identification and management. We support enhanced collaboration in research, diagnostics, affordable medicines, and health system integration. Bangladesh reaffirms its commitment to
Thank you, Bangladesh. I now give the floor to Gabon.
Merci. Thank you, Mr. Chair. Gabon endorses the statement made by Togo on behalf of the Africa region. We thank the Secretariat for the excellent report. My country is implementing a major transformation of its health architecture. We welcome the approach of the draft global strategy for integrated emergency, critical and operative care 2026-2035. Equitable access to these resources remains a major challenge, in particular exacerbated in isolated areas or fragile areas. Operative and critical and emergency care must be part and parcel of vital care in order to achieve sustainable development goals. Regarding transplantation of human cells, tissues, and organs, we support the decision to continue inclusive consultations in order to have a fine-tuned strategy by 2027. We must also, in Gabon, strengthen our national framework to have a framework which can prevent and combat effectively various issues such as trafficking of organs. With regard to rare diseases, we share the profound concern of the region in the face of persistent inequalities in terms of care. Improving early diagnosis and integration of these pathologies at all levels of the health system must become a concrete and inclusive reality in order to guarantee health for all. Thank you.
Thank you, Gabon. In conformity with the Rule 47 of the Rules of Procedures of the World Health Assembly concerning the representatives of the United Nations and of other intergovernmental organizations, I would now like to give the floor to United Nations Population Fund.
Thank you, Chair. Universal health coverage is fundamentally a matter of human rights. An equitable universal health coverage must integrate comprehensive sexual reproductive health services directly at primary health care. These services include family planning, maternal health, STIs and HIV prevention and treatment, comprehensive sexuality education, and prevention and response to gender-based violence and other harmful practices against women and girls. Investing in sexual and reproductive health and rights yields an impressive 8-to-1 return, yet remains critically underfunded. We call upon donor countries to honor their financial commitments and urge program countries to increase domestic resource allocation for ASR-HR by establishing dedicated budget lines. Member states can safeguard ASR-HR against unpredictable political and financial climates to reach 2.1 billion people currently facing extreme hardship. UNFPA will focus its technical cooperation on ensuring that comprehensive ASR-HR is at the heart of universal health coverage. I thank you, Chair.
Thank you. I now give the floor to International Organization for Migration.
Distinguished delegates, IOM welcomes efforts to advance universal health coverage through equity, inclusion, and resilient health systems. Recent WHO reporting shows encouraging progress, with more than 60 countries including refugees and migrants in national health policies. This policy progress must be matched by implementation, as persistent gaps continue to limit equitable access, continuity of care, and financial protection. Addressing these gaps for inclusive universal health coverage is consistent with the Progress Declaration adopted by the Second International Migration Review Forum, which signals continued intergovernmental support for inclusion in basic services, including healthcare. IOM remains committed to supporting member states, WHO, and partners in integrating migrants into UHC policies, planning and implementations to leave no one behind. Thank you.
Thank you. Several non-state actors in official relations with the WHO have requested the floor on this agenda item. According to the privileges conferred by the relationship with the World Health Organization, I have pleasure giving the floor to the representative of European Society for Medical Oncology.
The European Society for Medical Oncology welcomes the Precision Medicine Resolution and encourages member states to adopt it to advance equitable access to effective and sustainable precision medicine. We commend the recognition that molecular profiling, when supported by robust evidence and appropriate health system capacity, can improve patient outcomes, inform more efficient use of resources, and advance research. We welcome the emphasis on evidence-informed approaches that are essential for sustainable implementation. Where implementation is grounded in health system strengthening, equity, and national priorities and capacities, precision medicine can support universal health coverage. ESMO stands ready to support WHO and member states through evidence-based guidance and frameworks for the effective, equitable, and sustainable implementation of precision oncology into health systems. Thank you.
Thank you. I invite Global Health Information Network.
Thank you. Universal access to reliable healthcare information is essential for universal health coverage. Every person and every healthcare worker needs access to relevant and reliable healthcare information to protect their own health and the health of others. A recent global consultation by Global Healthcare Information Network concluded that this can only be achieved if WHO explicitly champions universal access to reliable healthcare information and leads efforts to strengthen the global evidence ecosystem. We commend WHO for launching the Global Coalition of Evidence to strengthen the ecosystem. We invite our colleagues across WHO and all stakeholders to work with us to strengthen the ecosystem. Thank you, Chair.
Thank you. I now invite Global Self-Care Federation.
Chair, distinguished delegates, we welcome WHO's continued leadership to advance universal health coverage, including through stronger integrated health systems that can deliver essential services across the continuum of care, including emergency, critical, and operative care. To make UHC real for people and communities, we highlight self-care as a practical and people-centered approach that complements health system strengthening, supporting prevention, early action, adherence, and continuity of care, especially where access remains limited or fragmented. Self-care must not be seen as shifting responsibility away from governments or health systems. Instead, it should be enabled through evidence-based products and services, trusted information and referral pathways that connect people to timely facility-based care when needed. We encourage WHO and member states to integrate self-care within UHC reforms and service delivery so that access is expanded, inequities are reduced, and health systems are strengthened. I thank you.
Thank you. I now invite International Association for Suicide Prevention.
Thank you, Chair. There can be no universal health coverage without mental health, and no mental health without suicide prevention. Access to suicide prevention services, crisis support, and postvention globally remains profoundly uneven, with the greatest gaps in low and middle-income countries where over 70% of suicides occur. The fourth high-level meeting declaration commits member states to ensuring essential medicines, technologies and services for mental health are available in 80% of primary healthcare facilities by 2030, and to extending financial protection for these services. These commitments must now be operationalised. The International Association for Suicide Prevention urges member states to integrate mental health and suicide prevention, to scale up community-based services, and to ensure that financial protection covers mental health care. We further call for the meaningful inclusion of people with lived experience in the design of universal health care reforms. Thank you.
Thank you. Now the floor is given to International Association of Communication Sciences and Disorders.
Thank you, Mr. Chairman. The International Association of Communication Sciences and Disorders, with the support of the World Rehabilitation Alliance, welcomes the proposed resolution on reducing the burden of stroke. This aligns with global evidence and national models, including Egypt, where fragmented healthcare sectors have been integrated into a unified nationwide stroke system. Coordinated pathways, early response, and structured rehabilitation improves outcomes and quality of life. We call on member states to ensure implementation through investment in integrated stroke and rehabilitation services, including workforce, capacity, and infrastructure, and incorporating functioning as the third dimension of population health within monitoring frameworks. Advancing stroke care and rehabilitation is imperative to build resilient and equitable health systems. Thank you.
Thank you. I now invite International Baby Food Action Network.
IPFAN strongly supports the right to access to free and adequate health care. To be effective, strong conflicts of interest safeguards are needed to prevent harmful industry practices that negatively impact health. Prevention for optimal health is critical and starts with infant and young child feeding, breastfeeding, and avoidance of ultra-processed products. Companies process raw ingredients to achieve sweetness while claiming products are healthy. Sweetness is addictive and sets up taste preferences in children, programming them to consume sweet ultra-processed products. The intentional higher levels of added sugar content by companies targeting the Global South is an unethical and unacceptable double standard. IPFAN urges governments to fully implement the code, now 45 years old, and to enact strong legislation covering all products marketed for infants and children. Thank you.
Thank you. I now invite International Council of Nurses.
Thank you, Chair. The International Council of Nurses, representing 30 million nurses worldwide, supports the global strategy for integrated emergency, critical, and operative care. Nurses are critical to delivering safe, timely, high-quality emergency, critical, and operative care. Strengthening ecosystems will not be possible without sustained investment in the health workforce, particularly education, regulation, and retention. Properly supported, advanced, and extended nursing role bring care closer to patient, enabling earlier intervention, better continuation of care, and wider reach into advanced areas. We commend the emphasis on integrated, team-based, people-centered care and underscore the importance of access to rural, remote, and conflict-affected populations, supported by robust data and quality improvement systems. ICN stands ready to work with member states, WHO, and partners to advance safe, equitable care. I thank you.
Thank you. I now invite International Federation of Medical Students Associations.
Honorable Chairperson, esteemed delegates, we note with concern the inequities in access to emergency, critical, and operative care, particularly in low resources and conflict-affected settings. Globally, 6% of surgical procedures occur in low-resource countries, despite those being home to over a third of the world's population. As future health professionals, we recognize that timely access to these services is essential to universal healthcare and resilient systems. IFMSA urges member states to integrate emergency, critical, and operative care into universal health coverage, while strengthening health workforce, infrastructure, referral systems, and digital tools. Equitable access must be prioritized for all, especially vulnerable and marginalized populations. Health systems cannot be truly universal when access to essential services remain unequal. Thank you.
Thank you. I now invite International Lactation Consultant Association.
Thank you. A cornerstone of universal health coverage is the protection and support of breastfeeding to improve public health, reduce health disparities, and ensure safe feeding in emergencies. Sick and preterm infants may need donated human milk, which is regulated as a substance of human origin under laws for donation of human cells and tissues in many countries. Human milk is not yet included in the proposed global strategy on donation and transplantation of human cells, tissues, and organs. We recommend including it to ensure ethical practice, especially since donor human milk bank standards and implementation guidance from WHO and UNICEF are coming soon. Without ethical regulation, the paid collection of human milk by for-profit entities raises ethical concerns, including exploitation of women.
Unfortunately, time is up. I now invite International League Against Epilepsy.
Honorable Chair, Excellencies, distinguished delegates, the International League Against Epilepsy supports recognizing rare diseases as a global health priority to advance equity. Rare epilepsies and developmental epileptic encephalopathies often begin early, driving mortality, disability, stigma, and lifelong social economic burden. Inequities persist in access to genetic diagnosis, newborn screening, specialized care, essential medicines, and emerging precision therapies, especially in low and middle-income countries. Building on collaborative initiatives like ILA Europe and ILA Europe EpiCare, member states should integrate rare epilepsies into national rare diseases and universal health coverage strategies, expand diagnostic and multidisciplinary care, promote international research and data sharing, and ensure equitable access to innovation. I thank you.
Thank you. I now invite the International Pharmaceutical Federation.
Honorable Chair, distinguished delegates, the FIP Global Situation Report on Pharmacy states that achieving UHC by 2030 will require harnessing the full potential of pharmacists in primary health care. With enabling policies and investments, pharmacists can deliver far more in health promotion, disease prevention, and treatment optimization, ultimately improving access, well-being, quality, and equity in health for all. Despite their value, pharmacists remain under-recognized and underused in many countries' health policies and laws. Pharmacists are essential, yet often overlooked as fully integrated health professionals. We call on member states to develop and implement policies that enable pharmacists to put practice to their full scope and ensure equitable access to pharmacy services across all populations. Thank you for your attention.
Thank you. I now invite International Pharmaceutical Students Federation.
Honorable Chair, distinguished delegates, the International Pharmaceutical Student Federation, representing 600,000 members from more than 100 countries, reaffirm our strong commitment to advancing UHC. We believe UHC must be people-centered, equitable, and inclusive, with pharmacists playing a vital role in improving access, promoting prevention, and supporting continuity of care. At WHA 79, IPSF is campaigning a side event of UHC in collaboration with Sigma Nursing, highlighting the value of pharmacy-nurse collaboration and meaningful youth engagement in strengthening health system. As lead up to the IPSF USC Youth Summit in Bangkok on 6 August 2026, IPSF called for empowering young health professionals, investing in essential medicine, and removing financial barriers to advance equitable, people-centered care and achieve USC for all. Thank you.
Thank you. I now give the floor to Knowledge Ecology International.
Thank you very much. High prices lead to appalling disparities in access to insurance, as well as the products and services excluded from such insurance. The most widely used policies to induce investments in R&D are the grant of temporary monopolies, and this predictably raises prices for a generation. The WHO needs to re-engage in discussions on the progressive delinking of incentives to invest in R&D from the grant of a temporary monopoly. KEI asked WHO members also to implement provisions in WHO resolution on transparency WHA 72.8 and, among other things, report on the number of units of products sold, which is the most obvious and compelling metric illustrating whether access is universal or unequal.
Thank you. I now give the floor to Medical Women's International Association.
Thank you, Chair. The Medical Women's International Association, representing 12,000 women physicians across 70 countries, urges renewed political commitment to universal health coverage. In the context of geopolitical tensions and constrained global health financing, member states must strengthen national investments in UHC and ensure protection of vulnerable populations, especially women and children. MWIA welcomes efforts to advance precision medicine, integrated critical and operative care, equitable access and ethical oversight of transplantation services, and addressing rare diseases as essential components of UHC. Finally, we urge member states and partners to integrate sepsis into UHC benefit packages. Sepsis affects 26 million women, 20 million children under 5 annually, and it is...
Thank you. I now invite Medicus Mundi International Network Health for All.
This statement is supported by the People's Health Movement. We note with concern and alarm the stagnation in progress towards universal health coverage as outlined in the 2025 Global Monitoring Report. The world is no longer on a path toward realizing UHC by 2030. In light of this, we believe that the relegation of UHC to the discussion of individual focal programs represents a fundamental failure to properly discuss persistent inequities in health financing in this forum. It is troubling that selective programs are bundled together as standalone columns of care under the roof of UHC and not a comprehensive strategy for the realization of health for all. Framed in this way, UHC will remain a siloed vertical approach. Moreover, when we legitimize disease-specific care purchasing, we create undue space for the interests of for-profit private actors, including the technology and pharmaceutical giants. Fragmentation inherently undermines the decentralized, community-focused vision endorsed nearly 50 years ago in the Declaration of Alma-Ata. Thank you.
Thank you. I now invite Rare Diseases International.
Thank you, Honorable Chair and esteemed delegates. We welcome the report and stress that UHC must fully include the over 300 million people living with a rare disease. The adoption of Resolution WHA 78.11 made rare diseases a global health priority. Yet, many people living with a rare disease continue to face delayed diagnosis, high out-of-pocket costs, and limited access to essential medicines and services, leaving them behind in UHC efforts. We look forward to working with the WHO on developing a global action plan for rare diseases, which is essential to address these global challenges. Rare Diseases International urges member states to continue to embed rare diseases within UHC benefit packages and strengthen health systems to address their complex needs across the life course. The rare disease community stands ready to support WHO and member states in these initiatives. We thank delegates for their leadership on this important issue.
I see one member state asking for the floor. Sudan, the floor is yours.
Hello. Sudan Health recovery strategy is built upon two foundational pillars: universal health coverage and health security. In the face of the ongoing conflict and humanitarian challenges, our commitment to rebuild a resilient and inclusive health system to protect all the Sudanese. Our approach to prioritize the maintenance of essential services delivery through the foundational and operational support of the health facilities, continuous provision of the critical supplies and comprehensive capacity building, and to retain on the frontline health workers. We have investigated in building our relation and frontline health worker. We have incentivized efforts of strengthening emergency care and ambulance services, ensuring timely access of life-saving interventions for the most vulnerable and conflict-affected population. Central to our vision of the strengthening of the local health system as a health worker and backbone of the substantial services delivery, Sudan has fully endorsed the community health strategy, expanded integrated people-centered community health strategy, expanding integrated people-centered care at the grassroots, and the improvement of community health workers to deliver essential services. We are also focused on advancing digital health innovation, improving data system for evidence-based planning, and investigating in the climate-resilient infrastructure, including solarization, wash improvement, and continuing planning and willingness to environmental stock. Our efforts are driven by the enhanced coordination, policy development, regular strategy review, and robust monitoring and supervision at every level.
Thank you, Sudan. We now resume with non-state actors. The floor is given to International League of Dermatological Societies.
Honourable Chair, distinguished delegates, the International League of Dermatological Societies, representing all dermatologists worldwide, welcomes the recognition of rare diseases as a global health priority for equity and inclusion. We wish to highlight rare skin conditions, including oculocutaneous albinism, ichthyosis and epidermolysis bullosa, and many other genetic skin conditions, which require lifelong multidisciplinary care, shorten life expectancy, and place a significant burden on individuals, families, and health systems. We support efforts toward a coordinated global action plan for rare diseases and emphasize the importance of stronger collaboration, research, registries, and health information systems to improve visibility, diagnosis, and care pathways. Integrating rare diseases into national health planning and universal health coverage efforts will be essential to addressing long-standing inequities in access to care. Thank you.
Thank you. I now invite the transplantation.
Honorable Chair and distinguished delegates, the Transplantation Society, TTS, highlights the urgent need for a global strategy on donation transplantation to address the growing burden of organ failure globally. To achieve universal health coverage targets, we urge member states to implement key actions. First, establish regulated and ethical life and disease donation programs to achieve self-sufficiency and safeguard against organ trafficking and exploitation of the vulnerable. Second, designate national regulatory authorities within health ministries to oversee entire chain from donation to transplantation. Third, implement standardized biovigilance, mandatory transplant activity, and the outcomes reporting in lifelong follow-up of living donors. In closing, transplantation is a high-impact, essential component of health systems. TTS stands ready to provide technical expertise to guide integration into national health systems.
Thank you. I now give the floor to Women Deliver.
Thank you, Chair. I deliver the statement on behalf of ARROW, Women Deliver, and the Kaleidoscope Initiative.
As we recognize that health-related SDGs require accelerated momentum, addressing the integration of emergency care systems is essential for achieving true UHC, including for comprehensive sexual and reproductive health and rights information and services, and robust health system strengthening. Complications related to pregnancy remain a significant cause of acute critical illness and preventable mortality among women and girls globally. We encourage member states to ensure that comprehensive emergency obstetric care is fully integrated into national emergency critical and operative care framework, eliminating administrative and institutional delays for individuals experiencing reproductive health emergencies is a highly cost-effective intervention to reduce maternal mortality. Thank you, Chair.
Thank you. I now give the floor to Wonga Association.
The World Organization of Family Doctors calls on WHO and member states to recognize family doctors and primary care teams as key partners of universal health coverage. In integrated ECO, they support stabilization, urgent care, perioperative management, referral and follow-up, particularly in rural and underserved communities, where they also provide essential surgical services. Family doctors identify people who may need transplantation, provide culturally safe counseling on organ donation and advanced care planning, support ethical, equitable access, and deliver longitudinal post-transplant care. Family doctors also recognize early warning signs of rare diseases, coordinate referrals, and ensure continuity of care so no patient is disadvantaged by geography, income, or complexity. Investing in family medicine, protected workforces, digital tools, and clear pathways will strengthen equity, safety, trust, and people-centered UHC. Thank you.
Thank you. I now give the floor to World Confederation of Physical Therapy.
Thank you, Chair. Rehabilitation plays a vital role in emergency, critical, and operative care, supporting recovery, preventing complications, and facilitating the functioning that makes survival meaningful. Evidence confirms that strengthening rehabilitation across all levels of care contributes to the effectiveness and efficiency of health services and reduces pressure on overstretched emergency, critical, and operative care systems. World Physiotherapy, supported by the World Rehabilitation Alliance, is committed to the implementation of the draft global strategy for integrated emergency, critical, and operative care. Rehabilitation must not be an afterthought, but included from the outset and integrated as a routine standard of care for conditions addressable by emergency, critical, and operative care. Thank you.
Thank you. I now give the floor to World Federation of Neurology.
Thank you, Chair. The World Federation of Neurology, with 126 member neurological societies worldwide, supports the inclusion of rare diseases in universal health coverage schemes. Rare neurological conditions have a very significant prevalence and create high economic burden through progressive neurologic and mental health disability, high treatment and rehabilitation costs, and caretaker involvement. Incorporating neurological rare diseases in UHC frameworks will allow for earlier intervention, longer active lifespans for patients, preserve dignity, and reduce family and societal burdens. The WFN urges member states to strive towards equitable access to genetic testing, novel therapies, and multidisciplinary management and rehabilitation for patients with rare diseases. As a Society of Neurology Professionals, we believe access for all is a prerequisite of humane and sustainable healthcare systems. Thank you.
Thank you. And now I give the floor to the World Federation of Occupational Therapists.
Honorable Chair, distinguished delegates, UHC cannot be achieved if rehabilitation remains neglected. 1 in 3 people globally could benefit from rehabilitation, yet many go without it. Services are often excluded from coverage schemes and under-prioritized due to insufficient data. UHC monitoring frameworks, including SDG 3.8.1, omit rehabilitation and functioning, undermining visibility and accountability. In preparation for the 2027 UN High-Level Meeting on UHC, the World Federation of Occupational Therapists, with support from the World Rehabilitation Alliance, calls for integration of rehabilitation and functioning into UHC commitments and monitoring to strengthen investment and rehabilitation across care pathways, ensure that health goes beyond reducing mortality and morbidity, and enable social participation, inclusion, and workforce productivity. Thank you.
Thank you. I now give the floor to the World Federation of Societies of Anesthesiologists.
The WFSA welcomes the draft ECO strategy. Anesthesiologists are uniquely positioned as we work across the whole ECO continuum, and this is an important step forward for UHC. Successful implementation of strategy will only be achieved if clinicians, through their national societies, are central to the design, governance, and delivery of the training systems at the core of this strategy. This is not a new insight. Experience across countries consistently shows that externally driven or fragmented training approaches do not deliver sustainable system change. Training needs to be continuous, multidisciplinary, tailored to national context, and embedded within health systems. WFSA stands ready to support member states in translating this strategy into practical, workforce-led implementation that strengthens safe, timely, and equitable ECO care for all. Thank you, Chair.
Thank you. And now we invite World Obesity Federation.
Thank you. Good morning. 1 billion people are living with obesity right now, but millions continue to face stigma and limited access to evidence-based prevention and care. Obesity, a chronic, complex disease and major driver of other non-communicable diseases and health inequalities, is a growing pressure on health systems. And universal health coverage cannot be achieved without obesity-responsive health systems. We urge member states to ensure obesity is meaningfully reflected within national pathways towards UHC, primary care strengthening, and chronic disease strategies, including strengthening health system readiness to provide continuum of care through health promotion, prevention, early identification, counseling, psychosocial support and treatment where appropriate, training for healthcare professionals, addressing stigma and discrimination in healthcare settings, and expanding equitable access to evidence-based services in line with your national priorities and contexts. Thank you.
Thank you to all distinguished delegates. We have now concluded the list of statements. I would now like to invite the Secretariat, Dr. Nakatani, Assistant Director General, Health Systems, Access and Data.
Thank you, Chair. Thank you, Member States, your important contribution and valuable comments. All the topics and the resolutions are in front of us today, connecting a common thread, which is the resilient health systems. We must strengthen the health systems based on the primary health care approach, and this is the way to the achievement of the universal health coverage. Member states have reminded us also the urgent need for the integrated approach, inclusion, financial protection, and the crucial role of the health workforce. Global strategy on the emergency critical operative care will support the member states to provide life-saving services. The work is underway on the accompanying action plan now. And for the transplantation, we will arrange a regional consultation very soon as we develop of the draft strategy with the expert panel inputs. I thank Spain for long-standing support on this program. On the rare diseases, we continue to advance this priority for the equity and inclusion, working closely with the member states to support the implementation in the resilient health system and monitoring progress. And also, I thank member states for adopting of the 4 resolutions, agreeing the 4 resolutions on the stroke, teleradiology, precision medicine, and the pharmacovigilance. These resolutions bring strong commitments on the equitable access, innovation, and safety. It's pointed out of the important collaborations together with the WHO, such as the Uppsala Monitoring Center playing the crucial role to safeguarding the public health in the worldwide. And also the our collaborations within my team and the Jeremy's team, the Sylvie's team and Chikwe's team, and the regional country offices colleagues together. The Secretariat will continue to support member states in the building the resilient, equitable, sustainable health systems. Sustainability is really key because we all facing the constrained resources. We must our action on health systems focusing on the health sovereignty and self-reliance. This is the way to the progress, renew the progress to the achievement of the universal health coverage. I thank you. Back to Chair.
Thank you, Dr. Nakatani. Is the committee ready to note the reports pertaining to this discussion as contained in document A79/5? The reports are noted. Is the committee now ready to approve the draft resolution entitled Precision Medicine, a path toward targeted, personalized and equitable care, contained in resolution EB 158.R2? I see no objections. The resolution is approved. Is the committee now ready to approve the draft resolution entitled Strengthening Equitable Access to Diagnostic Imaging Through Teleradiology, contained in resolution EB 158.R3? I see no objections. The resolution is approved. Is the committee now ready to approve the draft resolution entitled Reducing the Burden of Stroke, Strengthening Prevention, Acute Care, Rehabilitation and Health System Readiness, contained in resolution EB 158.R4? I see no objections. The resolution is approved. Is the committee now ready to approve the draft resolution entitled Advancing Smart, Efficient Pharmacovigilance as an Essential Tool for the Robust, Sustainable, Resilient and Responsive Health Systems for Everyone, Everywhere, contained in resolution EB 158.R5? I see no objections. The resolution is approved. Is the committee now ready to approve the draft decision entitled Global Strategy for Integrated Emergency, Critical and Operative Care 2026-2035, contained in decision EB 158.4? I see no objections. This decision is approved. Is the committee now ready to approve the draft decision entitled Increasing Availability, Ethical Access and Oversight of Transplantation of Human Cells, Tissues and Organs, contained in decision EB 158.5? I see no objections. This decision is approved. This agenda sub-item is now closed. We will now take up the grouping of the following agenda items under Provide Health, sub-item 12.5, Primary Health Care, and sub-item 12.8, Report of the Expert Advisory Group on the WHO Global Code of Practice on International Recruitment of Health Personnel. The relevant documents are A79/5, A79/5 add 3, A79/5 add 5. Under sub-item 12.8, we are invited to consider the draft resolution contained in document A79/5 add 3. The associated financial and administrative implications are contained in document A79/5 add 5. I will now open the floor for discussions. Would those delegates wishing to speak please press the microphone button now? The microphone will open automatically when I call your delegation to take the floor. There is no need to touch the microphone button again, as this will remove you from the speakers list. I first give the floor to the delegate from Palestine, to be followed by Kenya. Palestine, you have the floor.
Thank you, Mr. Chairperson. Palestine has the honor to deliver this statement on behalf of the EMRO region member states, including my country, state of Palestine. Esteemed Mr. Chairperson, Your Excellencies, while the Eastern Mediterranean region has witnessed notable improvement in recent years, the latest conflicts and continuing compound fragilities have led to considerable setbacks. Despite the commitment of health ministers, the region faces a severe gap in access to care, driven by conflict, fragility, insufficient financial, workforce, care-driven shortages, and wide disparities across and within member states. Embracing a primary health care-oriented model of care results in less fragmented, more accessible services. For example, in Sudan, WHO has supported the integration of mental health and psychosocial support into primary health care services, including through mobile clinics reaching displaced populations. We need to commit to reprioritizing primary health care as the service delivery platform with the potential to serve up to 90% of an individual's health needs. We need to uphold, resource, and operationalize the Alma-Ata and Astana commitment by putting primary health care at the core of service delivery systems and pathways, ensuring coordination and continuity of care. We welcome the report of the Expert Advisory Group, which reiterates the relevance and effectiveness of the Global Code of Practice, as well as the need for increased efforts and commitment from member states towards its implementation. The recommendation of advisory group to pay special attention to countries in emergencies is highly relevant in the context of our region, where international mobility of health workers is increasing due to ongoing conflicts, protracted crises, and economic crisis, further exacerbating existing health workforce challenges. We welcome the concept of co-investment, solidarity, and collaboration for the health workforce among both destination and source countries, including by leveraging the large potential resource of diasporas with a strong willingness to contribute to their home countries. The regional flagship initiative facilitates dialogue among countries to address international mobility through multilateral, bilateral collaborative arrangements and to further invest in the health workforce. I thank you, Mr. Chairperson.
Thank you, Palestine. And now give the floor to Kenya, followed by Namibia.
Thank you, Chair. Kenya aligns itself with the statement delivered on behalf of the African states. On Agenda 12.5, Kenya calls for renewed global commitment to translating strong primary healthcare policies into effective implementation through investment in subnational capacity, integrated system, equitable financing, and community-centered approaches. Kenya is advancing PHC through the establishment of PHC networks, which have strengthened referral system, reduced facility workload, and improved patient-centered care. Community health promoters supported by multidisciplinary team are delivering household-level interventions and screening millions of hypertension, diabetes, and malnutrition. Innovation such as drone-based commodity distribution, household ultrasound, elderly care visits, and improved immunization and skill delivery coverage continue to transform health service delivery. On Agenda 12.5, Kenya reaffirms its commitment to the WHO Global Code of Practice on the international recruitment of health personnel as a key instrument for promoting ethical recruitment and health workforce sustainability. Kenya has strengthened health workforce governance through implementation of the National Strategy on Skills Development for Labor Mobility 2024, improved workforce information system, including the National Health Workforce Accounts, and enhanced bilateral cooperation framework. Kenya is also finalizing Healthcare Professionals Policy 2026 to strengthen training, retention, and equitable distribution. Kenya calls for strengthened global collaboration, sustained financing, and coordinated international actions to support equitable health workforce mobility and resilient health system. Thank you.
Thank you, Kenya. And now give the floor to Namibia, followed by Croatia.
Thank you, Chair. We have the honor to deliver this statement on behalf of the 47 member states of the World Health Organization African region. On item 12.5, we commend the Secretariat's leadership in advancing universal health coverage through primary health care. We acknowledge significant progress made, including increased UHC service coverage in African region and an increased health workforce from 5.1 million in 2022 to 5.7 million in 2024, as well as reduced health expense-driven poverty. However, the changing global financing landscape and the reduced aid to developing countries alongside geopolitics tensions is disrupting supply chains, inflating costs, and straining health budget for developing countries. Persistent underfunding and underinvestment in PHC undermines equitable access and sustainable health systems. African region calls for urgent action to address these disparities. These global challenges reinforce the need for PHC as the most cost-effective approach to sustain UHC. We call for the development of the PHC roadmap and urge support to member states to domesticate it. We implore all member states and partners to allocate adequate, sustainable resources to PHC. We must reinforce our health workforce, especially community-based services, leverage data, and address social determinants of health. On item 12.8, we commend the Secretariat and the Expert Advisory Group for a comprehensive report and improved member state participation in code implementation. However, we note that growing health worker immigration severely takes our fragile health systems, creating healthcare worker shortages. Targeted recruitment from the African region, often without robust accountability, is deeply concerning, compounded by insufficient investment in health workforce development and shortfalls in the work conditions. The African region firm believes the universal application for the code to all migrating health personnel across all contexts. We emphasize a win-win, ethical, and mutual beneficial partnership. In this regard, we believe that the destination countries must uphold ethical recruitment practices, fostering transparency and equity in bilateral agreement to minimize negative impacts, particularly in the African region. We call for the enhanced data collection and the integration for code provision into national policies. In conclusion, we echo the call for enhanced international cooperation to minimize negative impacts on source countries. The draft resolution must result in robust, equitable, and binding commitment supporting African health workforce sustainability. I thank you.
Thank you, Namibia. I now give the floor to Croatia, followed by Democratic People's Republic of Korea.
Mr. President, Croatia is making this statement on behalf of more than 30 member states of the group of friends of the WHO Academy. The friends attach the utmost importance to the two items currently under discussion on the agenda: the WHO Global Code of Practice on the international recruitment of health personnel and the strengthening of primary health care. On each of these points, we believe that the WHO Academy will have a major role to play in achieving concrete and sustainable progress. Through its expertise on issues relating to the international migration of health workers, the WHO Health Workforce Programme of Work, integrated in the newly configured WHO Academy, will be a key tool to support member states in implementing the WHO Global Code of Practice. The global quality and standards of recruitment and its implementation must be further improved in line with the principles of the Code, while supporting countries to build mutual beneficial partnership and engaging private sectors and other partners. As for strengthening primary health care, this depends first and foremost on the strengthening of workforce of health and care workers. We expect the Academy to put its expertise in lifelong training at the service of member states by expanding its already significant offering in the field of primary health care. The group of friends takes this opportunity to reiterate its expectations towards the WHO Academy. It is now important for the Academy to demonstrate through concrete actions that it is able to meet these expectations. Under the leadership of its next director, the WHO Academy should successfully carry out priority areas including, first, truly building on the excellent work, including normative of the Health Workforce Programme, while capitalizing internal synergies. Second, providing services, guidelines and training programs that meet the priority needs of member states, particularly those in the South. Third, establishing fruitful partnerships, including with the academic world. And fourth, consolidating and diversifying its resources and defining a business model that guarantees its sustainability. We, the member states of the group of friends, pledge our full support to the WHO Academy, its next director and the team. Thank you, Mr. President.
Thank you, Croatia. I now give the floor to Democratic People's Republic of Korea, followed by Kazakhstan.
Thank you, Mr. Chair. Democratic People's Republic of Korea has the honor to deliver this statement on behalf of member states of WHO Southeast Asia region. We reaffirm that primary health care remains one of the most powerful instruments for achieving the global vision of health for all. Primary health care existed in the CR region well before 1978 Alma-Ata Declaration on PHC and indeed helped to shape it. Key health systems challenge for countries in the region is the need to actively accelerate progress to achieve EHC by 2030. Well-functioning frontline services are part of the solution, but this will lead remarkable transitions. Member states of CR region would like to highlight the following priorities. First, PHC must be positioned as the core platform for integrated people-centered health systems, organizing essential services across NCDs, mental health, maternal and child health, infectious disease, emergency care, rehabilitation, and palliative care. Second, we need more investment in PHC quality, digital transformation, and climate-resilient infrastructure to ensure continuity of care in all settings. Third, sustainable PHC financing and strong governance are indispensable. PHC should form the backbone of the national UHC benefit packages with full coverage of preventive and promotive services, supported by multi-sectoral action, community accountability, and PHC-oriented workforce planning. Last but not least, significant transitions are required from member states' political commitment, equity, to practical implementation of effective solutions for all, as PHC is a technical agenda as well as political. We call upon WHO and technical agencies to intensify support, foster innovation, and champion PHC as the global pathway to equitable universal healthcare. Regarding the item 12.8, we reaffirm that health workers are central to improving health services and attaining UHC. Export advisory group reports find that code retains its full relevance in the context of growing international mobility and migration, escalating threats to health security, and increased interconnectedness of health systems. Representatives from 8 member states of our region participated in the consultation along with development of partners and research, academic and donor agencies. We emphasize to further strengthen the code's implementation, including with respect to those recruiters, alternative forms of recruitment, amongst others. Thank you.
I thank the delegate from Democratic People's Republic of Korea, and now give the floor to Kazakhstan, followed by Senegal.
Dear Mr. Chair, Kazakhstan continues the consistently strengthening of primary care with a particular focus on prevention, early diagnosis, and effective management of the most prevalent diseases. Special attention is being given to the development of integrated patient pathways aimed on ensuring early and continuous contact with PHS professionals on all health-related issues, thereby contributing to the achievement of universal health coverage. Currently, the extended primary care network covers all country population with health services. To strengthen engagement with the population, Kazakhstan is implementing multidisciplinary approaches designed to provide comprehensive support not only to patients, but also to their family members across all aspects of health and well-being. The multidisciplinary model also enables a more rational distribution of workload among healthcare professionals, which is particularly important in the context of the continuing health workforce shortage. To address the issues of staffing, Kazakhstan is implementing social benefits for specialists coming to work in rural areas. The financial support allows young professionals to purchase housing and establish themselves in the region. A mechanism is also being developed for differentiated pay system for time and service in a single organization for 3, 5, 10 years and more, along with the retirement for specialists who worked in rural areas for a long time. Kazakhstan remains open to international cooperation. The Coalition in Primary Health Care, initiated in 2023, is especially aimed at collaboration between countries tailored to regional and national contexts. Thank you, Mr. Chair.
Thank you, Kazakhstan. And now give the floor to Senegal, followed by India.
President, distinguished delegates, Senegal endorses the statement on primary health care made by Namibia on behalf of the Africa Group. My country commends the WHO Director General for the report on primary health care and fully shares the concerns raised, in particular persistent insufficient funding and limited investment in this area. The government, through its Senegal 2050 vision, seeks to ensure prosperous Senegal by making primary health care the heart of our policies and sustainable development. This commitment is reasserted in a letter on sectoral policy with particular emphasis on the promotion of health and community health. Since the Almaty Declaration of 1978, we have been fully integrated in the primary healthcare approach by integrating the Bamako initiative and taking measures to strengthen territorial communities and state coordination. Our plan on PHC is based on access to integrated health services, governmental leadership, partnerships, multi-sectoriality, and strengthening communication and community engagement, promotion, research, and innovation. Senegal has started ambitious reform of a national policy on community care, healthcare, putting community at the heart of health action and strengthening equity, efficacy, and resilience of the health system. We launch an appeal for lasting investment in primary health care, integrating public policies in order to guarantee that each citizen can implement their right to avoid financial ruin. Thank you.
Thank you, Senegal. And now I invite India, followed by Eswatini.
Thank you, Chair. Recognizing the necessity for strengthening primary healthcare, which is the foundation of UHC, India's comprehensive healthcare system delivers a range of services spanning preventive, promotive, curative, rehabilitative and palliative care under Ayushman Bharat, that is Long Live India scheme. Around 185,000 health and wellness centers, namely Ayushman Arogya Mandirs, have been established to bring health services closer to the community. In addition, telemedicine has emerged as a vital bridge between primary and tertiary healthcare by enabling teleconsultations that reduce the need for physical referrals. Its growing impact is reflected in the fact that India has conducted over 447.5 million teleconsultations to date, demonstrating the transformative role of the digital health in improving accessibility and efficiency of healthcare delivery. Chair, in alignment with the provisions of the WHO Global Code of Practices on International Recruitment of Healthcare Personnel, India's international partnerships in healthcare workforce mobility focus on fostering shared advantage.
Time is up. Thank you, India. And now give the floor to Eswatini, followed by Philippines.
Chairperson, the Kingdom of Eswatini is pleased to deliver a statement on these two agenda items. Eswatini reaffirms that primary health care is foundation of universal health coverage. In this regard, we are prioritizing the strengthening of community-based health services and our community health workers who remain the first point of care for our most vulnerable population. Eswatini further underscores the importance of data systems, addressing social determinants of health and forming country coalitions to accelerate primary health care progress towards universal health coverage. These two agenda items are deeply connected. We cannot strengthen primary health care without securing the health workforce that delivers it. Eswatini strongly supports the WHO Global Code of Practice on the international recruitment of health personnel. The continuous migration of skilled health workers from source countries like ours directly weakens our primary health system and our path to universal health coverage. We welcome the expert advisory group's recommendations and call for constructive engagement in member state-led informal consultations so this assembly adopts a robust, actionable decision. We call on destination countries to uphold ethical recruitment standards, honor bilateral commitments, and support health workforce strengthening in source countries. We further call for flexible application of the WHO Health Workforce Support and Safeguard List improved data system to track migration flows and enhance international cooperation to mitigate the damaging impact of health workers' migration on vulnerable health systems. I thank you.
Thank you, Eswatini. And now give the floor to Philippines, followed by Jamaica.
Thank you, Chair. The Philippines, as part of the core group with Germany, Bangladesh, and Pakistan, expresses appreciation to the expert advisory group for its comprehensive report. We reaffirm strong support for the WHO Global Code of Practice on the international recruitment of health personnel and its central role in promoting ethical recruitment and safeguarding health personnel welfare. We emphasize the need to translate the code into practice through fair partnerships, strengthening health systems, and equitable, mutually beneficial mobility arrangements. We also highlight the importance of co-investments by destination countries to ensure proportionate benefits for source countries and advance global health workforce sustainability. The Philippines believes the time has come for the Assembly to adopt the draft resolution. This marks the first revision of the code since its adoption and reflects our collective resolve to make global health workforce governance more responsive, accountable, and effective. We also call on the Secretariat to sustain investment and ethical support for health workforce development, even as it undergoes internal reorganization. A strong Secretariat engagement is indispensable for effective implementation of the code at country level. The Philippines also takes note of the report on primary health care. PHC remains the foundation of UHC and the most practical pathway for ensuring that communities, especially those facing geographic, financial, and social barriers, feel the benefits of UHC. Through these combined efforts, strengthening PHC and upholding the Global Code of Practice, the Philippines remains committed to working with the Secretariat and all member states to build resilient, equitable systems and ensure that no community or no health workforce is left behind.
Thank you, Philippines. And now give the floor to Jamaica.
Chair, Jamaica supports the recommendations of the Expert Advisory Group and reaffirms the importance of the WHO Global Code of Practice on the international recruitment of health professionals. Jamaica continues to experience the impact of migration of skilled health professionals, particularly nurses, midwives, and allied health workers. Jamaica emphasizes that recruitment practices must not compromise the source country's health systems. Jamaica has strengthened its national human resources for health agenda through targeted workforce planning, expansion of training opportunities and scholarship support, internship and residency programs, and ongoing recruitment of critical cadre across the public health system. The government has also advanced retention strategies through improved compensation packages, professional development, and investment in safer and more supportive worker environment. Jamaica is building South-to-South cooperation and is presently in negotiations with the Philippines, India, Ghana, and Nigeria. Our discussions have reinforced that countries in the Southern Hemisphere share the same challenges and can help each other through partnerships to bolster training and provide job opportunities. Jamaica supports the call for stronger bilateral cooperation, better workforce data systems, and greater investment in education, employment, and retention in source countries. We believe that fair and ethical international recruitment must deliver mutual benefit and contribute to stronger health systems globally. Thank you, Chair.
Thank you, Jamaica. Dear delegates, we have now come to the end of our meeting, and we will suspend our discussion. I would like to inform delegates that our afternoon session will start at 2 p.m., as announced in the Daily Journal. So the afternoon session will start at 2 p.m. When we resume, we will reopen the grouping of agenda sub-item 12.5 and 12.8. To continue our debate according to the current speakers list, delegates having already requested the floor should not touch the microphone button. Also, several official side events are taking place during the lunch break. Please refer to the official side event calendar on the WHA website and the app. The meeting is now closed.
Good afternoon. We will start the session for this afternoon. I have a few announcements to make. Delegates, before we start this afternoon, I would like to inform you that we will suspend our session at 4:30 to allow delegates to make their way to Palace to attend the 6th plenary meeting starting at 5 p.m. Thank you. We will now reopen the grouping of the following agenda items under Provide Health, sub-item 12.5, Primary Health Care, and sub-item 12.8, Report of the Expert Advisory Group on WHO Global Code of Practice on the International Recruitment of Health Personnel. The relevant documents are A79/5, A79/5 Ed 3, A79/5 Ed 5. When we suspended our discussion this morning, several delegates requested for the floor. The speakers list is displayed on the screen and the microphones will open automatically when I call your delegation to take the floor. There is no need to touch the microphone button again, as this will remove you from the speakers list. Are we ready? Okay, I will give the floor now to Antigua and Barbuda, followed by Saudi Arabia.
Thank you, Chair.
I have the honor of delivering this statement on behalf of the member states of the Caribbean Community, CARICOM. CARICOM welcomes the report of the third review of the WHO Global Code of Practice in the recruitment of health personnel, hereafter referred to as the Code, and notes the advancement made in its implementation. The Code remains especially relevant to small island developing states, SIDS, that experience some of the highest healthcare worker migration rates, contributing to intensifying workforce shortages. We recognize ongoing efforts to strengthen implementation of the Code and support the recommendations of the Expert Advisory Group. However, as a voluntary instrument, it has not meaningfully contributed to stemming the sustained loss of health personnel from small states. CARICOM therefore supports the incorporation of legally binding elements into the text and calls for high-level policy dialogue on the development of structured, ethical, and mutually beneficial bilateral and multilateral arrangements, co-investment in human resources for health, HRH, education and training, skills reinvestment, and managed circular migration. CARICOM also emphasizes the need for enhanced support to member states to strengthen workforce data systems, expand HRH-related research, strengthen the inclusion criteria for placement on the Health Workforce Support and Safeguards list, and define tangible yet flexible protections for listed countries, particularly vulnerable SIDS facing critical workforce shortages. These efforts must be matched by dedicated global financing for the Code's full implementation. Thank you.
Thank you. Now I will give the floor to Saudi Arabia, followed by Lesotho.
Sayyid Rais.
Mr. Chair, the Kingdom of Saudi Arabia would like to extend heartfelt thanks to the DG for his report, which stresses that PHC is the main pillar to achieve UHC by 2030. The success requires integrated reform when it comes to governance, workforce, health data systems. We stress that it is important to integrate PHC into national plans for UHC. This should be linked to performance indicators that are measurable with a focus on patient safety and high-quality services in order to have a preventive model that is based on community. It is equally important to provide technical and operational support to reform health financing and to integrate vertical programs in PHC framework to ensure the sustainability of essential services and improve access. In this framework, the Kingdom of Saudi Arabia and under our Vision 2030, we're going for a paradigm shift placing prevention and UHC and PHC at the heart of this model with the support of digital solutions, focus and efficiency. Once again, we stand ready to share experience with member states regionally and globally. Thank you.
Thank you. Now I will give the floor to Lesotho.
Chair, Lesotho aligns with the actively advances the global agenda on primary health care, digital health, and universal health coverage. For universal health coverage to be truly universal, care must reach remote and underserved areas. Community-based services are not merely an optional component of universal health coverage. They are foundational in achieving it. Community health workers are central to this effect. Lesotho has introduced a community health worker digital mobile application. The application enables community health workers to register all household members under their care and supports the collection, storage, and management of service delivery data for the clients they serve, while maintaining appropriate safeguards to protect personal patient information. In addition to Lesotho's experience through the community-based chronic care project, Combacal, implemented and in partnership with Solidamed and University of Basel, with support from the Swiss Agency for Development and Cooperation, Lesotho has recently demonstrated enormous potential for a strong community health worker program in combating non-communicable diseases. The trial in rural Lesotho have shown that community health workers, supported by digital clinical decision support tools, can safely and effectively screen for and connect with the healthcare workers for management of hypertension and type 2 diabetes. Investing in community health workers and digital platform is an indispensable investment in resilient and inclusive and effective universal health coverage. Lesotho stands ready to share our lessons and to learn from others. Thank you.
Thank you. As several constituencies of non-state actors in official relationship with WHO have requested the floor for this grouping of agenda items, I will give them the floor alternating from time to time with member states. According to these privileges conferred by relationship with WHO, I have the pleasure to give the floor to the constituency of non-state actors presented by International Agency for Prevention of Blindness.
Thank you. The statement is delivered by International Agency for the Prevention of Blindness on behalf of the Fred Hollows Foundation, Sight Savers, the Royal Commonwealth Society of the Blind, the World Council of Optometry, CBM Christian Blind Mission, Organisation pour la Prévention de la Cécité, and World Blind Union. Honorable Chair and distinguished delegates, we commend member states and WHO for their continued commitment to primary health care while recognizing the persistent underfunding and underinvestment in PHC globally. Today, over 2.2 billion people live with vision impairment or blindness, including at least 1 billion cases that are preventable or unaddressed. Yet eye care remains under-integrated within PHC, despite many eye conditions being manageable at primary care level with adequate resourcing, trained personnel, referral pathways, and essential services. Uncorrected refractive error remains a leading cause of vision impairment globally, although a simple pair of spectacles can restore vision and improve education, employment, productivity, independence, and quality of life. The economic case on eye health value of vision demonstrates that every $1 invested in eye health in LMICs can generate approximately $28 in economic returns through improved health, education, productivity, and participation. Integrating inclusive, people-centered eye care into PHC is therefore essential for advancing universal health coverage, health equity, and social and economic development. We welcome the inclusion of eye health within the 2019 and 2023 political declarations on UHC and urge member states to explicitly strengthen commitments on eye health, including its integration within PHC approaches in the 2027 political declaration, consistent with the resolution WHA 73.4 on integrated people-centered eye care. We also encourage governments to advance commitments at the Global Summit for Eye Health in Antigua and Barbuda in November. Thank you.
Thank you. Now I will give the floor to New Zealand, followed by Panama.
Tēnā koutou katoa. Thank you, Chair. New Zealand welcomes the Director General's report and strongly supports the emphasis on primary health care as the foundation of universal health coverage. We share the concerns highlighted by member states regarding persistent underinvestment, workforce pressures and inequities in access. Strengthening integrated, people-centred primary and community care is essential, not only to improve access and quality, but also to build resilience and address the growing burden of chronic disease and unmet need. In New Zealand, we are taking a focused approach to primary care reform. This includes expanding access through 24/7 digital primary care services, enabling more timely care regardless of location, strengthening multidisciplinary teams and national workforce planning, and reducing financial barriers through targeted protections and improved medicines access. We are also placing a strong emphasis on data, transparency and accountability. Consistent with the report's call to better measure progress, New Zealand is introducing a primary care monitoring framework and health target to strengthen visibility of access, timeliness and equity across the system. On the health workforce, New Zealand supports the continued implementation of the WHO Global Code of Practice. We agree on the importance of ethical recruitment, strengthened data systems and international cooperation to mitigate impacts on source countries. Like many countries, we face workforce constraints. Our response is to invest in domestic training, retention and new models of care while ensuring our international recruitment practices are responsible, transparent and aligned with global commitments. Chair, primary healthcare and workforce sustainability are inseparable. Progress will depend on sustained investment, stronger data and genuine international collaboration. New Zealand looks forward to working with the WHO and member states to share innovation, strengthen implementation and accelerate progress towards universal health coverage. Ngā mihi nui, thank you.
Thank you. Now I will give the floor to Panama, followed by Russian Federation.
Gracias, señor.
Thank you, Chair. Panama is grateful for the consolidated report, and we highlight the key role of primary healthcare as a foundation. We also are in favor of the Code of Practice on the international recruitment of health personnel as a key instrument for equitable recruitment. We are pushing forward with strengthening primary health care at the community level. We're integrating prevention, promotion, and care, and we're also strengthening integrated health services networks. We recognize that PHC is fundamental to dealing with communicable and non-communicable diseases alike and the social determinants of health. We want to highlight that the international mobility of health workforce can present opportunities and challenges. On the one hand, it can help develop and build their capacity, but it also can have a significant negative impact on the origin countries because they might have more fragile health services and a scarcity of health workforce. There are also challenges with respect to insufficient financing, access gaps, and in this context, Panama reaffirms that primary health care should link all levels of healthcare and UHC. We also believe that we need to build intersectoral partnerships and have integrated networks to meet the needs of vulnerable populations. We reaffirm our commitment to working towards a people-centered health system where primary health care is the effective point of entry. We call for stronger global cooperation to ensure that we can deliver sustainable health services. Thank you.
Thank you. Now I will give the floor to Russian Federation, followed by Bahamas.
Thank you, distinguished Mr. Chair, distinguished colleagues. The basic principles of Russian healthcare, free of charge and universal accessibility, have been unchanged for over 100 years now. In Russia, we have undertaken unprecedented modernization of the primary healthcare unit. In the last 5 years in our country, every day we have been opening about 8 modernized medical facilities. We stand ready to share our experience in building a national healthcare system, which was built as a standardized, united, interlinked, technologically equipped system, which includes all the necessary aspects from primary healthcare and prevention of diseases through to specialized, highly technological emergency healthcare. Particular attention has been given to integrating all levels of healthcare in a unified system to ensure continuity of medical care and effective exchange of data. We use modern organizational approaches, digital platform, and AI technologies for diagnosis, analytics, and routing of patients, as well as optimizing the work of medical institutions. We also develop our own production of medicines, equipment, which helps to strengthen the sustainability of the healthcare system. Thank you.
Thank you. Now I will give the floor to Bahamas, followed by Algeria.
Thank you, Chair. The Bahamas aligns with the Regional CARICOM statement on Agenda Item 12.8 and thanks the Secretariat for the reports. Primary health care is the heartbeat of universal health coverage, but cannot be delivered without an adequate, skilled, and retained health workforce. Through our National Health Insurance Framework and National Health Strategy, the Bahamas is strengthening primary and secondary care, improving service integration, expanding access, and placing prevention at the center of the health system reform. However, these goals are constrained by persistent human resource gaps. With limited HRH pools and the need to serve dispersed archipelagic populations, even modest outward migration can significantly affect service delivery, especially in specialized and hard-to-fill areas. Ethical recruitment must mean more than transparency, but also fairness, shared responsibility, and meaningful co-investment in source country health systems and training. The Bahamas supports stronger implementation of the code, but questions whether its benefits are being shared equitably or whether this framework is fit for purpose, given that source countries bear the cost of training and the consequences of workforce depletion. We therefore call on the Secretariat to provide targeted technical support to SIDS on practical co-investment models and strengthen accountability so that health worker mobility benefits both source and destination countries. These pressures are further compounded when SIDS face external constraints and limit partners with whom we may engage to augment our health workforce. Such constraints narrow options, weaken bargaining options, and make it harder to close urgent service gaps. In closing, a fair global workforce architecture must preserve the ability of vulnerable countries to pursue legitimate and mutually beneficial workforce partnerships. Thank you.
Thank you. Now I will give the floor to Algeria, followed by Pakistan.
Merci, Monsieur le Président. Thank you, Chair. My statement speaks on the outreach, that is to say, to protect health. This is the linchpin and the guarantee of health care. It builds confidence in our populations at all stages of their life cycle. This should be people-centered and not disease-centered, and we must integrate prevention and promotion in the same continuity. We must also ensure that primary health care services provide vital services such as maternal health and vaccinations and chronic disease care. We must streamline investment as well at the government level. This is the best way to improve health indicators and reach those who are most in need. We also need political goodwill to ensure that there are fiscal measures to provide this health care. This reaffirms the importance of tackling the gaps in healthcare. We have to ensure that there is outreach, and we must follow the vaccine schedules. We have over 7,000 healthcare workers providing this level of care in schools. And in addition to that, we have mobile clinics with sophisticated equipment to screen for cervical cancer, among other diseases. This is also contributing to the certification of trachoma elimination in Algeria since 2016. Thank you.
Thank you. Now I will give the floor to Pakistan, followed by Iran.
Thank you, Chair. We take the floor on agenda item 12.8. Pakistan joined this core group with high ambitions and with reason. Every year, we invest heavily in training doctors, nurses, and allied health workers. We bear that cost willingly because our people need care. But the hard truth is that many of these workers leave, recruited by high-income countries that save billions on health professional education they never had to fund. The Expert Advisory Group has documented this reality in black and white, and it is reflected in PP 10 of this very resolution. Meanwhile, Pakistan contends with fragile health system, climate catastrophes, conflict on our borders, and shrinking fiscal space. We came to these negotiations asking for justice, not charity. We pushed for ring-fence financing. We pushed for binding co-investment obligations. We pushed for language that would give this resolution real teeth. What remains in OP3 is an encouragement where we sought an obligation. And yet, we did not walk away empty-handed. Proportional benefits, operationalizing co-investment, concrete financial mechanisms, including ODA, these are in the text, and they matter. The Director General will report on how these commitments take shape, over the next 3 years, we will be watching carefully and with long memories. We would also ask the Secretariat, how many full-time staff will be dedicated to advancing the code agenda? Ambition must be matched by capacity. The resolution is a beginning, Chair, but the current text does not reflect the scale of the problem nor the urgency that source countries feel. Pakistan supports adoption with expectations. I thank you very much.
Thank you, Pakistan. We will now give the floor to Iran, followed by Nepal.
Mr. Chair, distinguished delegates, Iran reaffirms its strong commitment to achieving UHC through a primary healthcare approach as the foundation for equitable, resilience, and people-centered health systems. In the face of growing global challenges, including economic pressure, conflicts, sanctions, and increasing demand on health systems, Iran believes that strengthening PHC remains essential to achieving the goal of health for all. In this regard, Iran continues to strengthen its nationwide PHC network through a focus on prevention, equity, digital health, public participation, innovative service packages, and self-care services. We emphasize that achieving UHC through PHC is not only a health priority, but also a social, humanitarian, and moral imperative. Sustainable financing, workforce empowerment, resilient health systems, strengthened referral systems, access to medicine and medical equipment, and effective monitoring and evaluation are all critical to advancing this agenda. Iran also appreciates the ongoing discussions on healthcare workforce challenges. As a source country, Iran has experienced increasing migration of health personnel, which affect the service continuity, particularly in underserved areas. Despite our extensive health network, workforce outflows create additional pressures on health systems influenced by active international recruitment and external constraints. Iran welcomed the direction of the current document and calls for greater attention to specific circumstances of countries of origin, including enhanced technical support and strengthened monitoring mechanisms based on measurable indicators such as workforce density, retention rates, and net migration rates. Iran remains committed to working closely with WHO member states to strengthen PHC, support health workforce, and advance.
Thank you. Now I will give the floor to Nepal, followed by International Alliance of Patients Organization.
Mr. President, I'm speaking on agenda item 12.8. Nepal thanks the core group for leading the consultations and the Secretariat for the support provided for the negotiations. My delegation engaged in these negotiations on international recruitment of health personnel driven by a necessity. Despite the constrained fiscal space, source countries invest substantively in training health professionals only to see those investments walk out the door. When these trained professionals are recruited internationally at scale, our investments effectively subsidize the health workforces of destination countries. The expert advisory group has documented this reality clearly. The resolution being considered today seeks to rebalance that equation. Preamble of paragraph 10 is clear, Mr. President. High-income destination countries make substantial savings through international recruitment. The expected investments in the health systems of developing source countries have not materialized. We therefore welcome this resolution's textual amendments to the code, particularly those on co-investment by destination countries. As operative paragraph 3 of the resolution asks, we encourage destination countries to establish mutually agreed, structured, measurable, and transparent co-investment arrangements. These commitments are now embedded in the code. This is a meaningful progress. We had pushed for more, but we recognized what has been achieved. We will continue advocating for a stronger enforcement mechanism and clear pathways for co-investment, including through ring-fence financing. The Secretariat must be adequately resourced, strategically positioned, and fit for purpose at all 3 levels to support implementation of this resolution. Nepal supports adoption of the draft resolution as a co-sponsor. I thank you. And to echo Pakistan, who spoke earlier, we will monitor the progress with rigor while the DZ will report on implementation. Thank you.
Okay, now we will give the floor to International Alliance of Patients Organization, followed by Slovenia.
This statement is delivered by IAPO, the International Alliance of Patients Organizations, on behalf of International Society for Biomedical Research on Alcoholism, WaterAid International, ANESVAD Foundation, Global Network of People Living with HIV, World Heart Federation, Worldwide Hospice Palliative Care Alliance, the Task Force for Global Health, International Association for Hospice and Palliative Care, World Federation of Hemophilia, World Federation of Societies of Anesthesiologists, International Association of Communication Sciences and Disorders, Health Action International, World Obesity Federation, International Diabetes Federation, Women in Global Health, Global Health Partnerships, Global Healthcare International Network, SIG, Multiple Sclerosis International Federation, Sight Savers, World Federation of Chiropractic, International Society for Telemedicine and E-Health. Honorable Chair, distinguished delegates, we speak on behalf of patients, people with lived experience, and health communities worldwide. We welcome the Director General's report on primary healthcare as the foundation for universal health coverage. PHC is where most people meet the health system or fail to, particularly for caregivers and persons living with HIV, NTDs, NCDs, mental health conditions, rare diseases, bleeding disorders, or multi-morbidity. PHC is not an abstract reform. It determines whether we are diagnosed early, treated with dignity in a clean, safe environment, and supported across the life course, including access to acute and palliative care. We highlight 3 priorities as the 2027 high-level meeting on UHC approaches. First, meaningful engagement. The report stresses empowered people and communities, yet our constituencies remain inconsistently included in PHC design, financing, implementation, and governance. Social participation must move from principle to practice. Second, person-centered integration. Fragmented vertical programs still shape care pathways. Person, not disease-centered integration is essential, including for HIV, NTDs, NCDs, circulatory health, comorbidities, and acute conditions. Third, accountability with people-centered indicators. Covered metrics alone do not capture quality, safety, equity, or experience of care. Monitoring frameworks must include functioning measures co-developed with those they are meant to serve. We stand ready to work with WHO and member states to translate the promise of.
Thank you. Now I will give the floor to Slovenia, followed by France.
Honorable Chair, distinguished delegates. Slovenia prides itself on one of the most advanced primary healthcare models, built upon a gatekeeping system with a broad range of services and a concept of holistic patient care. Crucially, all these services, including comprehensive preventive programs and mental health services within health promotion centers, are fully covered by compulsory health insurance, ensuring equitable and universal access without financial barriers for patients. After productive collaboration with WHO office in Kazakhstan and through analysis of the primary health system, the strategy for the development of primary healthcare until 2031 was adopted to further strengthen the multidisciplinarity and holistic nature of primary healthcare in Slovenia. Primary healthcare in Slovenia remains a sustainable model of accessible, efficient, prevention-oriented and patient-centered care, which resulted in WHO nominating Healthcare Center of Ljubljana as a WHO collaborating center on family medicine development. We look forward in working together with WHO and other MSs in searching for innovative solutions to further developing primary health care as a fundamental pillar of health system. Thank you.
Thank you. Now I will give the floor to France, followed by Japan.
Thank you, Chair. France endorses the statement made by Croatia on behalf of the group of Friends of the WHO Academy. Aware of the need for international mobility of health staff, which is regulated and takes place in the mutual interest of countries of departure and arrival, and respectful of the well-being and professional development of those concerned, France attaches great importance to the effective implementation of the WHO Code of Practice on the international recruitment of health personnel. France believes that PHC is the basis, the foundation of the entire public health system. How is it possible to design national, effective health care system which is not based on a PHC health system to which everybody has access? We have made this a priority of our global system. We invite WHO to place PHC at the heart of its efforts to strengthen the health system. Thank you.
Thank you. Now I will give the floor to Japan, followed by United Kingdom.
Thank you, Chair. Japan aligns itself with the group statement made by Croatia on behalf of the Friends of the WHO Academy. We express our deep appreciation for the steady progress achieved across all regions in strengthening health systems grounded in primary health care. These country-led efforts constitute a vital driving force toward the global realization of universal health coverage. PHC provides the essential foundation for overcoming fragmented disease-specific approaches and for integrating diverse health programs into resilient, equitable, and sustainable systems. We underscore the importance of sharing knowledge and experience, as well as advancing PHC-oriented reforms as critical steps toward achieving UHC in practice. In this regard, strengthening domestic health financing systems and promoting cross-country learning remain indispensable. We also commend the UHC Knowledge Hub jointly established by WHO and the World Bank for fostering collaboration between health and finance authorities and supporting capacity building and policy dialogue, particularly in developing countries. Turning to the health and care workforce, we appreciate the Secretariat's report and support the draft resolution, including the proposed revision of the WHO Global Code of Practice in line with Decision EB 158. Ensuring an adequate and high-quality workforce is indispensable for advancing PHC and achieving UHC. We have therefore continued to support workforce development through bilateral cooperation, including JICA, and in partnership with WHO. We particularly welcome the clear recognition of care workers in the revised code. As one of the most rapidly aging societies, we remain committed to sharing our experience and strengthening international cooperation to promote equitable and sustainable health systems. Thank you.
Thank you. Now I will give the floor to United Kingdom, followed by Dominican Republic.
Thank you, Chair. The United Kingdom reaffirms its strong and enduring commitment to the WHO Global Code of Practice on the international recruitment of health personnel. We welcome the finding of the Expert Advisory Group and the updates to the Global Code. We appreciate the considerable effort of Member States to reach consensus on this resolution. The Code remains an important global framework for promoting ethical international recruitment, supporting health workforce sustainability, and strengthening collaboration between Member States. We recognise its growing relevance in the context of an increasingly interconnected global health workforce. In this context, we underscore the voluntary nature of the Code and support provisions that ensure any co-investment within partnership approaches is based on mutual agreement and reflective of national contexts, priorities, and existing frameworks. These arrangements should remain flexible and proportionate, supporting practical cooperation between source and destination countries. The United Kingdom has long been a champion of the WHO Global Code. We will continue to work with WHO to ensure our UK Code of Practice for international recruitment remains aligned and to support effective implementation, including through partnerships that build capacity, support skills exchange, and deliver mutual benefit. Thank you.
Now I will give the floor to Dominican Republic, followed by International Association for Dental Research.
Thank you, Chair. The Dominican Republic reaffirms its commitment to strengthening health systems, more equitable, sustainable and resilient systems, recognizing PHC as a strategic pillar for achieving UHC and effectively responding to current health challenges. We welcome the reports submitted on PHC and the Global Code of Practice on the international recruitment of health personnel, because these are complementary tools to strengthen health workforces and the health system. We think that strengthening PHC means not just expanding services, but ensuring that there is effective governance, sustainable financing, and strengthened workforce that can meet the needs of the population using a territorial, people-centered approach. We also recognize that the current mobility of international health workforce is important for sustaining health systems, especially in middle-income countries. We therefore think it's vital to have co-responsibility mechanisms and partnerships between origin and destination countries, and building capacity domestically as well as one of the means of doing so. We will continue to work along with member states and the WHO to build health systems that are more integrated, resilient, people-centered, and focused on robust PHC, and ones that are prepared to meet the present and future needs of our populations. Thank you.
Thank you. Now I will give the floor to International Association for Dental Research, followed by Micronesia.
Thank you. Chairman, distinguished delegates, this statement is being read on behalf of the International Association for Dental Research, AMREF Health Africa, FDI World Dental Federation, Global Health Council, Global Health Partnerships, Global Self-Care Federation, International Diabetes Federation, International Federation of Biomedical Laboratory Sciences, International Society of Nephrology, Multiple Sclerosis International Federation, World Federation of Hemophilia, World Obesity Federation. No health without oral health. Growing evidence links oral health with systemic conditions such as obesity, diabetes, cardiovascular disease, stroke, kidney disease, cancer, adverse pregnancy outcomes, bleeding disorders, and respiratory infections. Integrating oral health can strengthen prevention, enable earlier detection, and improve the comprehensive management of chronic conditions. We call on member states to integrate essential oral health services into primary health care and universal health coverage, and embed oral health in national monitoring, oral health information systems, and accountability frameworks, aligned with the WHO Global Oral Health Action Plan. Strengthening primary health care requires a decisive shift towards integrated, prevention-orientated systems that address health across the life course. Early action on nutrition, health environments, self-care and oral health promotion can reduce childhood obesity and NCDs and shape lifelong health. We encourage member states to invest in early life interventions and sustained person-centered care that support healthy aging, preserve function, cognitive health, and promote dignity and quality of life. Effective primary health care must also address upstream and commercial determinants of health through coordinated multi-sectoral action. We urge member states to strengthen primary health care governance through inclusive country-led coalitions that empower people living with NCDs, communities, and civil society. Progress requires sustained investment in multidisciplinary workforces, community-based services, implementation research, and robust data systems to guide decisions and ensure accountability. We stand ready to support Member States through research, innovation and collaboration. Thank you.
Thank you. Now I will give the floor to Micronesia, followed by Romania.
Thank you, Mr. Chairman. The Federated States of Micronesia welcomes the report on primary health care and strongly agrees that primary health care remains the foundation of universal health coverage and resilient health systems. For small island nations, primary health care is often the first and sometimes the only point of care available to remote communities. Therefore, strengthening primary health care is very necessary to ensure that island communities and peoples have equitable access to essential health services. Micronesia also shares concerns regarding persistent underfunding and underinvestment in primary health care globally. Sustainable financing, workforce development, and strengthened community-based services are critical priorities for Micronesia. We particularly support WHO's emphasis on integrated approaches that address all diseases through primary health care while also tackling the broader determinants of health. In island settings, strong primary health care systems are necessary not only for routine care but also for disease outbreak response and for continued and sustained delivery of essential health services for maternal and child health, mental health, communicable and non-communicable diseases, and others, especially during emergencies. For Micronesia, investments in community health workers, digital health solutions, transportation and telecommunication systems, and decentralized healthcare services are key and critical to ensuring that no community, no person is left behind. Micronesia thanks WHO and our partners for your continued support to small island nations and reaffirms our commitment to strengthening people-centered, resilient, and equitable primary health care systems. Thank you, Chair.
Thank you. Now I will give the floor to Romania, followed by Ireland.
Thank you very much, Mr. President. Mr. President, I will express our position on the agenda point 12.8. Romania welcomes and supports the adoption of the draft resolution on the Code of Practice of the international recruitment of the health personnel and thanks the member of the core group, namely Bangladesh, Pakistan, Germany and the Philippines for their work and cooperation in preparing such an excellent document. Romania, at the same time, Romania has the honor to announce from the floor the co-sponsorship of the above-mentioned resolution by the following member states: Austria, Belgium, Bulgaria, Croatia, Czechia, Denmark, Estonia, Finland, France, Germany, Greece, Ireland, Italy, Latvia, Lithuania, Luxembourg, Malta, Netherlands, Poland, Portugal, Romania, Slovakia, Slovenia, Spain, and Sweden. Thank you very much, Mr. President.
Thank you. Now I will give the floor to Ireland, followed by Indonesia.
Thank you, Chair. Ireland reiterates the importance of ensuring equitable access and strengthening primary health care as the foundation of universal health coverage. To truly transform health outcomes, countries must scale up investment in primary care. To this end, Ireland has increased investment in primary care services through a suite of strategic reform initiatives that seek to reduce dependency on the hospital system, with service delivery reorientated towards general practice, primary care, and integrated community-based services. This has improved access to and the affordability of primary care services, delivering expanded eligibility and reducing the cost to patients. Chair, a strong and well-supported health workforce is critical to building resilient health systems and ensuring equitable access to quality of care for all. In this regard, Ireland continues to support and value the principles of the WHO Global Code of Practice on the international recruitment of health personnel and its aims to balance the need of source countries, destination countries and the health workers themselves. Ireland also supports renewed efforts to strengthen the implementation of the Code and welcomes the informal consultations focusing on the Expert Advisory Group recommendations. In alignment with the Code and recommendations of the Expert Advisory Group, Ireland is seeking to strengthen its workforce sustainability and has developed an evidence-based strategic direction for the health and social care workforce for the next 15 years, as set out in the paper Ireland's Future Health and Social Care Workforce. Furthermore, Ireland is making efforts to increase our domestic supply of health and social care workers and to support partner countries through programmes that co-invest in training capacity and health system strengthening. Thank you.
Thank you. Now I will give the floor to Indonesia, followed by Colombia.
Thank you, Chair. Universal health coverage goes beyond financing. Equally important, UHC is about ensuring service coverage by bringing quality healthcare closer to where people live. Achieving this requires strong primary healthcare that adopts a people-centered and life course approach supported by sustainable financing and an adequately distributed health workforce. Indonesia welcomes the Director General report and aligning with national efforts. Since 2021, Indonesia has been implementing a health system transformation built on the spirit of reaching the unreached, with primary health care remain at the core of our transformation. We are reforming primary health care by standardizing and digitizing nearly 10,000 primary health care, while also implementing a nationwide free health screening aimed at reaching 280 million Indonesians as an effort to strengthen preventive action. Indonesia is also strengthening health workforce planning through capacity development and closing the gap in specialist doctors through university and hospital-based specialist programs to accelerate the education and deployment of doctors to remote underserved areas. Furthermore, Indonesia welcomes the adoption of the code with note that it should ensure fairness and balanced benefits between source and the destination countries and enhance international support, including financing and technical assistance for countries affected by health workforce migration. In closing, Indonesia firmly believes that investing in primary health care means investing not only in better health outcomes, but also in stronger and more resilient nations. Thank you, Chair.
Thank you. Now I will give the floor to Colombia, followed by the Maldives.
Gracias.
Thank you, Chair. The issues before us are a reminder that achieving more effective health systems means we mustn't just expand capacities, rather we must ensure that we provide timely responses to underserved persons and communities. Regarding PHC, it is our view that this should not only be understood as expanding services or strengthening the first level of care, but rather it is also an opportunity to identify needs and the risks and do so early, and make sure that responses reach persons and communities. In this connection, we have strengthened our model through territorial teams and the integration of networks that help us reach people more quickly and in a coordinated fashion. Regarding health workforce, we believe that the human talent is a strategic resource for health systems. Our public HR policy establishes guidelines for strengthening training, equitable distribution, retention, and the integrated well-being of health workforce. We reaffirm our commitment to the Code of Practice on the international recruitment of health force workers, and we recognize the value of cooperation to strengthen capacity. We believe it is also equally important to ensure that these mechanisms effectively contribute to strengthening health systems sustainably and avoid reproducing asymmetries or deepening gaps when it comes to capacity and the availability of human talent. Thank you.
Thank you. Now I will give the floor to Maldives, followed by NCD Alliance.
Thank you, Chair. The Maldives thanks the Secretariat for the report and aligns with the concerns raised regarding persistent underfunding and underinvestment in primary health care. As highlighted, strengthening primary health care is fundamental to achieving universal health coverage and ensuring equitable access to essential services. In the Maldives, non-communicable diseases account for 84% of all deaths. This underscores the urgent need to further strengthen primary health care as the foundation for prevention, early detection, and continuity of care. We recognize that effective primary health care requires sustainable financing, a strengthened health workforce, including community-based services and robust data systems to monitor progress and guide policy decisions. At the national level, the Maldives has made steady progress through the primary healthcare revitalization rollout program, now expanded to 14 atolls. This initiative promotes a team-based approach to care delivery and strengthens the coordination across levels of care. The program has also introduced a health information system, which is supporting data-driven decision-making, improving accountability, and enabling more effective responses to non-communicable diseases and their risk factors. However, challenges remain, particularly in ensuring quality and continuity of care, strengthening community engagement, and addressing the broader social, environmental, and commercial determinants of health areas that requires sustained multi-sectoral action. The Maldives calls for strengthened WHO support through targeted technical assistance, capacity building, and sustainable financing mechanisms to ensure equitable access and to further reinforce primary health care systems. Thank you.
Thank you. Now I will give the floor to NCD Alliance, followed by Singapore.
Thank you, Chair. This statement is coordinated by the NCD Alliance and supported by the Global Surgery Umbrella, Women in Global Health, HelpAge International, Society on Thrombosis and Hemostasis, World Cancer Research Fund International, International Diabetes Federation, World Heart Federation, International Association for Suicide Prevention, the International Society of Pediatric Oncology, World Stroke Organization, International Federation on Aging, Vital Strategy, Multiple Sclerosis International Federation, World Federation of Chiropractic, the Union for International Cancer Control, International Society for Biomedical Research on Alcoholism, and the Medical Imaging and Technology Alliance. Distinguished delegates, primary health care is the foundation of resilient, equitable health systems and essential to delivering universal health coverage and an effective response to NCDs and mental health across the life course. Yet, health promotion and NCDs, the leading cause of death, remain poorly integrated into PHC systems. We urge Member States to integrate NCD prevention and care into PHCL health benefit packages, including prevention, diagnosis, treatment, rehabilitation, palliative care, ensuring effective referral pathway across levels of care and health services. To implement the target set in the 2025 Political Declaration on NCDs and mental health, to ensure 80% of PHC facilities in all countries have affordable availability of WHO recommended essential medicines and basic technologies for NCDs and mental health conditions. To ensure that PHC-oriented reforms are guided by current and projected disease burdens, including NCDs, and informed by disaggregated data. To ensure a people-centered approach that embeds community-based services and workforce with meaningful engagement of communities and people living with NCDs in designing and implementing PHC services. To increase financing and reduce financial barriers at the PHC level, avoiding out-of-pocket expenses. The road to the 2027 UHC high-level meeting should be used to elevate PHC as a foundation and secure stronger commitment for integrated NCD prevention and care within PHC systems. Thank you.
Thank you. Now I will give the floor to Singapore, followed by Oman.
Thank you, Chair. Singapore wishes to share 3 lessons from Healthier SG, our multi-year transformative approach to primary care reform. First, we are moving from episodic visits to trusted long-term patient-provider relationships anchored on a one resident, one regular family doctor model. This approach strengthens continuity, accountability, and preventive care. Second, we are aligning care across public and private sectors by streamlining care protocols, financial schemes, and partnering with broader community partners and social services, recognizing that health outcomes are shaped beyond the clinic. Third, Singapore's experience underscores the importance of financing reform. We are progressively moving beyond fee-for-service towards capitation and value-based care, aligning incentives with population health outcomes. Singapore is committed to strengthening primary care as the foundation of universal health coverage. More details are in our written statement. Thank you.
Thank you. Now I will give the floor to Oman, followed by Papua New Guinea.
السيد الرئيس تتقدم سلطنة عمان
Chair, We would like to thank the Secretariat of WHO for the report presented on primary health care. We support the efforts of WHO to promote PHC as a foundation to implement universal health coverage and to ensure more flexible and more sustainable health systems. Oman highlights its commitment to the PHC approach. We provide free of charge health services or inexpensive services that guarantee equitable access to vital services. More than 98% of inhabitants live at a distance which is, does not go beyond 3 kilometers from PHC institutions. This reflects the fact that the coverage is very broad. Oman also promotes preventive and early diagnosis and screening and neonatal screening campaigns, also rectal cancers and perinatal cancers. So because we are very aware of importance of early intervention. There are still challenges, however, remaining with regard to increase in NCDs and the problem of funding. Problems linked to the development and training of health staff and strengthening complementarity between the various levels of care. This is why we highlight the importance of the support provided by WHO to member states, and in particular in terms of capacity building, developing of performance indicators, strengthening health information systems, and implementing sustainable financing models. We highlight the importance of investing more in PHC and broadening virtual healthcare services.
Thank you. Now I will give the floor to Papua New Guinea, followed by Tanzania.
Distinguished delegates, Papua New Guinea thank the Secretariat and the Expert Advisory Group for this report on WHO Global Code of Practice on the international recruitment of health personnel. For small islands and developing states like ours, the health workforce crisis is not theoretical. It is immediate and deeply felt. We face persistent shortage of doctors, nurses, and midwives, particularly in rural and remote communities where the majority of our population live. This greatly impacts our ability to deliver primary healthcare interventions and programs. At the same time, international migration continues to draw skilled health workers away from our system. While we respect individual rights to migrate, the imbalance this creates places significant strain on already fragile health services. The code remains highly relevant, however, implementation must move beyond commitment to measurable action. Papua New Guinea calls for stronger investment in domestic workforce training, retention, rural deployment, more effective and transparent bilateral agreements that include support for source countries, better data and monitoring of health worker mobility, and practical measures to reduce active recruitment from countries with critical shortages. We also emphasize the importance of sustained technical and financial support from WHO and partners. Chair, without a stable, well-supported workforce, primary health care and universal health coverage cannot be achieved. We urge collective responsibility and accelerated action. I thank you.
Thank you. Delegates, let me remind you that we will suspend our discussion at 4:30 p.m. to allow delegates to make their way to the 6th plenary meeting starting at 5 p.m. Now I will give the floor to Tanzania, followed by Spain.
Thank you, Chairperson. The United Republic of Tanzania aligns itself with the priorities outlined by WHO, which reaffirms primary health care as the most effective pathway to achieve universal coverage, health security, and overall system resilience. We recognize primary health care as a strategic approach to delivering integrated, people-centered services while addressing the broader determinant of health. Guided by the principles of the Almaty and Astana Declaration, Tanzania continues to place primary health care at the core of the national health agenda. Chairperson, Tanzania is advancing the integration of essential health services through PHC platform. We are also leveraging digital health innovation, strengthening health information systems to enhance coordination, data use, and accountability, consistent with the WHO's call for evidence-driven decision-making. We remain committed to addressing persistent inequities in access to care, expanding sustainable financing for primary health care, and fostering multi-sector collaboration to tackle the social and environmental determinant of health. Tanzania underscores the importance of partnership, knowledge sharing, and country-to-country learning among PHC implementers. We stand ready to collaborate with the member states and partners to advance the global PHC agenda and achieve universal coverage for all. Thank you.
Now I will give the floor to Spain, followed by Cuba.
Spain supports the statement delivered by Croatia, and we co-sponsored the resolution on the Code of Practice. We continue to place primary health care as the background of our national health system, and we remain strongly committed to its strengthening it as an essential element for achieving more resilient, equitable, and people-centered health systems. We're convinced that robust primary health care improves the decision-making capacity of the system, and it makes healthcare quicker. We also believe that strengthening promotion, prevention, and community-based activities will help us improve health outcomes and reduce inequalities. We have three priorities: attracting and retaining talent, strengthening the case resolution capacity, improving governance, and also, more importantly, ensuring universal and equitable access. Turning to human resources, we are promoting stability and motivating our professionals through annual job fairs, more job flexibility, and we're also looking at the common model for planning adapted to populational needs. We're also looking at the case resolution capacity by looking at the common portfolio of services, and we are simplifying administrative processes and we are trying to improve care for citizens in vulnerable situations, including homeless people. Spain has been actively participating in international initiatives to strengthen PHC, including at the European Union and WHO levels. Thank you very much.
Thank you. Now I will give the floor to Cuba, followed by Ghana.
Señor Presidente.
Chair, universal healthcare is a concept that encompasses all essential health services, from promoting health to preventing, treating, rehabilitation, and palliative care throughout people's life cycle. The WHO recommends that we base health systems on primary health care as a pathway to full coverage because it is the most inclusive, equitable, cost-effective, and effective approach to improve physical and mental health and the social well-being of people. It also enables everyone to access health service close to where they live on a daily basis. In Cuba, the first level of healthcare comprises 451 polyclinics and 10,749 basic health teams, of which 10,551 are at the community level and 130 of them placed in places of learning, 38 in universities, and 40 in workplaces, ensuring that we cover 100% of our population. Today, we have 13,041 doctors assigned to family practices, and with an average coverage of 1.24 doctors per practice. And at the end of the first quarter, case resolution capacity was 90.4% at the first level of healthcare as the point of entry to the national health system. We will continue to fine-tune our family medicine program created in 1984, which was an idea of our commander, Fidel Castro, and we will stand ready to share our experience accumulated in these over 40 years of experience. Thank you.
Thank you. Now I will give the floor to Ghana, followed by Brazil.
Thank you, Chair. Ghana aligns with the statement delivered by Seychelles on behalf of the 47 member states of the African region on agendas item 12.5 and 12.8. Ghana welcomes the report and reaffirms that primary healthcare remains the foundation of universal health coverage, resilient health systems, and health security. We note with concern the persistent underfunding of primary healthcare, which continues to limit equitable access to essential services, particularly in low and middle-income countries. Ghana remains committed to strengthening people-centered primary health care. In this regard, Ghana has launched free primary health care and the Mahama Care initiatives to remove financial barriers and improve access to essential services, especially for vulnerable populations. We strongly agree that strong primary health care systems are critical for addressing communicable and non-communicable diseases, mental health conditions, maternal and child health needs, and emerging health threats through community-based and preventive approaches. Ghana also recognizes the growing impact of international recruitment of health personnel on source countries' health systems. We therefore support strengthening implementation of the WHO Global Code of Practice, improved workforce data systems, ethical recruitment practices, and enhanced international cooperation to protect health workforce sustainability. Ghana reaffirms its commitment to strengthening primary health care as the backbone of universal health coverage and resilient health systems, and look forward to continued WHO support in translating commitments into measurable results. Thank you, Mr. Chair.
Thank you. Now I will give the floor to Brazil, followed by Save the Children Fund.
Thank you, Mr. Chair. Primary health care constitutes the backbone of universal health coverage, global health security, and health equity. Its advancement requires predictable financing, a reinforced health workforce, and the integration of public health functions at the community level. Brazil is translating these objectives into concrete outcomes by deploying strategic investments in facilities and the digital connectivity of our primary care services. We are also systematically strengthening governance frameworks and optimizing resource allocation to advance national coverage targets and ensure equitable access. These domestic efforts reflect an understanding that communicable and non-communicable disease can only be fought through a unified primary care approach, which addresses economic factors and the social and environmental determinants of health. Furthermore, optimized fiscal distribution at the subnational level ensures that vulnerable populations receive continuous care customized to local epidemiological realities and demographic transitions. These goals also depend on the protection and equitable distribution of the health workforce in line with the WHO Global Code of Practice on the international recruitment of health personnel. Current global health workforce mobility poses difficult challenges to the long-term sustainability of health systems within developing countries. It is precisely in view of these challenges that Brazil strongly supports the agreement achieved upon the resolution on the WHO Global Code of Practice as the key instrument to promote ethical recruitment, protect health workers' rights, and ensure the sustainability of health systems. Therefore, Mr. Chair, we are pleased to co-sponsor the resolution on the WHO Global Code of Practice on the international recruitment of health personnel. I thank you.
Thank you. Now I will give the floor to Save the Children Fund, and followed by Zimbabwe.
Thank you, Chair. I'm reading this statement on behalf of Save the Children, Action Against Hunger, the Global Health Council, Center for Reproductive Rights, World Vision International, the International Alliance for Patient Organizations, the Task Force for Global Health, and Sightsavers. The year 2025 marked the steepest annual decline in official development assistance on record. As a result, an additional 5.4 million preventable deaths of children under 5 by 2030 are estimated, as many low-middle-income countries struggle to fund primary healthcare. This moment represents more than a funding gap. It's a stress test for solidarity in the global health architecture. In collaboration with the WHO Civil Society Commission, Sustainable Health Financing Working Group, we received inputs from over 270 civil society organizations from around the world. about the most important actions for member states and WHO to commit at the WHO and ahead of the 2027 UHC high-level meeting. We ask member states to prioritize the following 4 asks. Firstly, to protect life-saving services by prioritizing primary healthcare, realizing UHC, and reinvesting in essential services lost to funding cuts. Secondly, to publicly commit to mobilizing domestic resource mobilization through equitable taxation, improving public financial management with clear national spending targets, whilst supporting debt relief and addressing illicit funding flows. Thirdly, to institutionalize meaningful civil society participation in health financing decision-making at all levels in alignment with the resolution on social participation. And finally, to strengthen transparency and accountability through timely availability of disaggregated health financing data. Thank you.
Thank you. Now I will give the floor to Zimbabwe, followed by Botswana.
Mr. Chair, Zimbabwe aligns itself with the statement delivered by the African region. Zimbabwe reaffirms that primary health care is the cornerstone of our health system. Our national health strategy seeks to continuously revitalize and strengthen primary health care through a people-centered and whole-of-society approach. Community health workers play a key role in this vision, and we are committed to their full integration with the formal health system to ensure equitable access and the continuity of care. We continue to prioritize increased domestic funding for sustained gains. Turning to the WHO Global Code of Practice on the international recruitment of health personnel, Zimbabwe remains deeply concerned by proposals to remove some countries from the WHO Health Workforce Support and Safeguard list. While we are making progress, as reflected by improving UHC index, our health workforce density remains below the WHO threshold, and shortages of nurses, midwives, and specialists continue to affect service delivery, particularly in rural areas. Mr. Chair, Zimbabwe is implementing its national health workforce strategy to 2030 to strengthen and expand the health workforce. However, years of training disruptions and migration have created major gaps that cannot be resolved overnight. We are rebuilding our training pipelines and investing in retention, but these efforts require time and sustained support. Distinguished delegates, Zimbabwe supports ethical recruitment, skills exchange, and mutually beneficial bilateral agreements under the framework. However, premature removal from the protected list risks accelerating workforce losses and undermining progress towards universal health coverage. We therefore respectfully request continued protection and greater international solidarity as we strengthen our health system and workforce resilience. I thank you.
Thank you. Now I will give the floor to Botswana, followed by Thailand.
Thank you, Chair. Botswana endorses the statement delivered by Namibia on behalf of the African member states. We thank the Director General for the report and commend WHO for its leadership in advancing primary health care as the cornerstone for universal health coverage and resilient, equitable, and people-centered health systems. Botswana reaffirms that strengthening primary health care remains essential to achieving health for all and delivering sustainable health outcomes. We note with appreciation the progress reported globally and within the African region, particularly in expanding service coverage, strengthening the health workforce, and advancing quality of care. At the national level, Botswana continues to prioritize primary health care reforms through intentionally allocating more resources to primary health care, strengthening integrated service delivery, improving referral systems, enhancing digital health solutions, and expanding access to prevention, treatment, and long-term management of communicable and non-communicable diseases. Botswana, however, notes persistent challenges, including increasing demand for chronic disease services, resource constraints, climate-related health impacts, and pressures on health workforce retention. As we prepare for the 2027 United Nations High-Level Meeting on Universal Health Coverage, Botswana reaffirms that investment in primary health care remains the most effective pathway towards achieving universal health coverage. I thank you.
Thank you. Now I will give the floor to Thailand, followed by Bulgaria.
Thank you, Chair. Thailand expresses sincere gratitude to core group in draft the restoration on the court. We strong support and please to accept their invitation to co-sponsor it. We also support DPR Korea's statement on behalf of the region in primary healthcare as the foundation of universal coverage, health equity, and resilience system. By 2030, a global shortage of 11 million health workers is projected, including over 100,000 nurses and 30,000 doctors in Thailand. In response, Thailand urged all member states to commit 3 actions. First, workforce retention in underserved areas must be priority to prevent urban migration from weakening PHC capacity and health equity. Second, destination countries should co-invest in professional development in source countries, including PHC training and digital workforce systems. Third, the WHO safeguard list must be protected through ethical recruitment, fair remuneration, and zero tolerance for discrimination against migrant health workers. Finally, Thailand fully supports the resolution on the court to promote a fair, sustainable global health workforce and urge the WHO to enhance.
Thank you. Now I will give the floor to Bulgaria, followed by Malta.
Thank you, Chair. Bulgaria supports the efforts to strengthen primary health care as it plays a key role in managing and coordinating activities related to building skills for healthy lifestyles, prevention, including vaccination, screening and early diagnosis, timely treatment and monitoring of patients' conditions, and rational prescription of medicines. The recent pandemic has shown that primary health care plays a key role in activities related to the prevention of epidemics and other serious threats to public health. To expand and improve access to healthcare services, Bulgaria, in accordance with the principles of solidarity, social justice, and financial protection in a context of limited resources, is working to raise public awareness of the opportunities, challenges, and responsibilities of all stakeholders in the system, expanding the basic package of services, ensuring sufficient financial resources, and guaranteeing financial stability with an optimized service package, developing and retaining high-quality, motivated healthcare personnel, maintaining information systems, conducting policy dialogue to implement action plans, building capacity for activities related to healthcare financing, and promoting the NCD prevention, improving mechanisms and procedures for interaction between institutions and countries. Bulgaria stands ready to collaborate with WHO and its member states, effective exchange of knowledge, experience, and good practices on primary health care. We also co-sponsored the resolution on the Global Code of Practice on international recruitment of personnel. I thank you.
Thank you. Now I will give the floor to Malta, followed by Malaysia.
Thank you, Chair. Malta aligns itself with the statement Romania has delivered on behalf of several European region member states. Professional resource shortages and other evolving global health workforce challenges have led to Malta developing numerous ways of maintaining its high level of health care, as we strive towards sustainable health workforce policies, planning, investments, and practices. We would like to reinforce Malta's commitment towards global health governance priorities, including equity, resilience, and partnership-based approaches, which are well considered within the Code of Practice on the international recruitment of health personnel. Indeed, this aligns with Malta's long-standing support for equitable and sustainable health workforce development, as well as principles of ethical international recruitment. In view of this, Malta, like Bulgaria, would like to be included as a co-sponsor of the resolution on the Code of Practice on the international recruitment of health personnel. Thank you, Chair.
Thank you. Now I will give the floor to Malaysia, followed by Bangladesh.
Thank you, Chair. Malaysia welcomes the report and reaffirms the primary healthcare is the most effective pathway towards universal health coverage. Sustained political commitment, aligned financing and integrations of public health and primary care functions are critical to accelerate PHC-oriented reforms globally. To drive the prioritizations of PHC approach, Malaysia highlights the necessity of comprehensive structural reform, recognizing that our historical, robust, hospital-centric model was becoming unsustainable. We passed our 15-year health white paper in 2023. To truly prioritize PHC, we must shift care upstream. We urge WHO to support member states in strategic governance reforms, such as implementing a purchaser-provider split to effectively integrate public and private resources. To further drive PHC prioritization, WHO roles in supporting finances reform, digital health interoperable and workforce capacity building remains crucial. Member states would benefit from technical support in implementing blended payment models, strengthening primary care workforce competency and integrating essential public health functions. Malaysia also underscores the importance of platforms for structured knowledge exchange, including peer learning, country case studies, and implementation-focused network to share practical lessons. Moving forward, to ensure effective knowledge exchange among countries, Malaysia requires platforms that go beyond high-level policy and focus on practical realities of PHC implementation. We urge WHO to facilitate continuous structured peer-to-peer learning networks that candidly share both success and operational challenges, such as management, digital integration, and financing transition. Thank you, Chair.
Thank you. Now I will give the floor to Bangladesh, followed by Burkina Faso.
Thank you, Mr. Chair. Bangladesh, as a member of the core group, welcomes the report of the Expert Advisory Group on the WHO Global Code of Practice on the international recruitment of health personnel and takes note of the recommendations made by the Expert Advisory Group. We recognize the relevance of the Global Code considering the increasing international mobility of health workers. We would like to draw attention to the fact that the WHO Support and Safeguard List, whose intended purpose was to protect the vulnerable health systems, has over time, due to lack of flexibility in application, has become a barrier to the rights of the health professionals from the countries on the list to pursue dignified and meaningful work abroad, while many of them are remaining unemployed or underemployed, as their own health systems are often unable to fully absorb them. It is also preventing them from gaining experience and professional knowledge by working abroad, which could have contributed to the strengthening of the health systems in their source countries. We would like to underscore that while applying the code, it is essential to take full account of the underlying drivers of health workforce challenges in source countries and to consider each country's capacity to effectively absorb the available health workforce in line with its level of investment, economic conditions, and health system needs. Hence, we support the recommendations of the report for ensuring flexibility in the application of the code. Since the voluntary code was adopted in 2010, the health systems of the source countries have not been able to avail desired benefits and desired investment and proportional benefits from the destination countries. We believe that meaningful and transparent co-investment in source countries and professional knowledge and experience gained through circular migration can ensure real improvement of the health services and health workforce development in countries with vulnerable healthcare systems. I thank you, Mr. Chair.
Thank you. Now I will give the floor to Burkina Faso, followed by China.
Merci. Thank you, Chair. Burkina Faso endorses the statement made by Namibia on behalf of the 47 member states of the Africa region. My delegation would like to thank the Bureau and all the stakeholders for the excellent report on primary health care to ensure equitable access and strengthen primary health care that must be the foundation of the universal health coverage. In Burkina Faso, PHC is at the heart of the National Plan for Health Development and the National Strategy on Community Health. Important progress has been made in the last 2 years in terms of access to PHC, improvement of access to care by building health centers and community facilities, financial accessibility of the population to care by implementing free of charge care policy among pregnant women and children under the age of 5 since 2016, and the launch in 2026 of the Universal Health Coverage Scheme, strengthening human resources through large-scale recruitment of health staff, through the plan 1,000 times 5, setting up clubs for the promotion of health and self-care. To conclude, my delegation takes note of the report and urges the WHO to further strengthen support to middle-income countries in PHC and to form international coalitions to promote primary health care. Thank you.
Thank you. Now I will give the floor to China, followed by Ukraine.
Thank you, Chair. We thank the WHO for the efforts in advancing primary health care and in reviewing the report on WHO Global Code of Practice on the recruitment. China notes the WHO is promoting universal health coverage with the primary health as its core. We hope WHO will further guide member states in strengthening the implementation and increasing national investment and policy support. Continue to summarize the country experiences, develop the operational guidelines, conduct the training activities. At the same time, China notes that the code has played an important role in strengthening consensus among countries, improving data collection, reporting, bilateral agreements. However, the inequality remains, and China believes that WHO should further promote the sharing of data on the international mobility of health personnel among countries, regularly access trend changes in personal mobility and guide member states in forming policies. China stands ready to work with all parties to promote high-quality development of primary health care and support advancements of implementation and improvement of the code. Thank you, Chair.
Thank you. Now I will give the floor to Ukraine, followed by Norway.
Thank you, Mr. Chair. Ukraine takes note of the report and reaffirms that primary health care is the foundation of universal health coverage, resilient health systems, and equitable access to health services. For my country, strong primary health care is not only a foreign priority, but a daily necessity in the context of ongoing war. Primary care remains essential to ensure continuity of services, prevention, early diagnosis, and support for people with chronic diseases, mental health needs, and war-related health conditions. At the same time, the war places an extraordinary burden on trauma care. The speed of evacuation and the quality of medical assistance determine how many lives can be saved and how many people can return to normal life without severe disability. A continuous chain of care is therefore critical, from stabilization during evacuation to specialized treatment and rehabilitation. This requires strong coordination and clear referral pathways between primary care, emergency services, hospitals, and rehabilitation care. Ukraine stresses the importance of sustainable financing for primary health care to ensure equal access to services, especially for vulnerable population and communities affected by the war. We also emphasize the need to strengthen the health and care workforce, including community-based services. Investment in health workers, their training, retention, and safety is essential for long-term health system resilience. In addition, a strong health information system and the use of data are important to measure progress, improve quality of care, and support effective decision-making. Ukraine remains committed to cooperation with WHO and international partners to strengthen primary health care as a core pillar of resilience and recovery. I thank you.
Thank you. Now I will give the floor to Norway, followed by Iceland.
Thank you, Chair. Norway would like to thank the Secretariat for the reports. I will start with agenda item 12.5. Norway remains concerned about the slow global progress towards universal health coverage and supports the continued prioritization of primary health care as the most effective pathway forward. PHC must be integrated, spanning prevention, treatment, and care across communicable and non-communicable diseases, mental health, sexual and reproductive health and rights, with preparedness embedded in everyday care. This shift needs to be more strongly reflected in all our collective efforts, while recognizing that country-specific PHC models require tailored approaches. Turning to agenda item 12.8, the EAG report confirms that the WHO's Global Code of Practice on International Recruitment of Health Personnel remains relevant and effective. Norway supports its recommendations. We thank the Philippines, Germany, Pakistan, and Bangladesh for tabling the resolution and the Secretariat for its support. Norway would like to be included as a co-sponsor to the resolution. Thank you.
Thank you. Now I will give the floor to Iceland, followed by Chile.
Thank you, Chair. Iceland would like to co-sponsor the draft resolution on the WHO Global Code of Practice on the international recruitment of health personnel. International mobility of health workers reflects the growing interdependence of our health systems. At the same time, it raises important questions about fairness, sustainability, and the resilience of health systems, particularly in countries facing workforce shortages. In this context, Iceland welcomes the member state-led process to strengthen the code. We appreciate the constructive discussion in recent weeks and the efforts made to reach a balanced and forward-looking outcome. From our perspective, ethical recruitment must remain central. No country should address its workforce shortages at the expense of another country's health system capacity. At the same time, better data and transparency are essential to understand evolving patterns of mobility and to inform policy decisions. We also see clear value in strengthening mutually beneficial cooperation, including through partnerships that support skills exchange and more balanced outcomes for both source and destination countries. Chair, a sustainable and fairly distributed health workforce is fundamental to preparedness, continuity of care, and global health security. Thank you.
Thank you. Now I will give the floor to Chile, followed by Canada.
Thank you, Chair. Chile is grateful for the report presented, and we welcome the work of the WHO to strengthen primary health care as the foundation of our systems. Our country shares the concern expressed by the member states regarding the persistent lack of investment and financing for primary health care. Our experience shows that if we are to achieve this agenda, we need sustained transformation, which means that we have to improve the case resolution capacity and look at the secondary and tertiary levels and ensure that care is provided throughout the entire life cycle. We believe that digital transformation is a strategic tool to improve access and to reduce waiting lists. Initiatives such as telemedicine and remote support for clinics can help us provide specialized care in the territories and to strengthen diagnostic and primary health care. This does not replace in-person care, but it does expand the scope of primary health care, and we must expand it. We think it's also vital that we know that we shouldn't just respond to clinical needs through PHC, but strengthen community links and social connection, and we must also tackle isolation and social exclusion, which requires care that can make sure we can hear and support people in vulnerable communities. We believe that the exchange of primary healthcare information must be geared towards implementation and resolving concrete problems. We need collaboration between countries, managers, and territorial teams. We support the report and we reaffirm our commitment to equitable, territorial, digitally enabled, and people-centered primary health care to achieve UHC and more resilient health systems. Thank you.
Thank you. Now I will give the floor to Canada, followed by Ecuador.
Thank you, Chair. Canada values WHO's leadership in strengthening the normative function for PHC, including through technical guidance and policy support to member states. We recognize that strong PHC improves health outcomes at lower cost, helps to prevent avoidable illness, and strengthens health system resilience to shocks such as pandemics and climate-related impacts. For Canada, health system strengthening, primary health care, and integrated services must remain central priorities. These are essential to building sustainable health systems and reinforcing global health security. We strongly believe that gender-responsive, community-driven, and people-centered approaches are fundamental to PHC and critical to achieving the SDGs, including universal health coverage. This includes integrating sexual and reproductive health services into primary health care and ensuring equitable access to services. Equity must remain at the center of these efforts. As countries navigate tighter fiscal constraints and evolving health needs, safeguarding and strengthening the health workforce, particularly community-level health workers, will be essential to sustaining progress. Stronger multi-sectoral collaboration and better alignment across the global health ecosystem are also needed to support country leadership and national plans towards UHC. Canada remains committed to supporting reforms that strengthen country ownership and better align investments behind national PHC priorities to deliver measurable improvements in people's lives. Thank you.
Thank you. Now I will give the floor to Ecuador, followed by Austria. Okay, now I will give the floor to Austria, followed by Central African Republic.
Distinguished Chair, dear colleagues, Austria acknowledged the report on primary healthcare. Strengthening primary healthcare is essential to ensure low threshold access to health services, continuity of care, and reduced pressure on hospital capacity. It is important to shift health systems from a primarily disease-oriented approach towards a more preventive and comprehensive model of healthcare. PHC reforms, together with optimizing patient pathways in general, must remain a priority across WHO member states. Austria has established the Austrian Platform for Primary Healthcare as an information and communication hub for the PHC community. The platform supports networking, mentoring, training activities, and exchange between professionals. We consider structured international exchange and peer learning to be valuable for strengthening PHC. The translation of PHC evidence into concrete reforms and practical implementation remains a challenge for many countries. Therefore, bundling experiences, lessons learned, and best practices can provide added value. Also, international support instruments, such as the European Union's Recovery Resilience Facility, RRF, and the Technical Support Instrument, TSI, have significantly contributed to the rollout of multi-professional primary healthcare units in Austria. WHO can further support member states by fostering cross-country cooperation regarding implementation experiences, for instance in financing PHC, optimizing patient pathways, using the potential of telemedicine or AI. Therefore, WHO's continued support through technical guidance, peer-to-peer learning, specific courses, traineeships, and operational frameworks is exceptionally valuable for countries implementing PHC reforms. Thank you.
Thank you. Now I will give the floor to Central African Republic, followed by Chad.
Thank you, Chair. CAR endorses the statement made by the African Group. We congratulate the Director General for the excellent exhaustive report on primary health care. We also share his concern as regards persistent insufficiency of funds allocated to primary health care and insufficient funding in general in this area. We, however, have started structural primary health care reforms since 2019 through 10 areas under the leadership of the President to achieve universal health coverage. There was a decree for pregnant women, breastfeeding women, children under the age of 5, and survivors of gender-based violence. We have been implementing community commitment strategy. We ensure integration of community care for PHC. There's also a decree on organization of primary health care services and universal health coverage. However, the lack of qualified health staff and lack of energy and internet network shortages and insufficiency of funding remain true challenges for the country. We ask WHO to support us in terms of targeted advocacy vis-à-vis ministers, parliamentarians, heads of state, to finance national programs in this area. We ask for the technical support of WHO in order to build capacity, health resources, and digitalization of data. We reassert our support for the adoption of this report. Thank you.
Thank you. Now I will give the floor to Chad, followed by Barbados.
Monsieur le Président.
Chair, the Republic of Chad endorses the discussions on 12.5 and 12.8 and the statement made by Namibia on behalf of the African region. We reaffirm that PHC are the foundation of universal health coverage and a vital pillar of the resilience of health systems. My delegation remains concerned by the lack of funding in a context marked by health, humanitarian, and climate crises. And within this framework, Chad expresses its desire to strengthen domestic health funding while calling for increased support by the international community for inclusive health cooperation in the spirit of solidarity and shared responsibility. Chad highlights the need for lasting sustainable funding in order to strengthen investment in health system, in particular human resources, infrastructure, vital equipment, as well as health information systems and data use in order to bolster performance and resilience of health systems in rural and fragile areas. Chad welcomes the work of the Expert Advisory Group on the WHO Code of Practice. We reassert the importance of its effective implementation. We call for ethical and equitable recruitment. We must strengthen health data, have greater international cooperation to mitigate the impact of migration on health workforce. Under the leadership of President of the Republic, Maréchal Mahamat Idriss Déby Itno, Chad continues its efforts to make a priority of primary health care towards WHC. We call for increased international solidarity based on shared responsibility in order to assist African countries in the long term. Thank you.
Thank you. Now I will give the floor to Barbados, followed by Switzerland.
Thank you so much, Chair. Barbados aligns itself with the statement made by Antigua and Barbuda on the Code of Recruitment of Healthcare Workers. The government of Barbados congratulates the Secretariat on their work in universal health coverage and supports measures to advance universal health coverage and health security, acknowledging that primary health care is the most effective and cost-efficient way to get to universal health coverage. In its effort to achieving universal health coverage, Barbados continues to focus on strengthening primary health care and health systems and the provision of high-quality primary care through an integrated approach and the use of evidence-based practices. Barbados supports multi-sectoral collaboration in keeping with the Lusaka agenda and asks the Secretariat to support countries to develop and implement culturally relevant health sector innovations and to facilitate effective exchange of knowledge and experience among countries on primary health care implementation with consideration to a context-specific adaptation. We thank the Secretariat for its work.
Thank you. Now I will give the floor to Switzerland, followed by Bhutan.
Monsieur le Chair, strengthening and resilience of health systems and primary health care are based above all on health personnel. Swiss reaffirms its commitment to support the WHO Global Code of Practice on the international recruitment of health personnel. The code remains an important tool to respond to the challenges linked to migration of health staff at international level. It is vital to bear in mind that the strength of the code is precisely in its voluntary nature. We welcome the occasional strengthening of the code, but we believe that the resolution under this point goes beyond the recommendations of the expert advisory group and the spirit of the decision adopted by the Executive Board. At the procedural level, we express regret also that a more inclusive process has not been possible on such an important topic. The necessary investment in the sector and the recruitment and working conditions are a shared responsibility for all countries concerned. Switzerland invests significantly in training health staff in order to tackle the shortage of the workforce. Likewise, we are trying to improve the working conditions and offer more possibilities for professional developing in order to increase the retention of staff. We will continue to follow with interest the developments on this topic at international level. Thank you.
Thank you. Now I will give the floor to Bhutan, followed by Turkey.
Thank you, Chair. Primary healthcare remains the cornerstone of resilient health systems and universal health coverage. Globally, we are witnessing renewed momentum to integrate PHC more deeply into health reforms by linking community-based care with hospital services, harnessing digital technologies, and embedding it into pandemic preparedness. However, these hopeful developments are threatened by financing constraints and workforce shortages. Our region continues to navigate a dual burden presented by infectious diseases, threats coupled with growing NCD and mental health challenges, reinforcing the need for a shared responsibility to strengthen primary health care. For Bhutan, PHC has long been the foundation of our health system. Our network of primary health centers and outreach clinics has enabled significant gains in maternal and child health, immunization, and community engagement. However, systemic challenges, namely financing gaps, health workforce attrition, and the need to integrate NCD and mental health services more effectively into primary care remain. Moreover, as a country that has just recently graduated from LDC status, sustaining public health gains amidst declining development assistance is a formidable task. Therefore, Bhutan welcomes the emphasis of this agenda item on integrated service delivery, strategic action on workforce retention, and digital transformation anchored within a more predictable and sustainable financing framework. We further underscore the need for global solidarity so that PHC reforms are equitably financed, digital innovations remain accessible to smaller states, and community engagement continues to be recognized as a core driver of system resilience. Bhutan stands ready to work with member states and WHO to accelerate PHC as the bedrock of UHC and health security. Thank you, Chair.
Thank you. Now I will give the floor to Turkey, followed by Tunisia.
Thank you, Chair. We thank the Secretariat for the reports. Turkey reaffirms that strong PHC is the cornerstone of universal health coverage, resilience, and health security. In line with this vision, Turkey has launched a comprehensive transformation program under the health model, which protects, enhances, and produces, placing PHC at the center of the health system. More than 1,200 primary healthcare facilities, including family health centers and community health centers, are being strengthened to improve accessibility, preventive services, screening, and chronic disease follow-up. Turkey also prioritizes stronger integration between primary, secondary, and tertiary care to ensure timely and people-centered services. We emphasize that sustainable financing, workforce investment, and preventive care remain essential for advancing equitable and resilient health systems. Regarding the agenda item of 12.8, Turkey welcomes the report of the Expert Advisory Group and reiterates its strong support for the WHO Global Code of Practice on the international recruitment of health personnel. Turkey is pleased to inform that it is among the co-sponsors of the resolution and welcomes the continued efforts to strengthen the implementation of the code. Turkey attaches importance to strengthening ethical international recruitment practices, improving health workforce data systems, and enhancing international cooperation in order to mitigate the adverse effects of health worker migration on source countries. We also support the continuation of inclusive member state-led consultations with a view to further strengthening implementation of the code. I thank you.
Thank you. Now I will give the floor to Tunisia, followed by Palestine.
شكرا سيد الرئيس. نتوجه بالشكر لمنظمة الصحة العالمية.
Thank you, Chair. We would like to thank the WHO for drafting this report on primary health care. This report reflects the vital role of WHO in this area. In Tunisia, primary health care are of vital importance. It's a crucial pillar of health policy for 2035. This policy attaches importance to family and community healthcare, which are the foundation of the health system. And they are promoted through multidisciplinary teams jointly between the private and public sectors. To implement this policy, we launched a project to renew primary health care in 2019, following the adoption of the Astana Declaration 2018 and with the support of WHO. This project is based on the following pillars: determining the package of vital care services that must be ensured for all citizens, determining human resources that are needed to provide these services, improving the network of primary health centers, and improving the management and financing of primary health care. As regards the WHO Global Code of Practice on the international recruitment of health personnel, we support the decisions of the Executive Board in this area. We stress the importance of improving the principles and legal frameworks regulating the recruitment of health personnel so that balance can be guaranteed between the countries of origin and the countries of destination. We propose to develop an a code of ethics for health professions. We also encourage member states to ensure adequate training for health personnel. This sound has been cut.
Give the floor to Palestine, followed by Nigeria.
Merci, Monsieur le Président.
Thank you, Chair. In Palestine, primary healthcare system is facing several important challenges affecting the coverage and the accessibility of the territory and occupation. The genocide, war, and the military operations disturb the healthcare service in Palestine, destroying healthcare institutions, damaging infrastructure, limiting thereby access to healthcare and emergency services. Restrictions of movement imposed by the occupying power, Israel, and the extreme violence of the Israeli settlements means that it prevents care being provided. Important shortages in equipment and pharmaceutical products and medications because of this genocide, war, and the blockade imposed by Israel. This has an impact on the capacity of providing comprehensive services to Palestinians. Discontinuity caused by the settlements and the control on the Gaza Strip and other areas make it difficult for Palestinians to access healthcare services. This is particular in A, B, and C areas, and what is more serious is the access to these care services. In the Gaza Strip, there's a lack of nursery staff and medical staff. The conditions are very dangerous. Mental health and the protection of health care in Palestine is very urgent because the psychological impact of the genocide war against Palestinians is terrifying. This war exercises additional pressure on the health system, which is already facing limited resources because of the Israeli blockade. Thank you.
Thank you. Now I will give the floor to Nigeria, followed by Portugal.
Thank you, Chair. Nigeria aligns with the statement delivered on behalf of the African region. On the Global Code of Practice, we commend the Expert Advisory Group for a comprehensive result. Full implementation of the code is now a global health imperative as health worker mobility accelerates and global inequities widen. As one of the countries most affected by large outflows of health personnel, Nigeria underscores that international recruitment must be ethical, transparent, and mutually beneficial. We support the call for proportional benefits and shared responsibility. Destination countries gain significantly from recruiting health workers trained in resource-constrained settings. So, co-investment in education, retention, and health system is essential. We support the explicit inclusion of internationally recruited care workers and stronger accountability against unethical recruitment. We urge the Secretariat to provide technical support for bilateral agreements to strengthen country-level implementation, noting that the list exists to support, not to restrict. On primary health care, Nigeria reaffirms that PHC remains the backbone of our journey to universal health coverage. Under our Health Sector Renewal Investment Initiative and a sector-wide approach, we are making one functional PHC in every ward. For UHC to be attained, vertical programs must use primary health care as their delivery platforms, and countries must receive predictable multi-year support. With stronger global prioritization, the right mix of technical and financial support, and more deliberate knowledge exchange, we can collectively accelerate progress and ensure that people experience health systems that are truly accessible, trusted, and people-centered. I thank you.
Now I give the floor to Portugal, followed by Libya.
Thank you, Chair. Portugal is grateful to the Director General for the report and welcomes the continued focus on primary healthcare and the foundation of universal health coverage and of resilient, equitable, and person-centered health systems. Primary healthcare brings health promotion, prevention, early diagnosis, continuity of care, community engagement, and essential public health functions closer to people and communities. It is also the most effective way to reduce avoidable pressure on hospitals and specialized services. Portugal's experience confirms this. The Portuguese National Health Service is built on universal access and strong primary healthcare. Recent reforms have strengthened multidisciplinary teamwork, closer integration between primary care, hospitals, highly specialized care, and community partners through local health units. Portugal highlights 4 priorities. 1, sustainable financing and financial protection. 2, investment in health and care workforce. 3, reliable data to increase transparency and monitor access, quality, safety, and outcomes. And 4, an integrated care pathway approach that brings essential public health functions into person-centered care delivery. We also support WHO's role in promoting country-led reforms, practical implementation tools, peer learning, and cooperation through the Universal Health Coverage Partnership and the Global Coalition on Primary Health Care. Ahead of the 2027 United Nations High-Level Meeting on Universal Health Coverage, we must move from renewed commitment to measurable implementation. Portugal remains committed to working with WHO and all member states to strengthen primary health care and deliver health for all. Thank you.
Thank you. I will give the floor to Libya, followed by Mexico.
Yes. Honorable Chair, Excellencies, distinguished delegates. Libya welcomes the discussion of primary health care and shares the concern about persistent underfunding and underinvestment. For Libya, this agenda item is especially important. As our country continues rebuilding its health system, primary health care must be the foundation of recovery, resilience, and universal health coverage. It's through strong primary care that we can bring services closer to communities, improve prevention and early diagnosis, reduce pressure on hospitals, and respond better to communicable disease, non-communicable diseases, maternal and child health, post-conflict morbidities, climate change, and emergencies. However, rebuilding primary care requires more than infrastructure. Libya needs support to strengthen financing tools, data systems, workforce planning, referral pathways, and quality measurement. We would also benefit from international experience in strategic purchasing for primary health care, how to direct resources toward priority services, link financing to results, and ensure equitable access for all communities. Libya also emphasizes the need for ethical and well-planned international recruitment of health workers where needed while protecting national workforce development. International cooperation can help fill urgent gaps, transfer skills, support training, and strengthen community-based primary care teams. Digital transformation will also reshape international recruitment. Libya will need not only more health workers, but health workers with new competencies in telemedicine, including robotics, telesurgeries, AI-supported care, digital records, precision medicine, and health data systems. International recruitment should therefore be ethical and strategic. The key message is technology changes international recruitment from importing staff to importing expertise, skills, system, and training capacity. Thanks.
Thank you. I give the floor to Mexico, followed by Morocco.
Gracias.
Thank you, Chair. Mexico has been promoting universal health service and aims Bienestar by organizing our services based on territory and the needs of each community, including community participation, cultural background, and addressing social determinants and prioritizing rural populations, indigenous peoples, and people who have been marginalized. These strategies include the house-to-house program, which delivers early detection and promoting health directly in homes in communities that are hard to access, and the Live Healthy, Live Happy strategy geared towards promoting integrated health in the school populations. Girl children and children are targeted through National Public Health Days, and we continue to see them as key platforms for reaching them with preventive services. We also highlight the importance of primary health care that is inclusive and free from discrimination. We are implementing the care model with inclusive mechanisms that incorporate gender perspective, intersectionality, and cultural background to ensure that our services are accessible to historically excluded groups, including indigenous persons, migrants, people with disabilities, and people on the sex and gender continuum. We would urge member states and the Secretariat to strengthen the mechanisms for exchange of experiences and good practices in PHC, and to ensure that there is sustainable financing that will enable us to strengthen preventive, community-based, and people-centered systems as an indispensable basis for attaining UHC. Thank you.
Thank you. Now I will give the floor to Morocco, followed by Italy.
Monsieur le Président.
Chair, Morocco welcomes the work of WHO on PHC and human resources for health. These are vitally interdependent issues regarding primary health care. The conclusions of the report are of great interest, in particular the central message making PHC an essential foundation of resilient, equitable, person-centered care. This is fully in line with the national priorities of the Kingdom. The guidelines of the EB, in particular in the area of strengthening investment in PHC, strengthening health, human resources development of health information system, promotion of the One Health approach are also supported by Morocco. Morocco also ensures telemedicine to ensure local services. So with regard to 12.8, we were committed to the principles of the WHO Global Code of Practice on the international recruitment of health personnel. Morocco supports the draft resolution, document A795 at 3, and we stress also the need to strengthen national capacity in training, retention, and promotion of health staff, while strengthening international cooperation and respecting ethical rules in recruitment in order to preserve balance and the resilience of health systems of the countries of origin. Thank you.
Thank you. Now I will give the floor to Italy, followed by Comoros.
Thank you, Chair. Italy underscores the pivotal role of primary care as an integrated framework of health and social services, as we are presently undertaking important primary health care reforms financed by the EU Recovery and Resilience Funds. These reforms are the framework for addressing in particular the health needs of a growing and frequently vulnerable aging population. An extensive institutional reform of care for older persons was launched in 2023 with the aim to integrate social and health services. In particular, a legislative decree of 2024 introduces a turning point in the management of frail and dependent older persons in Italy at primary level, placing the integration of social and health care at the center of the system. To implement this integration and to simplify evaluation, the reform introduces two useful innovations: the procedures unification in terms of space, time, and assessment instruments, and the assessment standardization. A unified multidimensional assessment tool therefore defines the specific care needs of older persons based on physical, mental, functional, social, economic, and emotional factors. The aim is to deliver a continuum of health and care services, linking the primary level to long-term care, rehabilitation, and palliative care where needed, and ultimately prevent frailty and dependency. We are pleased that the GDO office Italy hosts in Venice will have a specific attention to healthy aging, therefore look forward to an enhanced collaboration with WHO in this area. Thank you, Chair.
Thank you. Now I will give the floor to Comoros, followed by Ethiopia.
Monsieur le Président, Chair, the Union of the Comoros thanks the Secretariat for the reports, and we fully endorse the decision of the EB on the strategic importance of primary health care in a time when we are facing major challenges in terms of geography and economics. We are making radical changes to our national primary health care policy because it's a central pillar of UHC, equity, and resilience of our health system. We strongly share the concerns regarding sufficient primary health care financing. For small island developing states, these gaps are exacerbated by high structural costs, the fragmentation of interventions, and strong dependence on external assistance. We therefore need sustainable, better aligned, and predictable financing aligned with our national priorities so that we can invest in our health workforce and to help those who need it most, especially in the communities where healthcare is most needed. We also need means to fully monitor our implementation so that we can maximize the impact of our investment. We call for international solidarity at a greater level, especially for SIDS, and make sure that PHC can truly bring about social justice. We remain fully committed to working with WHO and all partners to make sure that we can translate this into tangible results for everyone. Thank you.
Thank you. Now I will give the floor to Ethiopia, followed by Germany.
Thank you, Chair. Ethiopia aligns with the Africa Regional Statement delivered earlier. Since the adoption of the Alma-Ata Declaration in 1978, Ethiopia has made primary health care the cornerstone of its health system. The Health Extension Program has been the primary vehicle for delivering community-based equitable care across the country. Today, approximately 81% of healthcare seekers receive their required services at the primary healthcare level, reflecting the depth of Ethiopia's primary healthcare investment. We welcome the emphasis on PHC-oriented health system reform, country coalition building, and the integration of essential public health functions with primary care. Ethiopia affirms that community-based service delivery, task sharing with trained health workers, and multi-sectoral action on health determinants are indispensable to achieving UHC by 2030. Ethiopia urges the WHO Secretariat and member states to increase sustained financing for primary health care, strengthen WHO technical support for health workforce development, leveraging the WHO Academy, and support country-led PHC systems reform processes through the PHC Global Health Initiative Toolbox and South-to-South knowledge sharing among coalition countries. On agenda item 12.8, Ethiopia welcomes and supports the draft resolution on the WHO Global Code of Practice on the international recruitment of health personnel. We recognize that the code remains a vital global health policy instrument, particularly in the context of increasingly interconnected world and the evolving dynamics of health workforce mobility in the post-COVID era. We wish to highlight that the movement of health workers must be carefully managed to avoid exacerbating inequities and undermining health system resilience, especially in countries with limited workforce capacity. Finally, we support the recommendation to undertake a further assessment of the code's relevance and effectiveness following the 7th round of national reporting to be presented to the 85th WHA. Ethiopia remains committed to the principles of the Code and to working collaboratively with WHO and member states to ensure ethical, equitable, and sustained health work mobility. I thank you.
Thank you. Now I will give the floor to Germany, followed by Australia.
Thank you, Chair. Germany commends the EAG members for their report and the core group for the hard work in finalizing the resolution to update the WHO Code. We thank our fellow co-chairs, Philippines, Pakistan and Bangladesh, for this common effort and all member states for their constructive engagement. We fully support and endorse the resolution. This is an important milestone towards strengthening the implementation of the Code of Practice and safeguarding its integrity. Germany is a strong believer in mutually beneficial partnerships in line with the Code. The global quality and standards of recruitment must be further improved in line with its principles. We support fair and ethical recruitment and advocate for bilateral beneficial recruitment models such as global skills partnerships. But we must continue to strive for further progress to implement the Code. And for this, we need a strong WHO health and care workforce program. Germany therefore calls on WHO to ensure that the workforce program will be fully equipped and integrated in the newly configured academy. We expect that the program also benefits from the budget currently allocated to the academy. Germany believes that the academy can benefit enormously from the normative work of the health and care workforce program in its strategic positioning. We therefore ask WHO to consider reflecting the work of the Health and Care Workforce Programme in the title of the new department of the Academy. Thank you.
Thank you. Now I will give the floor to Australia, followed by Zambia.
Thank you, Chair and distinguished delegates. Primary healthcare is fundamental to achieving universal health coverage. In Australia, our universal healthcare scheme, Medicare, ensures all residents can access a comprehensive range of health and hospital services, often at little or no cost. Our approach is centred on integrated person-focused care, action on social and economic determinants of health, strong national coordination and collaborative reform. While we benefit from a robust primary healthcare system, we are committed to ongoing improvement. We are currently reforming our system to enhance access, expand multidisciplinary care and better integrated care services, ensuring more equitable, patient-centred care for all Australians, particularly our First Nations communities. Australia is also deepening our important partnerships across the Pacific region, supporting resilient primary healthcare systems through workforce development and sustained technical cooperation. On health personnel, I begin by acknowledging the critical role healthcare workers play in providing care. We are all reliant on their expertise and their commitment. Domestically, Australia is continuing to strengthen our workforce supply and distribution, especially for our rural and remote communities. International mobility of health workers is essential to meet global workforce needs, but this must be balanced with effective safeguards to avoid negative impact on source countries. Australia supports the WHO Global Code of Practice, promoting ethical recruitment through improved data and transparency. We also continue to support greater regional collaboration through our partnerships and capability building, utilising important mechanisms like the South Pacific Chief Nursing and Midwifery Officers Alliance. We look forward to continued collaboration with Member States to ensure the Global Code of Practice fulfils its promise and supports a sustainable healthcare workforce everywhere. Thank you.
Thank you. Now I give the floor to Zambia, followed by Mali.
Thank you, Chair. Zambia aligns with the statement from AFRO and commends the Expert Advisory Group for the comprehensive review of the WHO Global Code of Practice to assure ethical recruitment and safeguarding of health systems of developing nations. Zambia endorses a transition from focus on compensation to a model of proportional mutual benefits. For too long, source countries have borne the high cost of educating health professionals only to see them depart for high-income settings with no reciprocal investment in our domestic training institutions. We advocate for the formalization of mechanisms that ensure destination countries contribute tangibly to the sustainability of the health workforce in the countries of origin. Zambia also observes that private players in the international recruitment space remain unregulated. This state of affairs has potential to, 1, undermine human resources planning in source countries, and 2, to exploit exported healthcare workers. Chairperson, Zambia has increased its training output, producing health workers at a rate that currently exceeds capacity for immediate absorption. Zambia argues that our surplus health workers deserve decent employment opportunities. To this end, we urge the WHO to enhance bilateral and multilateral mechanisms that facilitate managed migration. Such frameworks should allow countries with a documented oversupply of specific cadres to engage in ethical labor exploitation. This approach must be structured to ensure that migration is safe, orderly, and beneficial to the individual health worker while remaining sensitive to the long-term stability of the source country's health system. Chairperson, Zambia supports the EAG's recommendations and looks forward to a code that is more responsive to the realities of the modern global health workforce market. I thank you.
Thank you. Now I give the floor to Mali, followed by Tuvalu.
Thank you, Chair. Mali endorses the statement delivered by Namibia on PHC in the African region, and we reaffirm our deep conviction that PHC is to provide care for all Malians. And it is for this reason that improving access has led us to look at family and community medicine and the importance of community staff as the bridge between health services and the communities. We have performed well at the community level, and we have several programs, and they have been awarded for their pioneering role in strengthening primary health care and reaching out to underserved communities through local services. But there are still challenges given the complex and multidimensional crises in our region. Investment in PHC is our best response that is most equitable in addressing these challenges. And we will win the battles if we win the battle of health and address issues such as access to medicines, preventing communicable and non-communicable diseases, and epidemiological responses. We are working to boost community census efforts to make sure that we can provide equitable services and promote innovation in primary health care services. We call on the WHO and our international partners to promote massive and sustainable investment in our basic infrastructure and human resources to make sure that human health is delivered and we are listening to our communities and their needs. Thank you.
Thank you. Now I give the floor to Tuvalu.
Tuvalu aligns itself with the recommendation on strengthening primary health care, recognizing that primary health care remains the foundation of universal health coverage and resilient health systems. For small island developing states such as Tuvalu, revitalizing primary health care is essential to ensuring equitable access to quality health services, particularly for population living in remote and out-island communities. Tuvalu remains committed to providing medical services free of charge throughout the country as part of our national commitment to universal access to health care. We also acknowledge the important contribution of the Community Health Workers Initiative in bridging service delivery gaps, strengthening outreach, and improving communication between communities and the health system. Their role is critical in advancing health promotion, disease prevention, early detection, and continuity of care. Tuvalu wishes to highlight the importance of the WHO Global Code of Practice on the international recruitment of health personnel and support the recommendations proposed in the report. Tuvalu continues to experience significant international migration of health professionals to other parts of the region, creating major challenges in the delivery of essential primary health care services and the sustainability of the national health workforce. In this regard, we reaffirm our call to the World Health Organization and development partners to strengthen sustainable financing, technical support, capacity building, and workforce development initiatives to improve primary healthcare systems and workforce resilience in small island developing states. I thank you, Chair.
Thank you. As several non-state actors in official relations with WHO have requested the floor on this agenda item, according to the privileges conferred by relationship with World Health Organization, I have pleasure in giving the floor to the representative of World Medical Association, followed by International Association for Hospice and Palliative Care, Inc.
The World Medical Association reaffirms that strong primary health care as the entry point and backbone and supported by referral systems and integration with secondary and tertiary care is essential to equitable, resilient, people-centered health systems and universal health coverage. Yet gaps in financing, workforce capacity, and service integration still limit its impact. We urge member states to back commitments with sustained investment, fair working conditions, education, career development, ethical recruitment, and stronger governance and accountability for physicians and other health professionals. Integrated community-based care must remain a priority. Physician engagement in policy design and implementation is vital to quality, continuity, and access to care. The WMA stands ready to support efforts to strengthen primary health care for all. Thank you.
Thank you. Now I will give the floor for International Association for Hospice and Palliative Care, Inc., followed by International Commission on Occupational Health.
Thank you, Chair. Distinguished delegates, training doctors, nurses, and pharmacists to staff local primary care health centers could ease the suffering of patients who otherwise must travel to urban centers to fill prescriptions. Primary palliative care staff can reduce the physical and financial suffering associated with serious medical illness. In some settings, the primary care system still lacks essential palliative care medication. When morphine is unavailable, patients suffer at home. When it is available, it is still unaffordable for those lacking the means to travel to hospital for refills and to seek care. Model list medicines like laxatives, dexamethasone, slow release, and liquid morphine often run out. Primary health centers need palliative care trained pharmacists, nurses, and physicians to relieve patients' suffering. Thank you for your attention.
Thank you. Now I give the floor to International Commission on Occupational Health, followed by International Council on Nurses.
Thank you. Honorable Chair, distinguished delegates, occupational health is fundamental to public health, social justice, sustainable development, and economic resilience. Lack of prevention in workplaces attributes almost 3 million deaths and more than $180 million attributable to work-related diseases and injuries every year. Besides traditional occupational risks, globalization, digitalization, artificial intelligence, and climate change are responsible for increasing physical and mental burdens on workers' health, disproportionately affecting those in vulnerable work groups and high-risk settings. Occupational health is a fundamental component of disease prevention, health equity, and economic security, and should be reaffirmed as a core function of the WHO and reflected in future program planning and governance discussions. The International Commission on Occupational Health calls for renewed leadership of WHO in this area and stands ready to support in providing, protecting, and promoting health and workability through universal health coverage of occupational health services.
Thank you. Now I give the floor to International Council of Nurses.
Thank you, Chair. ICN supports the Expert Advisory Group's recommendation to strengthen the code. The global health workforce is a global public good, and collective worldwide action is needed to protect it. We have an opportunity and responsibility to move decisively towards practical, implementable solutions, and we believe the following is needed. collective and concrete reinvestment mechanism shared by major recruitment countries, directing co-investment towards nurse employment, education and retention, investing in specialist nurses, nursing faculty and leadership development, financing mechanisms such as proportionate reinvestment linked to cost-saved revenue contributions and debt forgiveness, source countries as equal partners in decision-making, convening a global meeting of high recruiting countries. We urge member states to fully respect the code by seizing this opportunity for global health sustainability, security, and health system strengthening. I thank you.
Thank you. Delegates, we have now come to the end of our meeting. Tomorrow, when the committee reconvenes at 9 a.m., we will continue our discussion on this grouping of sub-agenda items. Please consult the daily journal for more details. I would like to remind the delegates that plenary will start this afternoon at 5 p.m. at the Palace. Several official side events are again taking place this evening. Please refer to the official side events calendar on WHA website and WHA app. Have a nice evening. This meeting is now closed. Thank you.
Hello, everyone. Excelencias, distinguida delegación.
Your Excellencies, distinguished delegates, ladies and gentlemen, we're resuming the plenary, considering item 6, which is on the election of the Executive Board. And item 8, which is reports of the main committees. However, I would like to make a quick announcement before we begin. The credentials report, which was approved on Wednesday, I've been informed by the Secretariat that since then credentials have been received from the plurinational state of Bolivia, which had not presented them previously. In accordance with Article 24 of the Rules of Procedure, I have considered the credentials submitted by the plurinational state of Bolivia and have confirmed that they are in accordance with the rules of procedure of the Assembly. And consequently, I would recommend to the Assembly that it accept the plurinational state of Bolivia as having presented valid credentials. Is the Assembly in agreement with this proposal? I do not see any objections, and therefore the credentials of the plurinational state of Bolivia are duly accepted. Item 6. I draw your attention to the list of 10 members contained in document A79/37, drawn up by the General Committee in accordance with Rule 101 of the Rules of Procedure. If elected, these 10 members would provide a balanced distribution of the board as a whole. These members are, in their English alphabetical order, Bhutan, China, Côte d'Ivoire, Georgia, Guinea, Kuwait, Mozambique, South Sudan, Suriname, and the United Kingdom of Great Britain and Northern Ireland. I would like to recall that in accordance with Article 24 of the Constitution and a well-established and accepted practice, distribution of the seats on the Executive Board is made on a regional basis, taking into account the principle of equitable geographical distribution. The current distribution of seats in the board is as follows: Afro 7, AMRO 6, EMRO 5, Euro 8, CRO 3, WPRO 5. Is the Assembly prepared, in accordance with Rule 80 of the Rules of Procedure, to elect these 10 members as proposed? I give the floor to the Russian Federation.
Уважаемый господин председатель,
In October 2025, the European Union, in violation of 2 resolutions of the European Regional Committee, refused Russia its seat in the executive board. Using its numerical advantage in the region, the countries of the EU in Group C of the region did not represent its representative into the executive board and elected the state of Georgia. So that European regional election is in fact following the diktat of Brussels. The list for the European region does not secure a balanced geographical representation of countries in the executive board. In the executive board, there are already 3 members of the EU, 2 candidate countries to become members of the EU, and 2 countries participating in the EU structures. The election of the United Kingdom and Georgia leads to the domination of a single bloc of states. The intentional blocking of those countries that do not meet with the approval of the European Union means that a whole region is being blocked from participation, Central Asia. So, esteemed colleagues, the legal services of the WHO is not making any other procedural choice available to us today other than to affirm the lack of equity in this list of countries. The Russian delegation would distance itself from a decision on adopting this list and would like to state for the records its full objection. I would like to thank the delegations for the huge support which we have received at this assembly, and assure you that Russia will remain a leader in global health, and together with our faithful partners, will resolve the tasks facing us. Thank you.
Cedemos la palabra a Mónaco.
Thank you. Give the floor to Monica.
Je vous remercie, Monsieur le...
Thank you, Chair. Chair, I'm speaking on behalf of 40 member states from the European region: Albania, Germany, Andorra, Austria, Belgium, Bulgaria, Cyprus, Croatia, Denmark, Spain, Estonia, Finland, France, Georgia, Greece, Hungary, Ireland, Iceland, Italy, Latvia, Lithuania, Luxembourg, North Macedonia, Malta, Montenegro, Norway, Netherlands, Poland, Portugal, the Republic of Moldova, the Czech Republic, Romania, the United Kingdom, San Marino, Slovakia, Slovenia, Sweden, Switzerland, Ukraine, and my own country, Monaco. We wish to express our collective position regarding the recent nomination put forward by the Russian Federation for a seat on the EB for 2026-2029. Following successive rounds of voting at the 75th session of the WHO Regional Committee for Europe, member states reached a clear and unified outcome. The European region agreed to nominate Georgia and the United Kingdom as candidates for executive board seats, those seats allocated to our region for 2026-2029. This decision reflects the collective will of the member states of the European region, exercised in line with established rules and practices. The General Committee's recommendations further reconfirm the outcome of that regional process. This regional process is a cornerstone of our shared governance framework. It reflects the principles of fairness, representation, and mutual respect, principles that underpin cooperation within and across regions. The emergence of an additional nomination outside this agreed process risks undermining the integrity and credibility of the regional mechanism. Accepting such a nomination would set a concerning precedent, weakening established procedures that ensure orderly and equitable representation, not only in the European region, but across all WHO regions. We therefore reaffirm our commitment to the outcomes of the European region's deliberations, and we stress the importance of upholding agreed regional processes. Respect for these procedures is essential to maintaining trust among member states and ensuring the effective and predictable functioning of our governing bodies. We call upon all member states then to give due weight to the decision taken by the European region and to the importance of respecting regional autonomy and collectively agreed practices. By doing this, we safeguard not only the integrity of this specific process, but also the broader principles of multilateral cooperation on which the World Health Organization depends. Thank you.
Muchas gracias.
Thank the two delegations of Russia and Monaco. So my question is the Assembly in conformity with Article 80 of the Rules of Procedure to elect these 10 members as proposed? As I see no one wishing to object, I understand that the 10 members have been duly elected.
Esta elección quedará debidamente.
So that election is duly recorded in the records of the Health Assembly, and that concludes our consideration of item 6 of our agenda.
Ahora pasaremos al punto 8, informe.
We'll now move to item 8, reports of the main committees. We'll begin with Committee A and its report in document A7933. With regard to each of the reports, I would ask you to ignore the words draft because they've already been adopted by the committee without modification. So the first report, Committee A, contains a decision entitled Outcome of the Open-Ended Intergovernmental Working Group on the WHO Pandemic Agreement in relation to the drafting and negotiation of the annex described in Article 12 of the WHO Pandemic Agreement. Is the Assembly prepared to adopt this decision? I see no objections. Decision is adopted. We'll now turn to the second report of Committee A in document A79/36, containing two decisions. The first one, entitled Health Emergency in Lebanon. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. The second decision is entitled Health Emergency in Ukraine and Refugee Receiving and Hosting Countries Stemming from the Russian Federation's Aggression. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. We will now turn to the third report of Committee A. That is in document A7939. There are 2 decisions and 3 resolutions. The first decision is entitled End TB Strategy. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. The second decision is entitled Follow-up to the Political Declaration of the 4th High-Level Meeting of the General Assembly on the Prevention and Control of Non-Communicable Diseases and the Promotion of Mental Health and Well-Being. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. The first resolution is entitled Steatotic Liver Disease, a missing piece in the global non-communicable disease response. Is the Assembly prepared to adopt this resolution? I see no objections. The resolution is adopted. The second resolution is entitled Global Action to Advance Health Equity for People with Haemophilia and Other Bleeding Disorders. Is the Assembly prepared to adopt this resolution? I see no objections. The resolution is adopted. The third resolution is entitled Public Health Implications of the Unprovoked Attacks by the Islamic Republic of Iran on civilians and essential civilian infrastructure in Gulf Cooperation Council countries and Jordan. Is the Assembly prepared to adopt this resolution?
Cedo la palabra a Irán.
I give the floor to Iran.
Thank you, Mr. Chairman. I have an editorial amendment and also a question regarding this draft resolution. In this draft resolution, there is a term regarding the Arab Gulf countries. It seems it's the translation of the Duwal al-Khalij al-Arabiya. So all of the words of this phrase should start with capital words. So it should be Arab Gulf countries with a capital C. This is the first one. And the second one, I have a question from the Secretariat about, as this resolution needs to prepare some reports, and it has some financial implications. I have a question from the Secretariat to explain about the financial resources for implementing this resolution. And I have a question whether I have any time after the adoption of the resolution or anything that I want to say I should say now. Thank you.
Después de la adopción,
After the adoption, you will be invited to return and formulate your comments.
¿está dispuesta la Asamblea a adoptar?
Is the Assembly prepared to adopt this resolution?
No veo objeción.
I see no objections. The resolution is adopted.
So shall we maybe now have a reply from...
Reply on this?
Yeah, go ahead. Yeah, let's finish.
Pasemos ahora a los... Perfecto.
I now give the floor to Iran.
Thank you, Chairman. Indeed, I'm still waiting for the response of the Secretariat about the financial resources of this resolution. But, by the way, I want to disassociate my delegation from the adoption of this resolution. Thank you. And to be reflected in the report of the Assembly. Thank you.
Cedo la palabra a la Secretaría.
I give the floor to the Secretariat.
Thank you very much, Iran. We have had no time in the Secretariat to prepare a proper financial, a proper costing for the resolution, but this will follow and is currently being prepared, and we will submit this as soon as possible so that you can see it and it will be accommodated. On the other question, was there another question? I understand it's already been published, the costing. To find the costing, you find it in A79/A/conference/3. No, 2, sorry. Add 1. Financial and administrative implications. It's already on the web. Thank you.
Cedo la palabra a Irán.
Iran, you have the floor.
Thank you for the explanation. So this resolution has some financial implications. It's not without financial impacts. And about what about the editorial amendment of that term for the Arab Gulf countries with the capital C? Thank you.
Thank you for flagging this. This will be flagged to the editorial team. In any case, this is a silent edit that we can make afterwards. It does not affect the adoption. And your other comment, which was prior to me stopping to talk, is does this go on the records? Yes, everything goes on the summary records of the Assembly. Thank you.
Viendo que no hay objeciones,
Seeing there are no objections, the resolution is adopted.
a los informes de la Comisión.
We turn now to the reports of Committee B. With regards to each of the reports, I would request that you ignore. I'm repeating myself because I had given the floor to Iran and I had to reread this. We now move to the reports of Committee B. With each of the reports, I would ask you to overlook draft because they have already been adopted by the committee without any changes. So we'll consider now the first report of Committee B, which can be found in document A7935. The report contains 2 decisions. The first decision is entitled Results Report Programme Budget 24-25 Performance Assessment and Financial Report and Audited Financial Statements for the year ended 31st of December 2025. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. The second decision is entitled Health Conditions in the Occupied Palestinian Territory, including East Jerusalem and in the occupied Syrian Golan. Is the Assembly prepared to adopt this resolution? I see no objections. The decision is adopted. now give the floor to Syria.
شكرا جزيلا السيد الرئيس. طبعا ليس هناك من
Thank you, Chair. Chair, of course, we have no objection whatsoever to the adoption of this decision. However, we do have a number of comments to make. These are comments that are responding to certain observations made by the representatives of the occupying power, observations to which we were not able to respond when they were made, and so we would like to make our response now, and we'd like our response to be recorded in the minutes. We are proud to belong to the land of Golan. It is the land of resilience, the resilience of people who have fought against Israeli occupation for decades. We stand with those people, but we find it very regrettable that people in occupied Golan are today rejecting the sacrifices made by their worthy ancestors and turning away from their sense of belonging to that land. The occupying powers are obliging them to turn away from their identity, to turn away from the identity forged through generations. And we now see that fake news is being spread by AI in the world today, but the truth is that Golan is Syrian territory and people living there are living under the yoke of occupation in a way that flouts any kind of international law. The WHO today does not even have data on the health situation of people living in occupied Golan. And if the representative of the occupying Israeli powers does not know that this is a tragedy, then that is one thing. If he does know, that's even worse. And here I would remind you of what our people say, what people often sing.
Missions of inquiries have been prevented to entering the Golan Heights. I gladly defer him to spend some time reading the continuous DG reports to different assemblies and write down some notes that can refresh his memories. And all these reports have been adopted. Thank you very much.
Muchas gracias, Siria.
Thank you, Syria. We will now consider the second report of Committee B contained in document A7938. That document contains 3 decisions and 3 resolutions. The first decision is entitled Report of the External Auditor. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. The second decision is entitled Proposed Amendments to the Process for the Selection of the External Auditor. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. The third decision is entitled Appointment of Representatives to the WHO Staff Pension Committee of the External Auditor. Is the Assembly prepared to adopt this decision? I see no objections. The decision is adopted. The first resolution is entitled Health Conditions in the Occupied Palestinian Territory, including East Jerusalem. Is the Assembly prepared to adopt said resolution? I see no objections. The resolution is adopted. The second resolution is entitled Status of Collection of Assessed Contributions, including Member States in arrears in the payment of their contributions to an extent that would justify invoking Article 7 of the Constitution. Is the Assembly prepared to adopt this decision? This resolution? I see no objections. The resolution is adopted. The third resolution is entitled Salaries of Staff in Ungraded Positions and of the Director General. Is the Assembly prepared to adopt this resolution? I see no objections. The resolution is adopted. Given that we have concluded today's session, I would now like to give the floor to those delegations who have requested previously to exercise their right of reply, or those who wish to make that request now. I would refer to my previous request that when using the right of reply, delegations keep their contributions as short as possible, bearing in mind that in this meeting, speaking time is limited to 2 minutes. If delegation could fit within that period, within that time frame, I would be very grateful. If delegations request to speak again on the same matter that they've already addressed in their first right of reply, delegations are asked to limit those contributions to a maximum of 30 seconds. And I very much hope that delegations will understand that such requests are being made in the interests of all to ensure the smooth working of our discussions. I now give the floor to Japan.
Thank you, Mr. President. My delegation exercised the right of reply in response to the statement made by the delegation of China. There should be no geographical vacuum in addressing global health challenges. In order to address these challenges effectively, it is essential to share information and knowledge among all countries and regions in the world, including Taiwan, in a free, transparent, and timely manner. It is from this perspective that we referred to Taiwan in our statement at the plenary. The government of Japan's basic position on Taiwan is articulated in the 1972 Japan-China Joint Communique. I thank you, Mr. President.
Ahora doy la palabra.
I now give the floor to China.
Mr. President, China draws your attention to the fact that Japan's right of reply remarks are entirely irrelevant to today's deliberations and are filled with reckless and fallacious assertions which China firmly rejects. Japan occupied Taiwan and imposed 50 years of colonial rule on Taiwan, bearing irrefutable and grave historical guilt over the Taiwan question. It has no standing whatsoever to pontificate on this issue, let alone stir up provocations and meddle in China's internal affairs by misusing the WHA platform. For 10 consecutive years, the WHA has rejected Taiwan-related proposals, fully demonstrating that the international community's adherence to the One China principle is unassailable and unshakable. The participation of China's Taiwan region in WHO activities must be governed by the One China principle, a fundamental tenet enshrined in UN General Assembly Resolution 2758 and WHA Resolution 25.1. Without the consent of the central government, China's Taiwan region has no basis, justification, or right to take part in the WHA. The Chinese central government attaches great importance to the health and well-being of Taiwan compatriots and has put in place robust arrangements for Taiwan's engagement in global health affairs under the One China principle. Medical and health experts from Taiwan may attend relevant WHO technical meetings, and information sharing mechanisms between Taiwan and the WHO as well as other countries remain smooth and well established. The so-called gap in the global epidemic prevention system is nothing but a brazen political lie. We once again admonish the relevant countries to any acts to against the One China principle will end in failure. The One China principle is unshakable.
Thank you very much. To remain on the same matter, I will give the floor to Japan, and if it is on the same matter, please keep to the 30-second speaking limit.
Thank you, Mr. President. As Japan's position on Taiwan has already been articulated, I will not repeat it here. Regarding historical issues, I will refrain from refuting China's unsubstantiated claims regarding World War II. Japan's consistent contributions to international peace and stability are widely recognized. Japan will continue such contributions as a responsible member of the international community. I thank you, Mr. President.
Cedo la palabra.
I now give the floor to China, recalling the 30-second time limit.
Japan continues to peddle erroneous remarks on Taiwan in violation of the One China principle affirmed by the UNGA Resolution 2758 and WHO Resolution 25.1. And it is contrary to the spirit of the bilateral communique on the establishment of diplomatic relations between the two sides. Its aim is to politicize health issues and use the Taiwan question to contain China. We urge Japan to abide by the decisions of the WHO, cease political maneuvering within the Assembly, and demonstrate through concrete actions its commitment to the One China principle. I thank you, President.
Cedo la palabra.
I give the floor to Japan again.
Thank you, Mr. President. It is regrettable that the delegation of China has repeatedly directed criticism toward my country. Japan's position has already been clearly stated, and its details will not be repeated. However, we reiterated that the Chinese delegation made reference to UNGA Resolution 2758. However, it merely decided to recognize the PRC as representing China at the UN. Thank you.
Cedo la palabra.
I give the floor to China, reminding you of the 30-second limit.
President, you already introduced rules on the exercise of right of reply. Every country, when exercising right of reply, has two chances. However, Japan violates this principle in exercising the third time of rights of reply to peddle erroneous remarks on Taiwan continuously. This fully demonstrates the fact that Japan has never adhered to the spirit of any contract. We hope that the third right of reply exercised by Japan
The point of order says we have two requests for each try, so we have concluded. I will give the floor to the legal counsel. Daré la palabra al asesor.
I give the floor to legal counsel.
Thank you very much. Just to reiterate the practice that was outlined by the chair at the beginning, where he explained very clearly that there are two goes for each side in terms of a right of reply. So as he said, the point of order raised by China was correct, and Japan should not have been given a third opportunity to speak on the same matter by way of a right of reply. I think the ruling of the chair was that that's correct, and he was not going to give the floor further to Japan or China on this matter, since both have now had two goes at rights of reply.
China, ¿eso es un punto de orden?
China, is it a point of order?
Cedo la palabra a China.
I give the floor to China.
Now that the legal counsel has made his clarification that Japan has no right to exercise the third right of reply, then I request the President to make a ruling to not include the third right of reply exercised by Japan in the meeting record. Thank you.
Anotado y
Thank you. Noted and accepted. It will not be included in the meeting record.
tenía anteriormente a Kuwait.
I had Kuwait previously on the list of speakers. Would Kuwait wish to take the floor?
Cedo la palabra a Kuwait.
I give the floor to Kuwait.
No, thank you, Mr. Chair. Withdraw.
Muchas gracias.
Thank you. Then that concludes our work for today. Tomorrow, we will resume on Saturday, the 23rd of May.
Repito, la sesión plenaria.
The plenary will resume tomorrow, Saturday, 23rd of May, after the committees have finished their work. Thank you. We stand adjourned.